for people living with diabetes. So with that, our first session is yet to kickstart, and I'm going to request Dr. Vipul Chavda sir, who's our chair for the first session, to introduce our first speaker, Dr. Meenal Mohit ma'am. RX team, I will request you to please, screen her CV onto the screen right now. And I also have the pleasure of having all our organizing team, Dr. Rick and Dr. Rutul, our faculties, Dr. Rajneet sir, Dr. Bhavtarini ma'am, join us on time. Over to you, Vipul sir.
So, thank you so much, Dr. Dhruvi, for kickstart the Practical Diabesity 2026 first day virtual session. I'm happy to welcome you all with the blessing of God, our parents, our friends, and our mentors. We are here to start this academic extravaganza. So, to start with one of the extraordinary speaker of our country, let me invite Dr. Meenal Mohit ma'am, MBBS, MD, FD, FPA, FRCP, FICP, RSSDI Fellow, Diabetes India Fellow, many fellowships from UK, US. She is mentor for many doctors, including me, in this country. So let's start learning from Madam. And it's a best thing to start with you, ma'am.
Thank you, Vipul. Thank you so much. First of all, anyways, I'm honored to be here, Dhruvi and Vipul, thinking of me, remembering me, and making me a part of the event.
Just a second, Vansi sir is here. Just, sir, please.
Meenal is always remembered, in any meeting of Ahmedabad or Gujarat.
Thank
we
you so much,
consider
sir.
you
Honored.
half Gujarati.
Sir, please take me as full Gujarati.
Full Gujarati. You are an eminent person in
Rajasthan
India.
is disowning me, so it's okay. Rajneesh sir is here. He will
It's
say.
great. So, best wishes
so
to
much,
Vipul and Dhruvi, and for this
Thank you,
practical
sir.
diabesity to everyone. I'm sure it will be extraordinary scientific meeting, which we will be enjoying in next 2 days. And thank you, Meenal, for joining. And let us have first talk from Dr. Meenal. We may have discussion. I'll be there in between. I may or I may not, but I will be there most of the time. Thank you.
Thank you so much.
You are omnipresent. We know that you will be there, and Meenal ma'am is our favorite.
Thank you.
So,
Meenal is our
kind
favorite,
words.
no doubt.
Very, very kind words from all of you, and I'm so blessed that I'm so much loved and blessed by you all. I'm so nice of you, so kind of you. I'm really not finding words actually. So kindly allow me to share my slides.
Yes, ma'am.
Okay. So here we are talking, first of all, thank you, Vipul, thank you, Dhruvi, and many congratulations for making this event happen here. This is like practical diabetology, something we are looking forward to always every year because there are many important topics that are being discussed. And kindly just keep me updated if my slides are visible.
Yes, ma'am. They are in the screen share mode. Yes, ma'am.
Correct. So we will be talking, as you can see here, we are talking about the global recommendations and their application in the local perspectives, right? Talking about type 2 diabetes, and the very small and a very crux or the crispy message of the entire content is how we have evolved. We as human beings, we are the only people, I believe, who have been blessed with brains and intelligence, intellect, and we keep growing, we keep evolving as a person and in science also. So how much we have evolved, that is the idea for today. So we are talking of evolution of the diabetes management to begin. So the very first thing, the agenda will flow like evolution of the diabetes management. So if you look at the burden of diabetes, you will find that we are like almost no part of the country is without diabetes. And because we are sitting here, though I come from Rajasthan, I'll tend to talk about Rajasthan data, but we are sitting very close to Gujarat, and Gujarat burden is a slightly higher than the Rajasthan burden. So if you talk of the Rajasthan burden, we are presently around 5 to 7.5%, and the Gujarat burden is around 7.5 to 10%. Now, if you talk about the government responsibility, so government talked about the non-communicable diseases way back. So way back in 2010, the government started thinking about launching the non-communicable disease programs. So even in 2010, when the NCDs were planned and the pie chart of the NCDs was designed, diabetes still led the country. So the total burden of diabetes in 2010 was around 65 million. So one of the largest domain of the NCDs was diabetes. If you look at the diagnostic modality, way back then, we were taking into consideration fasting plasma glucose, which was more than 126. So the cutoff remains the same. We are still taking fasting plasma glucose more than 126 as diagnostic of type 2 diabetes. Then we took random plasma glucose above 200. This is also same. We still consider RPG above 200 as diabetes. 2-hour post glucose load was taken as 200, and again this also stands true. But can you see something is missing in this chart? Way back in 2009, there was no place for HbA1c as a diagnostic modality. We were doing HbA1c, but we were not considering it as diagnostic. So from there, 2009, we came to 2024. So in the ADA guideline 2024, HbA1c found its place. Finally, HbA1c was accepted, recognized, and placed as the number one diagnostic modality here, that HbA1c more than 6.5 is diagnostic of type 2 diabetes. Other cutoffs remained, they were not taken off, but along with a fasting plasma glucose of 126, postprandial plasma glucose of 200, and a random plasma glucose of 200, we also now take into consideration HbA1c, which is above 6.5, is diagnostic of type 2 diabetes. Then comes the understanding of pathophysiology. So when we started talking of diabetes, like when I did my PG and I was studying diabetes, I only knew the triumvirate concept. Pancreas will not make insulin, liver will increase its hepatic glucose production, and muscle will not utilize glucose because there is no insulin. So that was my basic understanding of diabetes, the triumvirate concept. Pancreas, liver, and muscle, they were the three players. Pancreas not making insulin, liver making more glucose, and muscle not using this glucose. So the culmination or the crux or everything comes down to a state of hyperglycemia. So that was my understanding of pathophysiology of diabetes. The three major defects led to hyperglycemia. Then we evolved. To the DeFronzo concept. The DeFronzo gave us the ominous octet. So then we evolved. Then we started accepting diabetes as a bihormonal disease. So it is not only the deficiency of insulin, it is also increased glucagon. So the bihormonal disease. Then we understood something called the glucose load given orally versus glucose load given IV. So the incretin effect came into play. Then adipose tissue was accepted as the largest endocrine gland or the endocrine organ, and we started understanding about the adipokines and the lipolysis, which also plays a role in hyperglycemia. Then came the kidney. We started understanding that yes, the glucose which is filtered out of the Bowman's capsule, if that glucose is not reabsorbed, we can also lead to hyperglycemia or we can prevent it. Then came, of course, the muscle stood there. Brain also had a very important role. We had a understanding that hypothalamus has a role and bromocriptine came into play. So from the ominous octet, we started growing and we moved to the dirty dozens or the flirtatious 15 or the sweet 16. So now our pathophysiological understanding of T2DM has moved up to 16 or maybe 17 factors now. So this is how we evolved in terms of diabetes understanding. What has been our evolution in terms of the treatment goals? So in terms of treatment goals, yes, we have evolved there also. Initially, our entire focus was to manage the blood glucose. So we were only focusing on certain data, certain figures. Fasting blood glucose, less than 110. Post-meal, less than 180. Too very tight, make it less than 140. GDMs, keep it 90 or 120. So we were only talking in terms of figures, numbers, and our idea was only focusing on blood glucose. So the approach was glucose centric. There also we evolved and we started understanding that it is a 4-pillar approach. We are not talking only of the blood glucose. It is important. I'm not saying we are missing it out. Blood glucose number still is important. But how do we achieve that target? So end justifies the means. No, we have given up that concept. Now means justify that are we reaching our end with the right means? So we are still targeting blood glucose, but at the same time taking care of weight. We should not allow our patients to gain weight because of our treatment or our therapies. At the same time, we are trying to prevent the organ damage. So organ protection has become the entire ultimate destination for the diabetes management. So where the most important organ remains still the heart, but not only heart, now we are also focusing on liver, that is mast cell we are trying to prevent. Kidney is always very, very important. So the diabetic nephropathy, retinopathy, neuropathy, brain strokes, peripheral vascular diseases, and also liver. So organ protection has now come to be the center of the stage. So this is how we have evolved in terms of our understanding. Now, this is the data, this is the lesson we learned from our very, very legendary trial, the UKPDS, that 1% drop of HbA1c is translated into a significant micro as well as macrovascular complication reduction. But this lesson we are still remembering, we are still taking this lesson ahead. Now we are also understanding that few percent weight loss along with HbA1c loss can be multiplied into our benefits in terms of our benefits. So weight loss as low as 5% will give us protection against blood pressure and hyperglycemia. Weight loss up to 10% can also prevent us from NAFLD and our young girls against PCOS, or now we call it PMOS. Weight loss up to 15% can be preventive against cardiovascular diseases, against stress, NASH, OSAs, our knee arthritis, GERDs. And of course, the maximum that if we can go up to a weight loss of 15% or more, we can even go for remission of diabetes, prevent the mortalities, and the most important, we can even treat our HFpEF, which is the most difficult to treat complication of diabetes. So, diabetes disease progression. Again, our treatment approach has changed. We were initially treating to fail. The idea was treat to fail. Treat, fail, treat, fail. So that was how we were treating. Diet and exercise, failed, start metformin, failed, add another agent, failed, add a third agent. Then again failed, add insulin. From here, we again moved to our modern approach of management also. Now we are treating in anticipation. We don't treat to fail. We treat, we try to run and in advance of the disease. Before disease can progress, we progress our treatment. So this is how we have evolved in terms of our diabetes management also. Now, what is the modern approach to diabetes management? Here, this is very, very interesting. Our goal now is organ protection. So that is cardio, renal, metabolic, that is CKM we are targeting. So cardiorenal risk reduction. So if the patient has a very high risk of atherosclerotic cardiovascular disease, now we think in terms of monotherapies or the starting therapy as GLP-1RA. Now this is the latest edition of the ADA 2026 or ACE 2026 guidelines, which say move from metformin, do not do away with metformin. That is not the message. The message is even these molecules can have the first position and can be used as monotherapy if needed. So justify, individualize, and if needed, if the patient is having a cardiorenal or metabolic complication, high risk of atherosclerotic cardiovascular diseases, you can choose GLP-1RA as your first molecule of choice, or you can choose SGLT2I as a monotherapy or the first molecule of your choice. If there is additionally heart failure present, then definitely SGLT2I takes precedence over GLP-1RA. If there is CKD present, again SGLT2I up to a eGFR of 20 can be gone. GLP-1RA or SGLT2I, in case one or the other is not tolerated, you can always switch from one to the other, or you can even add one to the other. So, on the other hand, yes, still, if achievement and maintenance of glycemia and weight is your goal, there is no risk of atherosclerotic cardiovascular diseases, then choose your molecules with efficacy towards weight management. So GLP-1RA definitely has a very high efficacy towards weight management. If the blood glucose is very high, you can combine insulin with a GLP-1RA. If weight management is your goal, then GLP-1RA can be chosen as your monotherapy or as the first line of your management, drug management. Coming to the last part of the agenda, that is what are the guidelines telling us? So this is our common understanding, of course, but what are the guidelines telling us? Guidelines have also evolved. So if you look at the area guidelines on the weight and the glycemic management, you will find that these molecules have been accepted, the glycemic management as well as the glycemic and weight management. So these molecules have been accepted having a very high potency. So you can choose either of the GLP-1 RAs. It can be dulaglutide, semaglutide, or the dual agonists, that is the tirzepatide. You can even combine any oral therapy with the GLP-1 RAs. For glycemic management, again, the efficacy for weight loss of these molecules have been found to be very high. So you can choose GLP-1 RAs, GIP, the dual agonist, the tirzepatide, or you can even think of dulaglutide, and at least liraglutide also is in pipeline. So all these molecules, the guidelines have also shifted, and you can choose these molecules to begin with. The European guidelines of cardiology. So we are not the only ones. It's not only the diabetes target. Choose either a DPP-4 inhibitor or a GLP-1 RA, SGLT2I. You can even choose thiazolidinediones. But again, if HbA1c is still high, you can choose the third molecule as SGLT2I or anything. Sulfonylureas come down very, very low because we are avoiding, consider the addition of sulfonylurea is here. So when the first molecule, second molecule, third molecule, because this is the molecule we are avoiding because of the weight gain and hypoglycemias. On the other hand, if the patient has a very high risk of atherosclerotic cardiovascular disease, then SGLT2I or GLP-1 RA monotherapy can be taken as your first line drug. So this is coming from the ESC guidelines. If HbA1c is above target, you can add metformin here. If HbA1c is still above target, you can choose any other molecule which is still not added. Maybe you can combine the GLP-1 RA with SGLT2I with metformin, or maybe you can add some basal insulin, or maybe you can add a sulfonylurea. And if heart failure is not present, even thiazolidinediones you can choose. So this is how the guidelines have also evolved. So agents like GLP-1 RA, they are now recommended in the drug-naive patients also with atherosclerotic cardiovascular diseases with a very high risk, severe risk as first-line therapy for the management of hyperglycemia. We can go to the extent of saying that GLP-1 RAs and SGLT2Is are even being used as protective agents for atherosclerotic cardiovascular diseases in the non-diabetic patient or even in the pre-diabetic patients also. So the key takeaways for the session: 1 in every 10 Indian has diabetes. 1 in every 5 Indian has obesity, maybe overweight you can consider. So diabetes and related complications, they appear in Indians before time. So we are the thin fat Indians. The YY paradox always stand. We can't forget it. So we are the thin fat Indians. So guidelines recommend targeting the 4 pillars now, not only blood glucose, but we are focusing on glucose, weight, cardiovascular protection, and overall organ protection. So we are talking of the 4 pillars now. Timely individualized treatment targeting multiple metabolic parameters is needed. So we need a very timely intervention before the train leaves the station or before the flight takes off. We should be taking our seats. GLP-1 RAs can be used as our first-line therapies. Even the dual agonists can be used as our first-line therapies. So with that, thank you so much once again, Dhruvi and Vipul. Thank you for having me here. I'll stop sharing my slides. So if you have anything to discuss, we can discuss.
Thank you so much, ma'am. It is indeed very intriguing as to how we started with triumvirate approach, and now we have 16, 17, 18 different pathophysiologies everywhere where we want to target. Ma'am, tell us something very practical. If you have one take-home message, for all of us listening, we have almost 50 delegates also. This is a faculty forum, and we have 50 delegates also who've joined us right now. Tell us something that could be practically executed, from the entire guidelines today in my OPD.
Yes, so the only take-home message is keep your vision, mind, horizon very, very broad. Don't go with conventional approaches. Time is changing, molecules are changing, we are changing, and the guidelines are changing. So nobody will literally put a pen on your prescription saying, why have you have a bias towards a GLP-1 RA? Because the noise level is very high. And if you prescribe a GLP-1 RA, you are probably thinking that there's a bias. But it is a scientific bias, if it is at all. It is a very, very scientific bias. And yes, I would prefer to give my patient the best molecule which is available to the market, for the market. And if it is GLP-1 RA which is needed, then please go for it. Don't shy away from the molecules. Keep your mind and vision very broad while treating your patients.
So thank you so much, ma'am. Thank you so much.
Thank you.
It is an honor to have you with us, and really a very auspicious start to our inaugural session. Thank you so much.
Thank you so much, Rohit.
Thank you, ma'am. With that, I again request Vipul Chawda sir to introduce our next speaker, the Samrat of the Samrats, and he's not here, but he is here. That's what he said. That मैं हूँ पर मैं नहीं हूँ wala zone. So all over to you, to Dr. Vipul Chawda sir, to introduce the Samrat.
So good afternoon all once again. The next talk is by Dr. Bansi Sabu sir, who is a mentor of mentors, and he taught how to be diabetologist, how the diabetology community is grown over last 2 decades in India. He saw the temperament of how non-communicable disease should be treated. The physicians who were very busy in treating the communicable disease in last 2 decades, India has evolved from communicable to non-communicable, but the doctor fraternity need to be evolved, and Dr. Bansi Sabu is a flag holder. He's a teacher, mentor for everybody who has interest in not only diabetes, not only obesity, but all the non-communicable disease. So Dr. Dhruvi, I would like to tell you, if sir is not here, if we have his recorded call or he is joining.
Sir is here. He's still logged in. Sir is current chair, Southeast Asia International Diabetes Federation. He's the secretary for Diabetes India. He's the past president for RSSDI. He is also in the leadership for Diabetes Asia Study Group, and he's also with the EASD. He's also now been invited as one of the speakers for ADA, and soon probably on the ADA panel as well. With that, I'll request the RX team to start his recorded lecture. Banshi sir has had an interest always in talking about diabesity and women health. So his talk on the use of GLP-1 for diabesity and in particular for infertility and PCOS is going to, enlighten our entire audience today.
Thank you, Dr. Vipul and Dr. Dhruvi, for giving me this wonderful opportunity to talk on a very important topic, semaglutide role in PCOS and infertility. I know in this practical diabesity course of 2 days, there will be a lot of talks related to obesity and on semaglutide. But what I'm going to talk in next 20-25 minutes, the role of semaglutide in PCOS and infertility. I'll be talking the impact of obesity in women health, the menstrual irregularities, PCOS, which is now new named, fertility, management, and guidelines, and then practical know-how for clinician. But the initial part, I will take a little faster, because I'm sure we all know about the semaglutide, but then later on, we'll be talking more about the management and guidelines. Globally, if you see the women obesity rate are increasing from 2010 to 2030 across the world, in each region of the world. And if you see, 1 in 5 women will be living with obesity in 2030. Now, this is for all adult women. Now, if you go above the age of 30, 40, or 50, now this incidence increases. This is current situation in 2020, 658 million, which is going to increase in 2030 by 882 million. So 1 in 5 women will be the person with obesity in female population. The gender difference in body fat percentage and fat distribution, there is a, compared to men, they have more brown adipose tissue, they have decreased intra-abdominal fat tissue, and they have enlarged peripheral fat. Now this could be somehow beneficial for females for less cardiovascular risk, but still overall obesity is higher. The gender differences in fat distribution and cardiometabolic risk are due to enhanced postprandial meal-derived free fatty acid and preferential post-absorptive direct free fatty acid uptake by SAT in women than in men. Now, impact of obesity in women health. I'm sure all we know that these are the different issues of obesity in person, whether it's a male or female. But there are a few very important issues, and one is infertility in female, which is higher in obese females, which is subfertility, PCOS, pregnancy complication, menopause, and menstrual irregularities. The cancer risk is slightly higher in female with obesity, and urinary incontinence is higher in persons with obesity in female population. There will be a lot of beneficial effect of body fat reduction in women, like we get the benefit in male and female both, but definitely it will be more in female for lowering the risk of breast cancer, improving fertility, improving ovulation, improving stress incontinence, lower risk of dysmenorrhea, and lower risk of certain gynecological cancer. So that's a specific benefits will be more in females in particularly these conditions. The probability of menstrual irregularities increase with person with obesity, and as the BMI increases, as waist circumference increases, as waist hip ratio increases, the menstrual irregularity probability increases higher. The pathophysiology of obesity and menstrual irregularity is because of insulin resistance, and that insulin resistance is responsible for hyperandrogenemia. This increased level of estrogen with increases free testosterone level is responsible that a testosterone free level and the level of estrogen that is responsible for menstrual irregulation. There are benefits of weight loss in menstrual irregularities. Weight loss of 5 to 10% improve ovulation frequency. It improves a lot of endocrine parameters like decreasing free testosterone level, LH, and insulin level. Even if ideal weight is not reached, even weight loss of 10% will restoring normal hormonal levels, and that leads to improvement in ovulation, menstrual cycle, and it enhances fertility. The polycystic ovarian syndrome is now becoming PMOS, which is polyendocrine ovarian disease. It is an heterogeneous condition characterized by oligoovulation and anovulation. It is hyperandrogenism, menstrual irregularities, and subfertility. 37 to 75% of women with PCOS have obesity, with 50 to 60% of central obesity. But obesity is not a criteria for diagnosing PCOS. We know that PCOS have a very peculiar criteria of it, but all obese are not going to have PCOS. There are lean PCOS also, but prevalence of PCOS is definitely increases with increasing obesity risk. The hyperandrogenism is a defining feature of PCOS, and that is again because of hyperinsulinemia. Obesity is one of the important reasons for them, but definitely there are lean PCOS with hyperandrogenism too. There is a definite role of insulin resistance and hyperandrogenism in PCOS, which results in infertility and fertility. Subfertility in women with PCOS, there is an increased risk of anovulation, and this anovulation risk is very high when BMI goes more than 32. There are multiple papers which has been published, and all of them had shown as increasing the risk of obesity, there is increased risk of PCOS. Weight loss definitely improves the clinical features and long-term metabolic health in women with PCOS. It's a insulin level gets decreased, decreasing insulin resistance. There is a decreased androgen level, and all other factors which are responsible for anovulation and menstrual irregularity, all of them improve. The weight management in PCOS with women with overweight, the reduction in over volume will be there. Ovarian volume, improvement in regular cycle, improvement in spontaneous ovulation, improvement in pregnancy, improvement in live birth, reduction in number of microfollicles. All these factors will be improved in percentage. The semaglutide in PCOS, these two important studies been done where the dose was given in one of the paper was only 0.5 milligram weekly, while other they had increased up to 1 milligram weekly, and both these papers had shown a significant improvement in menstrual cycle and infertility. Obesity is closely associated with reduced fertility in women. Again, the same factors which are there in PCOS, but there are a few more hormonal changes are responsible for reduced fertility in women. So they are the reason for them to have hyperinsulinemia and infertility. Obesity and infertility, as the BMI goes more than 30%, decrease in natural conception by 4 per kg. The mechanism or role of leptin in regulation of the reproductive axis, role of other gut and adipose tissue hormone in reproductive axis, and role of immune cells in adipocytes, inciting a systemic inflammatory response, which are responsible for decreasing fertility rates. The prevalence of infertility in women with obesity, as obesity increases, this risk is increasing higher and higher. Maternal BMI is also responsible for their spontaneous pregnancy. So as BMI increases, and you can see with someone who is becoming morbidly obese, this risk of getting pregnant is 43% lower compared to normal weight. Effect of obesity on female infertility in all modes of conception, whether it's a natural, whether it's a ovulation induction or assisted reproductive technology. And that's the reason sometimes the infertility specialists, they want to refer the patient only for the weight management. And once the 10% of the weight get reduced, the increasing chances of pregnancy, and then whether you are ovulation induction you are doing or you are giving them a IVF or any other therapy, the chances of pregnancy increases significantly. The effect of obesity is on oocyte and embryo quality also, who are going for in vitro fertilization. So it's not the ovum will be quality of ovum will be also poor in patients who are having infertility issues. The risk associated is not just with the maternal, even at the birth and offspring also have the maternal obesity issues. So a person with a female who is having pregnancy and who is obese, the more risk of all gestational issues, including gestational diabetes, will be higher. But newborn will also going to have preterm birth, increase in risk of cesarean birth, prolonged delivery, and offspring throughout the lifetime, also going to have increasing risk of obesity, and that is continue to be there lifelong. The risk of adverse outcome associated with obesity during pregnancy, you can see from miscarriage to postpartum depression, everything is increased with a person with obesity during pregnancy. There are a lot of benefits of weight loss in fertility outcome, and this is one paper, rather 6 randomized controlled trial that has shown women who received combination of reduced diet and exercise were having 1.5 times more likely to get pregnant than those who underwent standard care. Impact of weight loss on fertility, whether it's a conception rate, live birth rate, spontaneous conception rate, time to conception, all of them have improvement by decreasing weight loss of by around 10%. Meaningful weight loss definitely improve pregnancy and live birth rate patients. There are pharmacological options which were available in India before even semaglutide came, like liraglutide and orlistat. But liraglutide was never available in India for 3 milligram. We were using 1.8. And later on now, semaglutide, which is available, which you can give more than 1 milligram for weight reduction, was 1.7 and 2.4. So it's other than adjusting to diet and physical activity, they had shown benefit for that. The role of GLP-1 in appetite regulation, it is secreted from 2 sites. We all know about it, L cells and specialized cell in nucleus tractus solitarius of membrane, which is GLP has wide variety of physiological effect from pancreas, brain, gut, and heart. It reduces energy intake, and which is a major way of mechanism how it decreases hunger and increasing feeling of satiety, by which it decreases obesity. GLP have multiple and multifactorial effect, which is it pancreas, liver, lipotoxicity, brain, pancreas, GI tract, kidney, and muscles, and I'm sure all of you know about it very well. It is 94% homology to human GLP-1. It reduces energy intake, reduces appetite and cravings. Other metabolic and benefits are there with reducing weight loss. Semaglutide impacts all dimensions of appetite, reduce food intake, and results in weight loss. And this is one paper to show that 35% lower overall bean intake with once week semaglutide of 2.4, and weight reduction was decreased by 10.4 kg, which is significant. And increasing satiety and fullness is responsible reason for mainly for this weight loss. The semaglutide is available in India in all form, in oral as well as injectable in 1 milligram as well as in 2.4 milligram once in a week. And you see, when it is given subcutaneous or even oral, the response of using semaglutide is almost same. But you can definitely give higher dose of 14 milligram of oral is equivalent to 1 milligram subcutaneous, which is an actually anti-diabetic effect of oral or injectable semaglutide. But when you want to give higher dose of 2.4 milligram, that is actually the effect of this molecule as an anti-obesity agent. And now they are trying, and other clinical trials are going on for up titrating the dose of 2.4 up to 7.4 milligram, 7.2 milligram. The weight loss is up to 18.2 mean weight loss with semaglutide of 2.4. Around 20%, more than 20% weight loss is 1/3 of the patient, and there is a sustained weight loss up to 4 years. The participants who are achieving, 1/3 of them were achieving 20% and more, and you can say 90% of them are going to have weight loss of more than 5%. Semaglutide is the molecule which had shown the cardiovascular outcome trial a significant risk reduction for all MACE, but this benefit starts with the starting of the medication even before the weight loss. The SELECT trial had shown 19% risk reduction in all-cause death, 22% risk reduction in developing kidney disease, and 73% reduction in developing diabetes also. So even given when pre-diabetes or person who are obesity. Semaglutide have effect on weight-related, CV risk factor, and glucose metabolism. Weight loss benefits of this molecule, as I told you, the 7.2% and 7.2 milligram is also trial are going on, which is going to decrease the weight of almost 21%. And 1 in 3 people, 1/3 of them are reducing the molecule even with a higher dose, 25% of that. That's a benefit of this molecule when it will be useful or when it will be clinically available to use this molecule as a 7.2 milligram, very high weight loss. Superior HbA1c reduction with oral semaglutide, which we know that even as an anti-diabetic effect, oral semaglutide is also effective, up to 1.5%. But when we had used injectable, the HbA1c reduction was better. Oral semaglutide had also shown the weight loss, which is also clinically relevant, almost up to 5 kg. The positioning of GLP-1, if you just put in the guideline in PCOS treatment, as PCOS treatment, the primary issue is obesity, particularly for obese PCOS, the GLP-1 had become a choice of therapy. Is an intervention whenever we are looking for a metabolically beneficial intervention or intervention for hyperandrogenism or for intervention for menstrual dysfunction or intervention for infertility, you will find in all guidelines GLP-1 had come. Choice of treatment for modality according to grade of obesity and associated comorbidities. As we know, diet and physical exercise is always there, but with more than 27% BMI, the choice of therapy always goes in favor of semaglutide along with orlistat plus minus. This is ISAR consensus algorithm in 2024. The special consideration like PCOS condition is like that, postpartum weight management and peri and postmenopausal weight management also in SR algorithm they had put the use of GLP-1 analog. In 2023, International Evidence-Based Guideline for Assessment and Management of PCOS, here also you can see the GLP-1 is a choice of therapy. This is one more, optimizing obesity management in women in Indian obstetric and gynecology setting, a consensus approach by Indian Society of Assisted Reproduction. And here you can see some of our endocrinologists are also part of this paper to support that, yes, GLP-1 should be a choice of therapy. When should you consider use of anti-obesity medication for women with obesity in your practice? It should be continuously used, and this year we had shown up to 68 weeks, but those who have stopped in between, there is a regain of the weight also is being seen. So weight change over 48 weeks, but continuing medication prevents weight regain. So that's very, very important message that it is a disease and the therapy has to be continued. These are the different guidelines which talk about American Society of Reproductive Medicine, American Society of Metabolic and Pediatric Surgery, British Fertility Society. All of them are recommending strongly the weight reduction, improving fertility and maternal fetal consequences in obese women. This is our ADA guideline, which is talking about the type 2 diabetes and hyperglycemia. Again, it's a first choice if there is established cardiovascular disease for weight management, CKD, and even in the patients who are achieving a good or maintaining the glycemic goal. It is a molecule which is decreasing A1C significantly. So at all 4 places you will find semaglutide is a choice of therapy. It's very simple to start with 0.25, but you can step up with 0.5, 1 and 1.7 and stay with higher dose, which is 2.4. At present, it is recommended with more than 27 with one weight-related comorbidity or more than 30 should be given definitely. It is available in India with originator brand of Wegovy, 2.4 milligram, primarily indicated to decrease the risk of major adverse cardiovascular events along with the person who are obese or overweight. There are a special consideration when you would like to give. Elderly, no dose adjustment is required. Liver impairment, no dose adjustment is required. Renal impairment, again, no dose adjustment is required. Now, what about diabetic retinopathy? Monitor patients who have diabetic retinopathy for potential worsening of condition. And that too because of improving glycemic control. In pregnancy, not to be used. In pancreatitis, definitely, if it is because of GLP induced, it cannot be used. But if in other condition, it can be used in history of acute pancreatitis, but with caution. GLP-RA in male infertility, narrative use, systemic search from PubMed, Medline had shown 16 clinical studies, which are preclinical also, and they are focusing only on GLP-1 receptor agonist and male fertility. This is also very interesting area of male infertility where GLP-1 is also being tested. And they found the GLP receptors are present in testes, sperm and brain. So there are effect definitely at the level of hormonal, local, at the same time decreasing in weight gain is also going to have effect. And these are the GLP receptor agonists with male infertility had shown in some of the clinical trials the benefit, but still future directions are required for large and prospective studies. At present, with the smaller studies, you can't say that it is going to be given in a person's to increase their sperm motility or with male infertility. With this, I end my talk and giving once again thanks to Dr. Durvi and Dr. Vipul for giving me this wonderful opportunity. I'll be missing meeting and I'll be missing to meet all of you. Thank you.
So indeed, it was wonderful always to listen to Banshi sir deliver any talk, be it on academic or non-academic topics. And we really feel honored that in spite of his busy schedule, he recorded a video and he, sent it to us. And we are very happy to have him as our mentor. Over to Vipul sir to invite our next speaker, Dr. Rajni Saxena sir. Over to you, sir.
So yes, thank you so much, Dr. Dhruvi. It was indeed a treat to listen to Dr. Bansi sir always whenever he speaks because there is something we can learn from him. Our next speaker is Dr. Rajni Saxena. He's a director and chief diabetologist, Saxena Diabetes and Food Care Center, Ajmer, Rajasthan. He is a president, is Ajay Meru Diabetic Society, National General Secretary for Indian Podiatric Association, and multiple awards and affiliation to his name. He gives free consultation at RIC Diabetes Awareness Center, Kuchaman City, which is a rural village adaptation program by RSSDI, and organizing chairperson for Ajay Meru Diabetes Summit 2023 as well as 24. Sir has a keen interest in diabetic food and he's a very well-known faculty for any talk in diabetic food in Indian subcontinent. Over to you, sir.
Thank you very much, Dr. Vipul and Dhruvi.
Sir, your voice is...
Sir, now voice is coming or not?
Yeah, it's coming, but it's very slow.
Sir, actually, sir, technically I am both very poor. So,
No, it is audible though.
audible, okay. So now I can share my slides first of all. I think my slides are visible to all.
Yes, it is loading still. Yes, it is visible. Yes, it is
Yes.
inside. So yes.
Okay. Now I will discuss very important topic, that is diabetic foot practice for primary care physician. You all know, first of all, every patient of diabetes with any of diabetic foot lesion first contact nearest physician. So it is very important for a patient to take care their problem at initial level. I will discuss very important practical aspect because you all know at present there are burden of 101 million diabetic patient, and pre-diabetics is also more than 143 million. So a huge number of diabetic and pre-diabetic patients are at risk of developing diabetic foot problem, and lower extremity amputation is recorded more than 2 lakhs per year in our country, and in every 20 second one lower limb is amputated somewhere in the world. So it is very important to take care from the day of diagnosis of diabetes. You all know diabetic foot ulcer is a chronic wound with high amputation rate. And in chronic diabetic foot ulcer, any ulcer which fail to heal after 4 weeks. So the ulcer who fail to heal after 4 weeks will be termed as chronic diabetic foot ulcer. And diabetic foot ulcer complication, you all know, primary cause of hospitalization and amputation all the diabetic patient, and about 23 times high risk of lower extremity amputation in diabetic patient is seen, and more than 85% of major amputation preceded by foot ulcer in diabetic cases. According to International Working Group on Diabetic Foot, study findings suggest that about 46% of ulcer healed after 1 year, and 10% recurred after healing, and 17% required amputation of the lower extremity. So it is very important to take care the foot at the initial level. The various risk factors which are directly related to diabetic foot are the which is commonly seen in male gender, long diabetic duration, older age, specific lifestyle habit, and comorbidity. Uh, and globally, if we consider 18.6 million individuals experience diabetic foot ulcer in their lifetime, and in our country, the 6.2% of all diabetic patients can develop diabetic foot problem. Male, the pathology, we go for the pathology of the diabetic foot, mainly peripheral neuropathy, peripheral vascular disease, and alter biomechanics. With superadded infection is the important risk factor for the development of diabetic foot problems. In this picture, pathway of diabetic foot ulceration is shown. Basically, neuropathy, peripheral artery disease, both are commonest cause of developing diabetic foot problem. Due to neuropathy, there are sensory neuropathy where the loss of sensation is there, insensate fit is there, and this insensate fit is very prone to for trauma, and ultimately unnoticed trauma is responsible for the development of foot lesion, and ultimately if not managed properly it will landed up in for the in gangrene, septicemia, and so many other problems, and ultimately amputation may be required to save the life of the patient. In case of peripheral vascular disease, foot ischemia is very common, and it is because of the hyperlipidemia, and in our country cigarette chewing and tobacco chewing is very common practice in rural area. So this cigarette or tobacco chewing is very important for developing peripheral artery, and ultimately due to ischemia there may be foot ulceration. Simultaneously, in autonomic neuropathy, lack of sweating lead to dryness of the skin, and ultimately due to pruritic fissuring can occur, and with this fissure or scratch mark, infection can get into the foot. So ultimately there may be ulceration, and if epithelium is very hard or neuropathy is there, so callus formation is very common, and dead skin is present is seen in only in the neuropathic foot, but vascular supply is normal in this foot. So callus is one of the important risk factor for developing diabetic foot ulcer. So these are very important condition where alteration of biomechanics is very important for causing high pressure area at the different part of the foot, and ultimately due to higher pressure area and motor neuropathy there may be small muscle wasting, increased foot pressure, limited joint mobility. These all are responsible for again development of callus and ultimately ulceration can occur. So diabetic foot is a result of complex interplay between neuropathy, peripheral artery disease, foot deformity and infection. And who is at high risk of developing a foot ulcer? It is very important to know कि all patients suffering from peripheral neuropathy, we have to identify with the help of monofilament. If loss of sensation patient is fail to feel the sensation of monofilament, then he is at risk of developing diabetic foot problem. Then previous history of ulceration or amputation, any mechanical factors like structure deformity or limited joint mobility, peripheral artery disease or microvascular complication, the uncontrolled blood sugar, mainly very high SB1C is also one of the important risk factor, fungal infection and poor foot hygiene, and lastly very important is the poorly fitted or ill-fitted footwear. These create high pressure at different part of the foot, and ultimately diabetic foot can occur. You all know at the time of diagnosis of diabetes, only 25% patient complain symptoms like numbness, pricking, aching pain, burning pain and lancetting pain, allodynia, etc. But rest of the 50 to 70% of the patient they are having sign on examination. So in all the diabetic patient at the time of diagnosis we have to go for neuropathic assessment. It is very important. Then comprehensive foot examination risk assessment is very important at primary care physician level. First of all, you have to go for history taking, mainly fast history of ulceration, amputation, Charcot joint, any vascular surgery, angioplasty, or smoking or diminution vision, and chronic kidney disease is also very important. Always go for general inspection, not only from the plantar aspect but also from the dorsal aspect, interdigital space. Always inspect all the area, and always examine patient or inspect the patient after removal of the shoes and socks. And next is the dermatological assessment. Always go for examination of the skin status, whether sweating is normal or not, hair is normal or not, infection is there, any ulceration, any presence of callus or blistering is there or not. Then musculoskeletal examination include the deformity, presence of deformity like clotos, hamartos or muscle wasting. These are all indicative of the motor neuropathy. The neurological assessment is done with the help of 10 gram Sim-resistant monofilament plus one of the vibration using 128 Hz tuning fork, pinprick sensation, ankle reflex or vibration perception test. According to International Working Group on Diabetic Foot, at primary physician level, no instrument is available. So you have to go for finger touch test. With help of this finger touch test, you can easily identify whether patient is suffering from any loss of sensation or neuropathy or not. Other modern instrument are the infrared thermography is also very important. Then vascular assessment is done by examining the foot pulsation, mainly dorsalis pedis and posterior tibial pulsation, and ABI is also very important to know the presence of or extent of the ischemia. Then examination of it, yeah, I already discussed the history taking. Then different other types like the nail deformity, presence of erythema, prominent veins, calluses, foot ulcer, interdigital mycosis, or hamartos, bunions, or other foot deformity like clotos, examine at the time of foot examination. Then go for palpation. I already discussed peripheral pulsation. Then bony prominences and plantar aspect palpation is also very important to know that is bony prominence are there or not. Then go for examining the presence of edema. Any temperature difference in food, we can easily identify different temperature difference with our hand plan dorsal aspect of our hand. Then limited joint mobility. Latest tools are there, but we can easily know whether limited joint mobility is there or not. Why asking the patient to dorsiflex the अपना great toe, if it is up to more than 15 degree, then it is okay. Then sensation is examined with the help of simple touching and by applying any pressure with the cotton wool or monofilament. Then vibration is done with the tuning fork. In primary fusion level, tuning fork is available in all the clinic. Then position sensation and deep tendon reflex estimation is also very important. Then autonomic function is also assessed at a primary care physician level. Monofilament, we apply pressure of 10 gram with simple sim-written nylon monofilament at different parts of the foot, like plantar aspect of the great toe, first, third, and fifth metatarsal at heel and dorsal area also. Similarly, biothermometer, where with the help of mechanical machine we can estimate the presence of vibration patient if vibration pressure threshold, if patient feel after 25 volt, then 7 times prone to develop diabetic foot ulcer. If more than after 42 volt, then it is 23 times prone to develop diabetic foot ulcer. Then paper grip test and nerve conduction velocity is also very important, but it is not available at primary care physician level. But X-ray foot and ankle X-ray is very important. With the help of this X-ray, we can easily identify presence of osteomyelitis, early stage of Charcot foot, vascular state by calcification of digital artery seen in X-ray. We also detect the extent of infection with X-ray. Then electromyography, ultrasound, MRI, and probing. Probing is available at any primary care physician level. With the help of this probe, we can easily identify whether osteomyelitis is there or not. We can easily confirm presence of osteomyelitis. Then vascular assessment by arterial pulsation, dorsally posterior tibial pulsation, sometimes popliteal and femoral pulsations are also very important. Then small hand Doppler, it is very economical, about 20,000, it is costing about 20,000, and with the help of this small hand Doppler we can easily confirm the presence of pulses. Then ankle brachial pressure index, with the help of ankle brachial pressure index we can easily identify presence of ischemia, or normally it is 0.9 to 1.3. If more than 1.3, it indicates that calcified blood cells are there. If 0.6 to 0.9, that is mild to moderate ischemia is there, or claudication, stages of claudification. If less than 0.6, then rest pain or severe artery disease is there. Toe brachial index and ankle systolic pressure are also very important for assessing the presence of ischemia. Then other modern investigations are the transcutaneous oxygen tension, Doppler arterial waveform, contrast medium angiography, magnetic resonance angiography, but these are not available at primary level. Then plantar pressure assessment with the help of Harris-Mat assessment and computerized assessment of podium scan. Harris-Mat is very economical, very simple test. We can advise patient to walk over this mat, and we can estimate the pressure with the help of coloring of the different images of the foot. Next, very important is the examination of the footwear and foot. At primary care level, you examine the footwear of the patient. If there is bottoming out of the insole of the footwear, it indicates that at that particular point, high plantar pressure area is there. So we can advise insoles or footwear according to that high plantar pressure area. Then International Working Group on Diabetic Foot Risk Stratification System and corresponding foot screening frequency. It is very important at primary level. If ulcer risk is very low, if there is no loss of protective sensation or no peripheral disease seen, then once a year foot examination is advised. If loss of protective sensation or peripheral artery disease is there, the low risk patient, low risk ulcer patient, then once every 6 to 12 month examination. If loss of protective sensation with peripheral artery disease or loss of protection with food deformity or peripheral artery disease with food deformity there, then moderate ulcer risk is there, then once every 3 to 6 month frequency of foot examination is advised. If loss of protective section or peripheral artery disease and one or more of the following, that is history of foot ulcer, any history of amputation and stage renal disease there, then once every 1 to 3 month foot examination is advised to the patient. These are all important guidelines. We have to look for the loss of protective sensation and presence of peripheral artery disease at primary care level. Then multidisciplinary management is very important. The sixth aspect of patient treatment, first is the wound control, proper dressing and after proper debridement, and always estimate that if there is high pressure area at the plantar at the forefoot area, then we will decide the um, front offloading footwear, proper front offloading sandals is advised to these patients. A microbiological control is achieved with proper oral parenteral antibiotic according to the stage of diabetic foot. First of all, start empirical antibiotic and take the sample for culture and sensitivity, and after when culture sensitivity report is coming, then we can modify the antibiotic regime. Then mechanical control is achieved by the proper offloading, mainly bed rest, crutches, wheelchair, walker, plaster of Paris cast, and total contrast cast or other cast or therapeutic footwear. These are available in market. So with the help of these footwear, we can easily achieve the mechanical or control, or we can offload the ulcer site. Then vascular control is achieved by maintaining proper circulation. If dyslipidemia is there, we can advise statins, and reduction of edema is also very important. And metabolic control is achieved by achieving proper good glycemic control, because for healing of any foot ulcer, glycemic control is very important. Without glycemic control, no ulcer can be healed. Then management of hypertension, dyslipidemia, renal and cardiac function maintenance, proper serum albumin is also estimate. If proper protein is also required for the healing of ulcer. Always advise patient for stop tobacco chewing, and always use cardio selective beta blocker. And education control is also very important. If we educate all the patient and family member of diabetic, and only not only for the family members, society and physician who are treating the diabetes, so education of all the patient and physician is also very important for maintaining or preventing the diabetic foot problems. Then advanced strategies to prevent ulceration are the AI based and machine learning apps are also available. Telehealth is very important for proper healing of the ulcer. Then smart insole system is there. With the help of this smart insole system, intelligent shoes and in-shoes exoskeleton enhance the comfort and efficacy, and with the help of these we can easily identify whether patient is wearing properly footwear or not. Then Colligomat app is also coming to India. And last, smart boots approach to enhancing the offloading. With the help of this smart boot, we advise patient कि रेगुलरली वॉकिंग विथ प्रॉपर फुटवेयर इज़ वेरी इंपॉर्टेंट, क्योंकि पेशेंट जब हमारे पास आता है तो उस समय फुटवेयर पहन लेता है, अदरवाइज घर के अंदर बेयर फुट वॉकिंग का ट्रेडिशन अपने यहाँ पे इंडिया में रहता है. तो इट इज़ वेरी इंपॉर्टेंट टू यूज सच टाइप ऑफ फुटवेयर. देन आई कंक्लूड विथ टेक होम मैसेज दैट इज एवरी पर्सन with diabetes should undergo neurological and vascular assessment of fit at least once in a year. So at primary care level, with the help of proper tuning for cotton-based Sims monofilament and proper palpation of the peripheral pedal pulses, we can easily save the limb, we can easily prevent the development of diabetic problem. Then those who are at risk fit should undergo comprehensive examination of foot more frequently. So if at primary level no such examination facilities are available, then early referral is very important. And through patient education and lifelong surveillance of high risk fit, we shall be able to prevent foot ulceration and eventually limb amputation in persons with diabetes. And because now I conclude with this beautiful picture of Bhagwan Shri Krishna and Bhagwan Ram, because we are having tradition of foot care and footwear. And lastly we conclude with this beautiful picture of Dandi March. मेरे जो सारा टॉक है इसका टेक होम मैसेज इतना सा है कि इन दिस पिक्चर द नो वन इज वियरिंग फुटवेयर but the one who walks his good fortune also marches ahead. So always advise your patient to not to walk barefoot. Thank you very much.
Thank you, Saxena sir. Thanks. Diabetic foot is, I think, a section always that gets, very less sort of a heat in a busy diabetes OPD. A lot of us always do focus on larger complications, but diabetic foot is also something that needs a little focus. What do you wish to, tell us, all our primary care physicians and all our diabetologists who are listening to you today, sir? If you want to tell us one important thing, how can we incorporate diabetic foot care in our OPD?
In our OPD, first of all, we have to educate all the physicians for examination of foot as initial level, because all the patients of diabetes were examined for blood pressure, blood sugar, and all the investigation, but foot is always neglected part. To always go for examination of foot after removing the footwear. First of all, go for pedal pulsation estimation, and second we have to go for sensory checking, and always advise patient not to walk barefoot. With the help of proper foot examination, neuropathy, neurological and vascular examination, and footwear, we can prevent maximum diabetic foot problems.
Great,
Thank
great,
you.
sir. Yes, food is a very integral part of management, not only in diabetes, but also for general medicine, also for other communicable disease, also that peripheral pulses makes very significant part of examination. Thank you so much for discussing the things in detail, sir. So our last speaker for the first session is Dr. Rajesh
Thank you very much.
Deshmane. Thank you, sir. I would request Dr. Dhruvi to introduce Dr. Rajesh.
So wonderful, and it's indeed an honor and a pleasure. And first of all, a lot of congratulations to Rajesh Deshmane sir. He has just initiated a 100-bedded hospital, which includes a multidisciplinary care for people with diabetes. So congratulations. And I hear that this is one of the weekends where he was, officially going to inaugurate one of the other departments surgically. So congratulations, Rajesh sir, and thank you
Thank
still,
you.
in spite of being. Thank
Thank
you,
you.
thank you. Rajesh sir is a consulting diabetologist and metabolic physician from the city of Kolhapur. He's the ex-registrar, Department of Endocrinology of St. GS Medical College and KM Hospital, Mumbai. He has been a PI for a lot of clinical trials, has been a faculty to a lot of meetings nationally as well as internationally, has a couple of publications to his name, has done a lot of presentations, and he's a life member of RSSDI, DIPSI, Foot Society, Endocrine Society, as well as the ADA. So over to you, Deshmane sir.
Thank you, Dhruvi. Thank you, Vipul, and thank you, Banseshwar, for inviting me for this prestigious forum. So just a moment, I will share my slide. Can you see the slides? And slides are moving properly. Slides are moving properly.
Yes, yeah, they are
Voice
moving
is also
properly.
clear.
Yeah, it is also clear.
So
So from spectrum of phenotypes, and then the next slide. Yeah, it's quite.
So thank you. So my topic of discussion today is actually the diabetes various phenotype and how to manage these patients. So actually we know that obesity, there are different patients with diabetes and obesity, and as one of the important question that one treatment doesn't fit all. So that is true. So yes, those patients with same BMI, same HbA1c, same metabolic parameter, but they respond different to different therapy. So that is big problem, and that's why we will consider that whether we are doing something wrong, or we are not diagnosing the obesity problem, the diabetes problem in a correct fashion, in a right phenotypic fashion. So that's a big question right now, because we have a number of patients with 60% patient almost of diabetes they are either obese or overweight, and treating that patient are very, very important. And that's why today's question is, we have that question that whether we are treating rightly, or there are some what we are some doing. So yes, there are four different typical obesity combination phenotype. One is a portability type, which is clear classical visceral adiposity. Second is hyperinsulinemic obese. So there, there, there are severe insulin resistance, the patient with severe insulin resistance. Third is the fatty liver or pancreas. The patients are not that much obese particularly, but central obesity, as well as the if you look at the USG picture, the fat content is very high. Also, there is ectopic fat deposition, and the main culprit is lipotoxicity. And fourth is sarcopenic obesity, or thin fat Indian. So they're thin outside and fat Indian, fat inside India. So treating all these uh, 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 patterns of the patients are very different, and that's where this one. So first is the classical visceral adiposity, or adiposity. So such patients typically are actually hypertrophic visceral adipocyte. So yes, the major problem is inflammation, uh, and the high level of inflammatory marker like TNF alpha, interleukin 6, and the adiponectin level is actually critically low in such patient. And yes, the many times we do a routine CRP value in patient, and that CRP value is always on higher side in such patient, and that the basic uh, triad is such diagnosis for this obesity is waist circumference. For male it's more than 90 centimeter, and for female more than 80 centimeter. Adiponectin low, and HSCRP higher HSCRP value. So definitely for such in patient, must use, even though the patient is obese, but molecule like pioglitazone works fantastically in such patient. Actually, it acts on inflammatory marker. It actually shifts fat from visceral adipose tissue to subcutaneous space. If we use it with SGLT2 inhibitor, then definitely we counterbalance the fluid retention in such patient. And definitely the big problem in such patient, there is high insulin level, high level. So initiation of insulin in such patient create a lot of problem, particularly the weight gain again goes up, and the patient become obese. So such patients are very important. Second type of obesity. So yes, in that obesity, completely the clear-cut picture, acanthosis nigricans, fasting insulin and C-peptide level are high, and the triglyceride HDL level also on higher side, more than 4 for Indians. So definitely the second picture where is hyperinsulinemia is problem, then such patient needs to be treated with either GLP-1 receptor agonist or GLP-GIP combination. So the fantastic result we are getting, not in terms of uh, weight reduction, but also good glycemic control, as well as weight reduction can be possible. Second important thing, the metabolic surgery in such patients also gives fantastic result. And the big no is for sulfonylurea, because if you put the patient on sulfonylurea, again the problem of weight gain and early exhaustion of pancreatic beta cell is a big problem in such patients. Then, sorry. So to differentiate the first person and the second obesity pattern, so this is typically a patient X, patient Y, both with BMI 31 and HbA1c value of 8.5. But look at the first patient, the first type of obesity. Waist circumference is 104, HSCRP value 8, fasting insulin is 15, and inflammatory marker is high. And second typical hyperinsulinemic patient, typical central obesity, waist circumference just 99, HSCRP value 1.5. But look at the fasting insulin level, 45. And typical acanthosis picture, skin tag picture, so typically hyperinsulinemic. So the contrast treatment for type first patient will require a pioglitazone, whereas patient second will get benefited with semaglutide therapy. So physical examination and simple insulin as well as HSCRP values, which is costing not more than 600-700 rupees, gives a fantastic report, fantastic picture while managing such patient. So definitely the third obesity, that is lipotoxic obesity or ectopic fat phenotype, in which the subcutaneous fat is full of adipose tissues. And definitely in there is, we know that such patient, they have elevated free fatty acid level. There is problem of MASLD, and MASLD is associated in such patients. So do a routine ultrasound, you get a fatty liver picture. So there are two big problems, lipotoxic beta cell dysfunction as well as hepatic insulin resistance. Both are very important. But many times, if you look at the picture, MASLD, we are not getting directly in on the USG, but USG picture will have a high fatty liver disease. The fat content will be high. If you do fibroscan, then definitely there will be a you can get a picture of MASLD in such patient. The triglyceride level will be high, and ALT level will be also on higher side. So these are the typical patient. So what is the diagnostic tract for such patient? Grade 2, grade 3 fatty liver on USG or fibroscan, elevated AST ALT level, but always on normal side. So the disease also just elevated, but on normal side, high risk triglyceride level despite good glycemic control. So in such patient, a GLP-1 receptor agonist as well as SGLT2 effects, what we call as the twin fretting effect on liver fat, this also help a lot. And strict avoidance of carbohydrate intake, reduction in carbohydrate, particularly the reduction in fructose, that also help. And repeat fibroscan or USG annually to see whether the patient get benefited. But GLP-1 receptor agonist and SGLT2 inhibitors fantastically work in such patient. Then the fourth type of the phenotype is sarcopenic diabesity, that is thin outside and fat inside. Normally they have a normal BMI, low muscle mass, but high ectopic fat. The muscle is primary problem. The patients are typical Indian thin fat Indians. So the patients are young, mostly vegetarian, high carb intake. BMI is most of the time less than 25 or less than 25. Waist circumference is high. This is very, very important. And if you look at the strength, then the strength or muscle mass is on the lower side. Typical diagnosis, how we can diagnose the waist hip ratio or waist height ratio is a good diagnostic method. So waist height ratio or waist hip ratio abnormal for the normal BMI. Actually, if you look at the DEXA or body composition analysis, you can get clear-cut low muscle mass and high fat content. And the muscle strength testing like sit to stand test or hand grip dynamometry are simple tests. So in such patient, definitely the treatment is little bit different. High protein diet, SGLT2 inhibitor, definitely the medication itself will cause little bit of weight loss, but GLP-1 receptor agonist in such patient can cause more weight loss, but more muscle loss. So definitely the patient require initial protein treatment, and then if required, then after building a good amount of protein exercise, then we can think of GLP-1 receptor agonist in such patients. Actually, in male, sometimes the low testosterone is also a big problem in such patients. So simple decision tree for day-to-day clinical practice, waist hand grip ratio, normal BMI, low grip, then it is very important. Then BMI high as well as acanthosis is there, then it's a hyperinsulinemic patient. High waist circumference plus AST TG high, then definitely a lipotoxic obesity is a problem. And fourth, the high waist circumference, high HRCRP value, and ALT levels are high, then definitely the inflammatory. So definitely on this simple algorithm, we do not require a big test to diagnose phenotypic, which phenotypic, but simple test can do a lot of gives a functional test, gives a lot of insight whether what the patient is from which phenotype. So simple test will clearly differentiate between sarcopenic, hyperinsulinemic, lipotoxic, or inflammatory obesity. And to diagnose this can be very much helpful. And another important thing, which medication will work in which obesity, that is also. Even though patients are obese or overweight, some pioglitazone fantastically work in a patient where inflammatory markers are high. GLP-1 receptor agonist or fantastically work when there is hyperinsulinemia. GLP plus GIP work fantastically in patients who are hyperinsulinemic as well as patients who are lipotoxic. And the SGLT2 inhibitor can be used in all types, mostly that patient with inflammatory, patient with hyperinsulinemic, and patient with lipotoxicity. Metformin is a universal backbone, particularly except in a patient with advanced sarcopenia. If there is advanced sarcopenic patient, then we cannot use metformin or many molecule, but most of the time metformin is suitable in many of our such patients. So yes, which phenotype is important, and that is very important. So hyperinsulinemic patient on high dose of GLP-1 receptor agonist loses 50 kg. These are certain one of the case, but still doesn't exercise. Now they are dropping to sarcopenic obesity. So initially the patient was on hyperinsulinemic obesity. Later, because of use of GLP-1 receptor agonist, they become sarcopenic. But important thing is, after the introduction of GLP-1 receptor agonist, now the cost effective or the problem of sarcopenic obesity increases significantly. And yes, we need to classify or rephenotype every 6 months when there is weight loss of 5% or more. We need to reclassify such patients. So that is also very important, because that create a lot of big problem because of sarcopenia in nowadays. After rampant, we are using GLP-1 receptor agonist under very strict therapeutic condition, but some misuse of GLP-1 receptor agonist can change over the obesity pattern from hyperinsulinemic to sarcopenic obesity. So look at the phenotype, rephenotyping every 6 months or after 5% or 10% weight loss to rethink your decision what medication patient require. So, and weight loss without resistant training can unmask or worsen sarcopenia in such patients. So that is very important thing. So that's why the phenotypic first clinic is very important. So don't treat just diabetes and obesity, treat patient phenotype, and that is very, very important. So what are the simplest way of fasting insulin level, HSCRP, ALT, AST value, along with sometime USG, anthropometric measurements, waist circumference, waist hip ratio, waist height ratio, as well as the muscle simple tools we are getting right now, the dynamic grip testing. So with that testing is much better than 50,000 cost of genetic panel worth rupees 50,000. So simple testing which can be done in less than 1,000 rupees are simple than a big genetic testing panel. And a prescription which include diet and drug based on a major metabolic parameter, whether it's inflammation, hyperinsulinemia, lipotoxic, or sarcopenia, needs to be taken care while prescribing medication for obesity or this sarcopenic various type or various phenotype of obesity. So thank you.
Thank you, Dr. Rajesh. Of course, it's important to identify who we are treating so that we can treat them with precision. Do we have any questions, Vipul sir?
No.
I
Yes.
do have then one question. How practical it is? You just said that, simple tests which are practical and do not cost much. Could you tell me 3 tests that we should do for somebody coming into my OPD so that I can identify what phenotype am I treating with obesity?
So
3 simple
particularly
tests.
the to diagnose insulin resistance, C-peptide, and fasting sugar, which
I
clearly.
think there's some network issue on my side or your side. I don't know.
Hello, my voice
No,
is clear?
he's audible. Yeah, clear.
Yeah. So first, in fasting insulin level and fasting blood sugar. So definitely HOMA calculation is one of the simplest methods. Then anthropometric testing. So we have a height, BMI, waist circumference, waist hip ratio, height waist ratio. That also gives a very good clue. Simple HSCRP. Many times we do not do HSCRP value, but it's a very important marker. And obesity is not just itself a disease, but the cardiometabolic risk associated with obesity can be clearly, we can clearly see that if by doing HSCRP value, we get a good result. And liver scan particularly, either a routine ultrasound, which gives a picture of fatty infiltration liver with high fat content, so fatty liver picture. We do not have many centers do not have any elastograph with their fibroscan associated with them, but simple USG with high fat content, liver fat content gives a. So 3-4 tests, particularly the HOMA, the HSCRP, then liver morphology, high fat content, and simple anthropometric measures gives a fantastic result. And if you do have a BCS analyzer, body composition analyzer, BCA, then I think your almost all of your problem are solved. And I think after introduction of GLP-1 analogs, doctors are getting this routine instrument, because this simple muscle testing instrument, also cost-effective versions of body composition analyzer, which is costing not more than 15,000, that are also available. And by that, you can simply classify the obesity according to the phenotyping.
Thank you, Rajesh sir. Interesting and very executable. Thank you so much. Very practical for our practical diabesity. So with that, we thank all our speakers for our first session, Meenal ma'am, Banshi sir, Rajni sir, and Rajesh sir. And with that, I will request Sachiji to introduce a very dynamic and young diabetologists who are chairing our DIPSI symposium. Please invite them to chair our next session. Thank you to all our faculties of the first session again. Thank you so much.
Sure. A very good afternoon to everyone. Thank you, Dr. Dhruvi and Dr. Vipul, for this beautiful practical diversity conference. And moving ahead, now we have a DIPSI symposium, that is diabetes in women, from pregnancy to long-term metabolic health. And for this beautiful session, I invite Dr. Mudrik Patel. Sir.
Thank you so much, ma'am.
Welcome, sir, to the show. And Dr. Ninad Gaur, sir.
So Dr. Mudrik Patel is from the city of Baroda, a diabetologist, a very dynamic leader. And Dr. Ninad is from the city of Bhuj, heading multiple centers of diabetes. So with that, I give over the reins to both of you to take over and introduce our president of DIPSI. Yes, please invite her.
Yes, ma'am. Thank you so much from the warm introduction and lightning words. Dynamic young. Thank you so much. So a very important topic to be discussed upon, our GDM. So for that, I would like to call upon Dr. A. Bavarthini from Erode. About GDM, are we really missing the window of prevention of diabetes? I'm really excited to listen to you, ma'am. Please, over to you.
So Bhavtarini ma'am is the president of DIPSI, Diabetes and Pregnancy Study Group of India. Ma'am has so many laurels and awards to her names. She has been doing, I think, more than 3 decades of work with women health. And ma'am, we cannot wait to hear you.
Endless achievements. Yes, ma'am.
Dhruvi, is my slide visible?
Yes, ma'am, they are.
So first and foremost, immense thanks to my dear Dhruvi and Vipul for this wonderful opportunity. Now coming on to the subject GDM, are we missing the window of opportunity of diabetes prevention? Yes, of course, I can say we are missing the main thing.
it all starts in utero. That we should not forget. And if you see, India is the second largest obese children, even up till 2026, next to China. And of course, hypertension, not only that, macrosomia, cardiac problems, neonatal hypoglycemia, for all this, the maternal hyperglycemia and the fetal hypoinsulinemia are the kingpins which continues forever in life. If you take our mentor, Professor Dr. Seshi, has done long back in 2007 that GDM manifests in all trimesters, starting right from the first trimester, that if you are missing, going to diagnose in the later trimesters, we are going to miss almost half the cases of GDM, which are the causes of all non-communicable diseases in future. And he has repeated the same, of course, in 2016, 10 years later. What happened? It has all doubled. That is the paradigm shift what we are facing. So nowadays, we are getting a lot of obesity because of this paradigm shift. And Banting lecture 1980, he said that type 1 diabetes is the only diabetes that passes through pregnancy. Whereas if you take in 2020 Norbert Finkel lecture, David Simmons clearly said that prevalent GDM, diagnosing GDM in the first trimester because of the increased insulin resistance has become very much common along with insulin GDM. So now you all were very clear that female gender is the key for our diabesity prevention. It's not only diabetes, but also diabesity. And again, coming to David Parker, he told long back in 1920s, 50s, that the body's susceptibilities to lifetime diseases are all programmed intrauterine. What is this intrauterine program? It is the process whereby the stimuli, that is maternal fuels or stresses, anything that occurs at this critical or sensitive period of fetal development permanently changes the structure, physiology, metabolism, which all predisposes to individual to diseases in later life. This is the fetal origin of adult diseases, what David Parker pointed out. So having this in mind, we started screening all the pregnant ladies, not in the later trimester, like 24 to 28 weeks, but in the very first trimester with the easy single-step national guidelines given by DIPSI. What happened? We were able to overcome all the perinatal problems like preeclampsia, preterm, big baby, etc. But the childhood obesity, which is more common now, early IGT, future diabetes, and all other non-communicable diseases continue to increase in spite of strictly controlling the GDM also. So our father of GDM, Professor Seshi, after scratching it for a long time, has come out with a concept of primordial prevention. So what happens nowadays? It's a day of single child. That child who gets married very late, and then she plans a pregnancy late, by which time it almost coincides with the diabetes occurrence. And she is also sedentary, always on fast food. So what happens? She enters pregnancy with much of insulin resistance and hyperinsulinemia, which is the driving force factor in the development of metabolic diseases by affecting the placental growth, angiogenesis, and the lipid metabolism. Initially, this hyperinsulinemia is from the mother's side, but later, because of hyperglycemia, the glucose getting transferred via the placenta to the fetus, the hyperinsulinemia is taken over by the fetus. That again controls the actions of placenta. So you can see that initially the insulin resistance with maternal glucose, which crosses and increases the GLUT4 and GLUT1, which takes the glucose to the fetal side and stimulates the fetal insulin secretion. And again, the insulin, though it cannot cross the placenta, what it does, it has influence on the placenta, increasing the placental growth, angiogenesis, and causes more of lipid droplet deposition. And all these affects the actions of the functions of the placenta. And later what happens? The increased glucose stimulates the fetal pancreas to secrete more insulin. This again influences the placental growth, angiogenesis, everything. Not only that, this, because of hyperinsulinemia, which starts in utero and being there forever, causes beta cell exhaustion and type 2 diabetes in later life. And this causes cardiac hypertrophy and causes cardiovascular diseases. And because of fat deposition, it causes obesity. And because of impaired hypothalamic development, causes effects on feeding behavior. So what happens? The child has more appetite, keeps on eating. That's where we are getting more and more of obesity nowadays, for which we are putting them on this latest GLP-1 receptor analogs, which brings down this craving. That is what we are doing now. And if you see the long-term implications of this obesity in the fetus, the maternal hypoglycemia contributes to the fetal metabolic programming and increases the offspring risk of obesity, insulin resistance, metabolic syndrome, and future diabetes. Early and effective glycemic control during pregnancy may reduce the transgenerational cardiometabolic risk. How this affects the fetal programming? The maternal hyperglycemia drives fetal pancreatic overstimulation, promoting adipogenesis and macrosomia. And not only that, this causes epigenetic modification. That is, this intrauterine hyperglycemia alters the gene expression patterns, affecting the metabolic regulation in the offspring. And again, it also affects the adipose tissue programming by excess fat deposition, increasing the childhood and adult obesity risk through altered adipokine signaling. So the child gets more obese, 2 to 3 times increased risk of getting childhood obesity. And because of insulin resistance, there is increased metabolic syndrome in the very early age, right from young adulthood. And not only that, there is transgenerational risk amplification. David Metzer has long back said that those with normal fetal insulin will have very low IGT, no obesity, all that. Whereas if they have hyperinsulinemia, it's going to cause more obesity in the childhood, and also it has 33% increased risk of IGT at even 12 years of age, whereas it is 1/10 of that if the fetal insulin level is normal. So the insulin resistance with hyperinsulinemia in GDM is the one which increases the atherogenic lipid profile, inflammatory markers, hypertension, and endothelial dysfunction, leading to increased cardiovascular disease also in later life. So GDM is the mother of all non-communicable diseases, sida, menta, satiae. Now, we are organizing so many camps just for the detection of diabetes, but this is not going to prevent the occurrence of diabetes. What we need is primordial prevention of this diabesity, that is, the disease should not develop at all. And of course, detection of diabetes, that is, diagnosing GDM is possible. What we are concerned is prediction and prevention of GDM so that its consequences like diabetes all are controlled and stopped. So when to test and predict this GDM? Of course, NIH has said that blood test, which is done in the early trimester, first trimester, is going to help. That is 10th week. It says, why this 10th week? If you see the embryology of the fetus cell development, it develops by 4 weeks, but starts functioning by 10 to 11 weeks of gestation. For example, I can say if you're seeing a pregnant lady at 10 weeks, her blood sugar is 126, and she comes for review after 2 weeks, the blood sugar has come down to 112 without any intervention. How this has happened? This is because of the secretion of fetal insulin, which has started and brought down the maternal blood glucose. The maternal blood glucose does not go up due to the fetal insulin handling and all of the maternal glucose, that is stealing of maternal glucose. Whenever the maternal blood glucose crosses 110, immediate action has to be taken to bring down this postprandial blood sugar less than 110, or else she'll develop GDM and also its consequences. Here you can see that glucose crosses and stimulates the fetal pancreas to secrete insulin. When the mother's blood sugar is beyond 110, it will secrete the more insulin in the fetus, and the mother's blood sugar will look normal because of fetal steal glucose phenomena. So fetal hyperinsulinemia is likely to present before the GDM diagnosis. What they are doing usually now, that is 24 to 28 weeks. The fetal glucose steal phenomena could mask the maternal hyperglycemia and increases the risk of false negative GDM results. That is, if you are going to test beyond 12 weeks, what happens? The fetal insulin starts controlling the mother's blood sugar, and when we diagnose GDM in the mother, she may look normal, so this gives a false negative test. Why this 110? This is the fetal renal threshold, like by how we have adult renal threshold as 180, for fetus it is 110. So whenever we cross this 110, the fetal renal threshold, the fetal pancreas starts acting and secretes insulin to bring down the blood sugar. This fetal secretion starts at almost 11th week, but the problem is once the fetal insulin secretion starts, it will not stop. It is irreversible. It will continue throughout gestation and postnatally throughout life. Initially, the fetal insulin secretion helps to control the mother's blood sugar. Later, this hyperinsulinemia steals glucose from the mother as long as it is inside the mother. After delivery, the mother's blood sugar's glucose supply is cut off, so the neonate has recurrent hypoglycemias. When it grows, this hyperinsulinemia causes increased hunger and has craving for food, so consumes more and continuously develops metabolic syndrome consisting of this obesity, dyslipidemia, IGT, and later diabetes. This hyperinsulinemia is the problem creator for all this diabetes or other non-communicable diseases. Hence, to prevent diabetes and obesity, we should not let this hyperinsulinemia to happen in the fetus by controlling the mother's blood sugar before the starting of fetal insulin secretion. Again, as you have well heard from our previous speaker, Dr. Banshi, that increased insulin resistant, that is obese mothers, they do produce infertile sons also. So the prediction of GDM is postprandial blood sugar of more than 110 at 10th week. So we need to bring down this less than 110. For this, preventive action has to be taken at 8th week itself. So if you see the blood sugar, postprandial blood sugar of 110 at 8th week, start medical nutrition therapy plus metformin, and this has to be continued throughout pregnancy. The priming of the fetal beta cells around 11th week may account for the persistence of fetal hyperinsulinemia throughout pregnancy. Not only that, it continues throughout life also. So metformin, you may have a doubt whether it can be used or not. It is safe for use throughout pregnancy. This is the first anti-diabetic used, which can be used safely from conception to birth. Not only that, because hypertension is also a feature of preeclampsia, is also a feature of insulin resistance. This again lowers the risk of preeclampsia also. Thus, preventive actions for diabetes is possible if the postprandial blood sugar, it is postprandial blood sugar less than 110 at 10th week, as the fetal beta cells will not secrete insulin at this time, which if it happens, it's going to be irreversible. And so, how do you classify all this? If the blood sugar in pregnancy at 2-hour plasma glucose is more than or equal to 200, it is diabetes both in pregnancy as well as outside pregnancy. The plasma glucose 2-hour, if it is more than or equal to 140 up till 199, it is GDM in pregnancy, whereas the same is impaired glucose tolerance outside pregnancy. And remember, this 2-hour plasma glucose gives problem even at the level of 120. So be very cautious and careful that from 120 to 139, it is gestational glucose intolerance. Like how you have impaired glucose tolerance outside pregnancy, you do have gestational glucose intolerance. You need to start with your therapy of medical nutrition therapy at this stage itself. And this new terminology, the early gestational glucose intolerance is 2-hour postprandial. It is not for glucose, just one postprandial. If it is 110, you have to start action. This is any value above normal is abnormal. So remember, gestational diabetes mellitus is a window or opportunity for the prevention of not only diabesity, but also all the cardiometabolic disorders. So to achieve diabesity-free generation, we need to focus on the fetus in the future. Thank you.
Ma'am, it's always a privilege to listen to you all the time for your enlightening and enriching session. Literally all the time. Thank you so much for teaching us.
Thank
For
you.
the next on the panel, I would like to call Dr. Ashish Dengra from Jabalpur. He'll be speaking on beyond delivery to prevent the transition from GDM to type 2 DM. Over to you, sir.
So, Dr. Mudrik, because of some reasons, Dr. Ashish sir has not been able to join us. We
Okay.
have Bhavtarini ma'am, and this is a very nice opportunity for us to discuss with Bhavtarini ma'am what all we could do as a part of an Indian
Yes.
national group of doctors. We are associated with so many teams, with so many groups who are leading management on a lot of sides. How can we work to have better women health, better diagnosis for GDM, early diagnosis of GDM? Ma'am, if you would like to tell all our young stalwarts who are all here, including myself also, I'm considering myself, what would you like to?
Dhruvi, what I want is we need to collaborate with the logicians. That's main thing. We do have a lot of ideas and things, and we are able to treat only GDM, but we are not able to prevent. For what we need is we need to collaborate with them. All the logicians, they think if they deliver a baby, that's it. All has been solved. Even what we have found, even the baby is normal weight, that is the Indian standard weight between 2.5 and 3.5 also, if the subcutaneous fat, what you said, that thin fat Indians,
Yes.
even there, if the subcutaneous fat is more with a normal weight, it's going to cause all the problems, mainly our obesity and also leading to diabesity. What I feel is we need to collaborate with the logicians and we need to teach them more about our preventive measures, what we are struggling. That has to be done with them. It has to start with them.
In our recent interaction with a group of OGs, what we asked them was, how could you help us in the prevention? They said for a lot of females with PCOS, a lot of females with infertility, what they recommend is either you freeze your eggs at the time and then do not, wait, control your obesity, and plan conception only after you have a certain number of weight loss that has been achieved. How comfortable are we as diabetos doing this, or collaborating on this side?
The thing is, we ourselves have to approach them, because they send the cases to us only after getting a full-blown GDM. That's not correct. We need to prepare pre-conceptionally. It should be a day of fit to conceive. It's not like that. As you said, all the adolescent girls, we are doing studies in the adolescent girls, they all are having very easily the impaired glucose tolerance, HbA1c, around +6 or ±6. It's so common in the adolescent girls. They are entering pregnancy with impaired glucose tolerance, with IGT. That is 5.9, 6.2, 6.4. With that, they are entering. They should prepare themselves. All those have to be brought down pre-conceptionally. Of course, Dr. Shalini, Rajiv, they came out with a very good suggestion of pre-conceptional program. That's very important. And if at all, they have missed that, what I have told, that is at least soon after conception, they need to do that. At the time of confirming pregnancy, they need to see for just one postprandial blood sugar. That is what I said. It's very easy for anybody to 110 postprandial to see without glucose. It's the simplest what they can do. And if at all they see 110, that has to be brought down less. And this less than 110 has to be maintained throughout pregnancy. You do whatever you want. Either you put them on metformin or increase the dose of metformin. If it is not necessary, you go for insulin also. Whatever you do, that 110, below 110 has to be maintained throughout pregnancy to avoid mainly obesity. What I can say, obesity is very common. These obese girls are entering pregnancy. Then how can you expect normal future generation?
Thank you. Thank you, ma'am. So, prevention of GDM, prevention of obesity, and good health and preconception counseling, I think, should be something that we take home and propagate amongst our group of doctors and
Fit to
OBGYNs.
conceive. Fit to conceive.
Fit to conceive. Amazing. So that's what we will try and execute practically after this session. Thank you so much, ma'am. It was a pleasure having you. Dr. Mudrik, any closing remarks you want to give?
I think ma'am covered it all, and thank you so much, ma'am, for enlightening us again. Ma'am, I just have one question to ask out of the box. How much do we have to rely on fructosamine assay for looking at glycemic control in pregnant women?
Of course, they do commonly ask this question. I don't think they are doing fructosamine very commonly. This is going to give only a short-term control. The first overall, and that is for the past 15 days, all that. Instead, what you can do, if you are doing HbA1c in pregnancy, you can do monthly also, because the maximum it is going to show the past month, 1 month control. So you can better go for HbA1c, which is more reliable.
Very true.
Very sensitive. Yeah.
I was doing the opposite, ma'am. I was calling the woman monthly and I was doing the fructosamine assay. It used to be in the normal range, but the SMBG values were not in the normal range.
Yeah.
So it keeps me confused and I have to end up the woman being on CGM, put her on CGM. Anyways, thank you so much, ma'am.
Yeah, what you said is exactly correct. We need to rely only on the CGMS.
CGM, yes. Thank you so much.
Thank you, ma'am. Sajidi, can you invite our next chairs for the session? Thank you, Bhavtari.
Thank you, Dhruvi.
Thank you, ma'am, for the beautiful session. Now, moving ahead to a very beautiful topic, that is technology and the systems. So we have international diversity and technology sessions. Technology is always close to my heart, and it's an honor to invite today's chairperson for this topic, Dr. Hitesh Saraogi. Sir is from the New Delhi, and he is a metabolic physician and diabetologist at Dhanvantari Hospital. Very dynamic doctor. Welcome, sir. Then we have Dr. Nimmi Mulwani. Ma'am is a true visionary leader and a founder and consultant diabetologist at Dr. Nimmi's Diabetes Care and a very good friend of mine. Welcome, ma'am, for this beautiful chairing session on technology. Over to you, ma'am, and over to you, sir.
Nice to see Hitesh. Hitesh, hi.
Hello, ma'am. Good afternoon. How are you, ma'am? It's always a pleasure to listen to your lectures. You're so passionate about GDM and the kind of knowledge you have. Amazing, ma'am. Amazing.
So true, ma'am. You inspire so many of us to do better for our patient and better for ourselves. Thank you for such a lucid lecture in Practical Diabesity. We will definitely miss you seeing here tomorrow. So our next speaker is Dr. Dharmendra Panchal. He is a very dear friend and he is MD FRCP in Edinburgh. He's a diabetologist and he has been assistant professor of medicine at Dr. M. Kesha Medical College. He's founder of Dr. Diabetes, Digital Diabetes Clinic. We all learned teleconsultation and digitalization of diabetes from him. He has been a regional faculty for certificate course in evidence-based diabetes management by PHFI. And he's a regional faculty for advanced course in diabetology by RSSDI. He has published many papers and written chapters in national journals and textbook as a primary and co-author. Right now, he's settled in Dubai, UAE, and I invite Dr. Dharmendra Panchal to talk about gamification or migration of diabetes.
Thank you, first of all, having me here. And I would love to share my slides.
Good afternoon, Dr. Dharmender.
Yes, very, very good afternoon.
Always a pleasure.
Yeah. Just confirm if the slides are visible.
The screen is still paused.
Is this slide visible now?
No, Dharmendra, does not come.
Oh, it's showing here. This why.
Your screen is
Nice to
paused.
meet-
You share.
Yeah.
Nice to meet you, Dharmendra.
It's a pleasure, ma'am, always to see you. Your screen sharing is paused.
No.
Yeah, it is showing pause. I don't know why.
You can.
It is showing
log out
Dharmendra
from
Panchal
your-
has paused screen sharing.
Just a while.
Technical glitches in a technology session is bound to happen, so that's okay. That is the paradox of life.
I think now it is not paused.
Dharmendra Panchal has started screen sharing.
Hi, Dharmendra.
It's there. Hello, Vipul bhai. Yep, now it
Yeah,
is
you
there.
got it.
Started.
You
Right?
got it.
Finally,
Audible, visible.
So your screen was waiting for Vipul sir to come and tell you.
Yep. Fine. So, yes, many thanks. And it's like, I still feel that I will start the session by welcoming you all for the practical diversity. Then I realize, okay, oh my God, the time has a little changed. But yes, by heart, thanks, dear Bansi Sabu sir, and yep, Vipul bhai Dhruvi for just making this possible and, making the to be here. Many thanks. Yes, here we are for this technology symposium, and the task given to me is one of the to my core heart gamification in diabetes management. The this conception of this concept, it was way before 3 to 4 years when this we were all struggling, and still, I think before that, I would say nothing to disclose for this session. And yes, we were all struggling with the problem of uncontrolled diabetes. Since long, if we start from 2014 data, yep, if we see proportion of the people living with diabetes with HbA1c less than 7%, they are remaining around 30% or less. The same scenario, if we go ahead 2019, the same scenario, if we go ahead at 2022, people with controlled diabetes with HbA1c less than 7%, they are remaining almost around 30 to 40%. Why? This is something unique. This throughout the whole development with all the new drugs and technologies, and still this is the burning question which we are all struggling. So what's the unique in diabetes care? That is, it requires continued behavioral self-regulation. We all must agree to that. People with diabetes spend on an average almost around hardly 6 hours with the healthcare professional over the year. Rest of the time, they need to manage by themselves. And that is where I think overall, because coping with type 2 diabetes is not just the medicine. It requires social and emotional support, and that as a healthcare professional, as a policy maker, and everyone will need to contribute to make it possible. And this requires for a people with diabetes a constant motivation to remain healthy, constant motivation to take care of themselves by themselves. And yes, what does the motivation come from? Let's see on the moral ground. Definition of motivation means to set in motion. It's a different drives towards the different goals, but yes, it's a state or it's a drive, we can say. And what matters particularly for diabetes control is a intrinsic motivation, and that derives through the competence, relatedness, and autonomy. Just going a little away from the topic, but yes, whenever we need some behavior change, we want it has to be, I want to do this. But over the past, I think it's like the diabetes management. You have to do this. A person, a people with diabetes, has been told you have to do this. You have to do this. You have to control this. You have to check your sugar. You have to take the medicine. If we can change this perspective from have to want to, I want to check my sugar. I want to take my medicine. I want to make it, that my diet should be balanced. I want to do the regular exercise. And if this perspective we can change from have to want to, I think we will be able to win this war against diabetes. So yes, motivation is necessary, but only motivation doesn't guarantee for a behavior change, because motivation, behavior is carried apart from motivation, capability and opportunity to perform. Not only me, but my family member, my surrounding, my work atmosphere should be adapting to this behavior. Also capability, a person should be capable of doing this. So when this capability and opportunity mixes with the motivation, it builds up the behavior. Apart from this, there are many other layers which are acting upon, from policymakers to the intervention, and then this behavior changes occur. And then any behavior changes is there, if they are not reinforced, it is short-lived. We have seen this, many times, many programs in the past, or we have been experiencing, people are going for such kind of program for the detoxification or changing the lifestyle for 1 day, 2 day, 3 days, 1 week, 1 month. And again, it come bounce back, because any behavior is usually short-lived if it is not reinforced or it is not rewarded. And that is the behaviorist perspective, that reward plays a central role in shaping and maintenance of the human behavior. We have learned from our physiology of Paulo's pouch, So yes, this was the base of having this gamification on the board. Like, we need to, make people with diabetes to become motivated, to stay motivated, to carry out a healthy behavior, health education behavior, and to maintain that. So yes, we have to make them have a goal. We have to plan that, and then we need to maintain that. And if we see the stage of changes of model theory, from pre-contemptation to contemptation to preparation, action, I think till this we all are good. We are able to do this. Many of the people with diabetes in their life, they are able to achieve HbA1c less than 7 at one point of time. But yes, they are not able to maintain. Many people are not able to maintain. So maintenance is where I think somewhere we lapse and it goes into relapse. And that's why this concept came into mind, to deliver the diabetes care not only as just patient and physician, patient and clinician consultation, but On top of that, it is not replacing, but it is on top of that, making it in the form of some game. So this concept then came for, in the form of, we call it as a diabetes freedom model. This is, to make a quality of life of people with diabetes better. It doesn't mean that you will not have diabetes, but yes, it can assure that you can achieve your goal of diabetes and you can live a life free from complication. And I think that is the thing we want for our people with diabetes. And that is the goal for our uh, diabetes consultation or our healthcare delivery for the people with diabetes. It is based on a prototype of learn, implement, and maintain the good glycemic control by themselves at their own pace. So yes, as every game, there were some rules. This model should be adapted by healthcare professional, and person with diabetes should be observed with the healthcare professional, qualified healthcare professional only. And we have created the stages. For each stage, there is a point system. People with diabetes, after completion of each stage, they have some rewards, and that I think make it run on, run on, run on. So learn, do, and teach. These are the core principle of this model of gamification in diabetes care. So it's a three-step success formula to win the game of diabetes. Learn, and when we call it as a diabetes freedom, finish it to give as a some name, so that a person will feel that they have achieved something. We make them to play the game of, and once they win the game, they achieve their goal, they become the achiever. And yes, then they come on the board, they help the community, they help each other, to teach each other, to teach their surrounding, to living the healthy life, and they become the master of diabetes. So yes, in stage of learning, few basic principles: diabetes, exercise, sleep, stress, and relationship, of course, substance abuse, drugs, and monitoring themselves, like getting themselves evaluated in the form of few leaderboard questions. And yes, they need people with diabetes, they learn by themselves, they learn the game and they play the game. And once they successfully complete this, they go ahead for the second step or second stage of the game. That's the stage of implementation, where every week they have been people with diabetes, they are discussed and they are given some tasks to perform, keeping into mind overall as the whole health of them should be improved. And the 10 parameters of our blue index were kept as a goal, like A1C, blood pressure, cholesterol, diabetes, exercise, follow-up in the lab, clinic, and follow-up in the terms of glucose monitoring, their general health, habits, infection, and yes, adverse effect, adverse drug reaction. And based on that, the blue index score or diabetes health score is calculated. And this is followed up. At the end of 3 months, we wish, a person with diabetes, people with diabetes, they should achieve the diabetes health score of 40 or more. And of course, along with that, our educators, they have the live training, as well as they have the live interaction. They have been given some scenarios. They need to solve that puzzles, some scenarios of how they need to behave. These are the modules in the terms of, lifestyle modification, health, behavior change, physical activity, nutrition, sleep health, tobacco and alcohol use, emotional, mental well-being. So they are taught, they are placed as per the case-based scenario, and they need to work on it. They will suggest their own, from their own life experience, how they come out of it. and the expert educator working behind the scene, they will improve that. They will suggest. So it's likely weekly. They need to just they play the game in the form of weekly 1 hour. They attend this game, and yes, based on the improvement at the end of we will have the evaluation in the terms of diabetes health score, and that rewards to have the diabetes health score of 45 or more, and they achieve the tag of freedom achiever. And the stage of maintenance. So for those people who are able to achieve diabetes health score more than 45, those people who are able to have their HbA1c less than 7%, those people who are able to maintain the HbA1c less than 7%, they all become the master, and they start helping the community, other people with diabetes, to achieve their own goal. And the more and more they help them, also they are rewarded in a way. So have, and that is they are able to achieve their goal, maintain their goal, and then they are able to help this community. So these are the 3 steps of this game, from freedom finisher to achiever to the master of the diabetes model. And this is what is our experience, you know, uh, as a pilot project. This was run in the India. Okay, so yes, patients signing into the game 370, and they played over the 6 month. 283 people were able to continue over the 6 month. Yeah, over the 6 month, average HbA1c dropped down from 9.5 to 7.4, and people achieving or A1c less than 7%, they were baseline only 9% were having HbA1c less than 7%, but at the end of 6 months, 45% or more people were able to have their HbA1c less than 6 months. More and data are coming up, more and more data, and yes, we will represent it. This is the graphical formattation of the same thing. So yes, more and more people are able to achieve the HbA1c less than 7%. So advantage of this gamification, we were able to create or make it intrinsic motivation, self-realization, rewarding, and the pleasure. Because diabetes is not a disease, I will say it's a disease condition, it's a lifestyle condition. If we treat as a disease, it creates pain. So the starting, this changing concept that treating it as a condition, treating it as a game, and like to win the game and go ahead. So any reward, of course, creates the pleasure. So that was the whole thing. And yes, next we are coming with the part 2 of it, where we have the game leaderboard. So yes, we can see our colleagues who and how they are playing. We will have the AI avatar, and you can choose your AI avatar, from whom you want to learn. We will be able to connect the worldwide with all the people living with diabetes. And yes, we seek the global support. We are going to have multilingual support. And yes, different modules we are preparing for the all age group, children, adult, and elderly, because they do have their different needs. And of course, specific groups like pregnancy and pre-diabetes, these are also into the pipeline, and these modules are preparing. So of course, many must new things will be coming into gamification, but the idea remains just making it as a game, so that we can make a people with diabetes to have sustained behavior change for the lifelong, so that they can get their goals. So I think that was all from my side, the concept of gamification in diabetes management. And again, I would like to hand over the session to the organizer. Many, many thanks. Thank you.
Thank you, Dr. Dharmendra Bhai. It's you truly said that treating diabetes is easy, but making them understand how to deal and stay a patient of diabetes for lifelong is difficult. And when you add interesting modules, when you have interesting puzzles and you reward them, it becomes easier for patients living with diabetes. So, with that, thank you so much, Dr. Dharmendra Panchal, for sparing your valuable time. And you are always a part of Practical Diversity, and you
Yes.
always have to say, welcome all.
Yep.
Maybe
are
Thank
one.
you.
once we'll have
Yeah,
it in Dubai.
Definitely.
definitely.
Definitely. So, our next speaker is Ms. Khushbu. Can I please have the intro slide?
Okay.
Yes. So again, a very dear friend, and this time we are meeting virtually. She is Miss Khushbu Verma. She is from Denmark, and she is the founder of We Care, and she has worked on EHR, EMR system, and national projects in Denmark for data-driven care for chronic patient. And she has been advancing Danish healthcare for AI ML assisted care. So I welcome you, Ms. Khushbu.
Thank you so much, Dr. Nini, and thank you so much. I hope I am audible.
Absolutely.
you're audible. Welcome,
Okay,
doctor.
super. Thank you. And first of all, I would like to thank Dr. Dhruvi, Dr. Vipul, and Banshi sir for this wonderful opportunity to for this diabetes conference. And really have been wonderful hearing all the speakers so far. I'll share my screen, and you can see. Is my screen visible?
Yes.
I'll just skip this and do the presentation. Yes. So what I want to talk about is, of course, I come from the company Cordia, but I want to talk in general about how can we use technology for the best results in diabetes management or diabetes management. And it is the diabetes management includes longitudinal care delivery towards the patient. What we focus on is how to strengthen that relationship in that long-term care delivery, how to strengthen the relationship between clinicians and patients for better care delivery. And there we can use technology, we can use AI, and of course human support, because that cannot be replaced to reach the last mile as well. As many of our previous speakers, they mentioned that there are multiple challenges in diabetes management today. There is the problem of fragmented care. Patients do not adhere. Detections happen late. And then there are also nutritional gaps. So how do we solve all of these problems in order to get the best patient outcomes, best results towards the patient is the key. And I coming from digital health background with 22 years of experience in digital health design, development, and implementation, I can tell that from all the countries that we have worked with, we have found that technology has managed to help solve these problems in multiple ways, to multiple degrees. And that is what I would like to share a bit with our audience today. So the least technology can do is to replace the repetitive manual communication with automation. And that manual communication is, for example, sharing information, making the patients aware, informing them to make the right choices by themselves, and then also answering their queries. There could be multiple aspects of communication that can be replaced by technology to an extent. Of course, the personal touch, as I said, human in the loop is always needed, and that is my standing. That is the fundament that we operate with. But still, technology can replace a lot of repetitive tasks. And today, in the world of AI, this can be done in a very smart, contextual manner if it is done directly, if we understand and know the patient, like Dhruvi mentioned in the start, when Dr. Deshmane, he was talking about phenotypes. So what technology can enable is the care roadmap, that is care pathway, and that technology can handle these different phenotypes very smartly because the categorization, if it is not to be done manual, it becomes much easier. So that the care pathway design for different phenotypes, for different categories of the patient, and also at individual level, that can be done very effectively. Then the systematic patient education, for example, continuous guided learning to keep patients informed, confident, and safe at every stage. And I feel that just before we heard about gamification, and that plays an important role in that education as well. If this education can be made interesting towards the patient and can be gamified, nothing like they will absorb and they'll be more diligent towards it. Then the third is contextual promotion, and promotion doesn't mean that necessarily what is commercial promotion, but also promoting the right behavior, the right services to the patient at the right time, so that they can take the right decision and make the right choices again. Coordinated involvement of care teams and caregivers is also something which technology can cope up with very easily as compared to if done manually, because again, if the family members have to be involved, if a home nurse has to be involved, all of that becomes easier with technology. Technology can be made simple, scalable, and the protocols of a particular clinic can be mirrored into the digital world, into the digital setup, and that is what technology can be especially useful, because every clinic is unique, every patient is unique, and again, dealing with that uniqueness, if a technology can cope up with, it's a good technology. If we think about the advantages that we can harness, or the potential advantages that can be harnessed using technology for patients, we have heard a lot of speakers until now about how to stay connected with reminders, nudges, personal guidance. That is something which can be totally automated, so that a person can do, a clinical staff does not need to pick up the phone and call the patient for reminders and nudging. It is done automatically using technology. Then better long-term outcomes through adherence and lifestyle support. That is also something where, as Dr. Bhakarni was telling in her speech as well, in her lecture, that a lot of lifestyle support and adherence in the initial stages is dropped, is not taken care of because of lack of time, because of other issues take most of the time and attention. So that is also something which can be delegated to technology. Of course, again, with human support, with the human touch in it, and with the personalization that it demands, but it doesn't need to be totally on the shoulders of the doctors. And then there is this health overview with clear cause effect understanding. That becomes important as well, because we as clinicians are making a lot of interventions, a lot of trial, and of course, a lot of not try and fail, but more like trying different interventions and seeing how it works. If we know that clear cause effects relation, if we understand the coherence or the relation between the cause and effect, it also become more data driven, and we can be more sure about what works in which type of phenotype. And that is, again, technology can easily provide that kind of overview as compared to if done manually or paper-based or more memory-based also. Then early signals to timely intervention, that is also a huge advantage, so that we don't miss on things. Like we were discussing GDM, and Dr. Bhavtani, she mentioned that are we missing on the opportunity of detecting GDM early and preventing it? If we make digital protocols which mirror our clinical protocols, probably this would not happen because we would be able to identify the signals early and intervene in a timely manner. So technology, what it can help us with is, if done in the right way, if done in the right manner, it can help us in delivering preventive and proactive care. For the practitioners or clinicians, of course, lifestyle tracking, diet, activity, sleep, stress can be made very simple and easy. Real-time patient inputs and monitoring can help taking the right decisions at right time, so that we are not waiting on from one consultation to another to take those decisions. And also, if it is only done during the consultation, the data input that we get from patients are also filled with recency bias. Automation of routine follow-up, that is as I mentioned earlier, and then we move from episodic care towards continuous proactive care. So not only guidance and education, but continuous care management can be delivered or can be provided by technology. Of course, besides that, holistic disease management, continuous screening for early complications, screening in the sense proactive screening for different kinds of diseases, and including foot ulcer, including retinopathy or neuropathy, or all these comorbidities that we have been discussing. That can be done using technology. And then multidimensional data helps us in establishing correlations and publish research papers, intelligent initiation of reactive and preventive pathways. And that is the future, actually, because today we are thinking a lot about reactive pathways, but as our previous speaker mentioned, preventive pathways will become equally important in future. And that is something we can learn, and the technology can learn. So how does technology help exactly? From data to decision, what is that path? Because today we have a lot of data. Patients have glucose logs, they have BP, they have wearables, lab reports, diet records, a lot of data. Do we have the time to look into all the data is the question. Data alone cannot probably improve outcomes, but if it is interpreted in a structured manner, then it can produce good outcomes. It can deliver good outcomes. So we have to think of, from record keeping, we have to think of decision intelligence, that how can data presented in the right manner can give us decision support. For the clinician, if technology has to work in the right manner, it has to save the consultation time. It has to increase the quality of consultation and not add documentation burden. So for example, if we are talking about quality of consultation, if you have all the data from in between consultations, all the monitoring data as well, then it becomes much easier for the clinician to see what has happened in these 6 months or 3 months in between the follow-up. And if the system is highlighting the risk, the trends, and the deviations automatically, that becomes also so that you don't have to turn 20 PDFs either in form of a printed paper or in terms of WhatsApp messages that have been sent by the patient. You don't have to look into and scroll through a lot of messages to see the comparison of the reports and then make a mental note of it. So if the technology can do that, that makes the consultation quality much higher. And then, of course, supporting the clinical judgment, but not replacing it. Because even today, in the world of AI, we do not have that kind of technology that can support the clinical judgment. Representing data in proper manner is one thing, but definitely in judgment the decisions have to be made by the clinician. Now, the customizability of technology is also key important, where we can customize it to the workflows and the protocols and empower to make the right decisions to extend the services. And of course, measurable ROI, retention, revenue efficiency, some of it has to be there, because if there is no ROI, then it's just a software. And we don't want just software in the system. Like already there is a lot of burden with existing EHR system, existing research, clinical trial systems, whatever software that we use today. But it becomes even more burden if yet another system for patient engagement does not produce the right retention, right revenue, or some efficiency in the process. So technology doesn't have to be necessarily a software. It can be something which assists you in creating good return on investment. And investment again is also your time. There are a lot of times when I've spoken to doctors and clinicians where they always talk about or ask about what is the criteria to build versus buy, because they always think that we can always create an app for our clinic or our hospital or chain of hospitals. Isn't that more beneficial than getting something which is already pre-built? And just to share some perspective on this, um, it's really important to understand that building a customized platform could be a good idea, but it's not always the best idea when we think of, first of all, the upfront investment in it. But the most that hurts afterwards is the maintainability. The maintenance of it, having employees doing that, it always becomes a hassle towards, and then the platform is not managed and not upgraded, and then becomes stale over time. So that's where I personally feel, and I'm biased a bit because I've done this digital projects and implementations all my life. But I feel that having a digital platform which is maintained and managed by someone allows you to focus on patient care, and then your attention to patient care increases, or at least is maintained, and no distractions are there in order to make decisions on it. So that is an important aspect in making this decision. But of course, the choice, there is always a choice. One thing that also Dr. Bhavtarni and Dr. Deshmane both mentioned or highlighted on is one size does not fit all. Every patient is unique, every clinic has different protocols, and technology must be good enough to adapt to these care teams, to these care protocols, not the other way around. So if your care delivery system, if your patient engagement system is able to mirror your protocols, that gives a strength of your learnings, your experience, the way you want to work with your patient. It makes it possible. Because it's a dynamic world, the patients are dynamic too. Therefore, the technology that you use should be dynamic as well. This is the last slide, I think. But yeah, the benefits of right technology is that we as clinicians are able to manage the patient, use time on managing the patient rather than focusing on building technology, maintaining it, removing WhatsApp mental burden, because I think that there are some clinicians who are getting 400 messages a day on WhatsApp and have a clinical staff addressing those messages. There are clinicians who are getting many calls during the day from their patients. And in order to retain the patient, in order to have them have good, healthy, satisfied patients, they try to do as much as possible. And that's where, it becomes a mental burden and can be totally removed if you have the right technology and the right patient engagement system. Enable research and evidence creation is another thing, which becomes very easy with the data that you collect over time. So start today rather than tomorrow, because every day is a loss of data in terms of creating research data and evidence. And community can be used for motivation of the patient, but we also heard very good talk around how else the patient can be motivated. So I would not go much into that. So yeah, patients need the right guidance at the right time, and technology can support that timeliness. I see that Dr. Hitesh is turning on video. I think my time is up, or if I'm exceeding, just let me know. I'll just quickly wrap it up.
Oh, it's nothing like that. It was really great to hear you. I was getting in time, just live slide. It was really important what you told, AI and whatever technology we're going to be getting diabetes is going to help our patients. And with time, we have already realized that technology has already gotten into us. We have retinal scans with the help of technology. We have CGMs, we have automated devices. And sooner or later, we will be having this closed loop system coming very soon. So it was amazing to listen to you, and always great to listen to your ideas, which can help you develop technology. Thank you, Kushal.
Thank you so much. Thank you, Dr. Hitesh, and thank you everyone for the opportunity.
For the next topic, we love to have the introduction slide for none other than Dr. Jyoti Dev sir. Hello.
Can I interrupt for 1 minute, RX team as well?
Yeah, sure.
So we have Dr. Ravindran with us as well right now. Can we, with the permission of our chair, Dr. Nimi and Dr. Hitesh, can we have Dr.
Yeah, sure.
Ravindran sirs first and then Jyoti sirs?
No
Maybe
issues, no
then
issues.
Jyoti sir will get a little free and we can have him as well for the discussion.
That will be great.
Thank you.
Can we have Dr. Ravindran's slide? Welcome, Dr. Ravindran. He's our international faculty from Oman, and he will be speaking on Sir will be speaking on adiposity-induced metabolic dysfunction associated diseases. Can we have his slide, introduction slide for Dr. Ravindran?
RX team, please.
Hi, Dr. Dhruvi.
Hello, Dr. Hitesh.
Doing great.
Thank you. Thank you.
Thank you for inviting me, Dr. Vipul and Dr. Dhruvi, and obviously thanks to Dr. Bansi sir.
We are actually feeling very bad that we can't have all our friends with us in person. Next year we are trying to have it a little better plan. Friends from Oman, Dubai, as well as from all over India. At least we can get together.
Who knows, next time Dr.
Nice.
Will plans it in Dubai. He might plan it in Dubai itself.
God willing, yes.
Yeah.
Yes, absolutely.
Is Dr. Ravindran online? I think
yes, Dr. Ravindran sir is here. RX team, if you're listening to me, this is not what I asked and requested. Mahima, Nankishorji, please have the introduction slides of Dr. Ravindran sir, please. Yes, that's how it is. Thank you so much. Dr. Hitesh, over to you.
It gives me great pleasure to introduce Dr. Ravindran. He's an alumnus of the Government Medical College, Kozhikode and KIMS Tumli. Worked as an assistant professor of medicine, Government Medical College, Kozhikode. Currently working as a specialist in internal medicine at Badr Al Sama Hospital, Sultanate of Oman. He has published more than 35 articles in various national and international based journals. He has wrote more than 150 health education articles in various health magazines. He has presented papers and posters at various national and international conferences, including the IDF Conference, Epicon, IMS Forum. He is a recipient of prestigious Dr. Apam Samuel Award of IMA Kerala State for Best Research Article. He is a recipient of prestigious National IMA Dr. D.S. Mangeshkar Award for Research. He is a recipient of prestigious JPEF USB Diabetes Tech Innovation Award. He is also a fellow of Royal College of Physicians and also fellow of Diabetes India. I'd like to welcome Dr. Ravindran. Sir, stage is yours. I think he's not clear.
No, sir is here. We have his recorded lecture also. Sir is here for the discussion. Mahima, can I request you to play his recorded lecture, please? Yeah, thank you. Thank you, Nankisha. Please do that.
People for this wonderful opportunity. I'll be directly going to the topic, adiposity-induced metabolic dysfunction associated disease, a practical approach to comprehensive metabolic care. I'll be discussing under the following headings: introduction, about personal fat threshold, adiposity-induced metabolic dysfunction associated disease, or AMADs, organ or system-based classification of AMAD, and conclusion. Obesity is a chronic and multifactorial disease. It has become a worldwide epidemic with devastating health and economical consequences. Obesity affects essentially every organ system in the body. Obesity is a risk factor for many morbid conditions, the most impactful of which are type 2 diabetes, hypertension, dyslipidemia, cardiovascular disease, and some cancers. Obesity also directly decreases the life expectancy. Coming to obesity and AMAD. Obesity is an anthropometric term that indicates excess fat deposition in the body on various measurements, including body mass index, waist hip ratio, waist height ratio, or direct measurement of the body fat using radiological methods. Excess fat deposition leads to organ dysfunction, and this is called adiposity-induced metabolic dysfunction associated disease. So obesity is accumulation of excess fat in the body, and when this leads to organ dysfunction, it is called adiposity-induced metabolic dysfunction associated disease. Previously, obesity is considered both as a risk factor and as a disease because of the lack of appropriate terminology to denote both. When excess fat accumulation reaches a particular stage, it affects multiple organ systems, producing various manifestations in the involved organ, leading to its dysfunction. So the risk factor has to be differentiated from the disease stage with proper terminology, and the term AMAD will help for it. AMAD is defined as a multi-system disorder with varying manifestations in different organ systems due to excess fat accumulation above the personal organ-specific fat threshold and resulting in pathophysiological changes with potential for remission with weight loss. As we all know, with weight loss, there is improvement in various associated conditions like insulin resistance, dyslipidemia, hypertension, etc. And with further weight reduction, there will be remission of type 2 diabetes, hypertension, metabolic dysfunction associated steatotic liver disease, and sleep apnea. With further reduction in the body weight, there can be prevention of development of malignancy and cardiovascular disease in people with high body weight or excess fat deposition. And as we all know, the excess fat deposition can affect various organ systems in the body, including brain, head to foot, all the organs. Like it can cause migraine, pseudotumor cerebri, obstructive sleep apnea, dyslipidemia, non-alcoholic fatty liver disease, which is renamed as metabolic dysfunction associated fatty liver disease, type 2 diabetes mellitus, polycystic ovarian disease, venous stasis, bronchial asthma, cardiovascular disease, hypertension, GERD, infertility, stress urinary incontinence, peripheral arterial disease, degenerative joint disease, gout, etc. So, excess fat deposition leads to various disease. Coming to adiposity-induced metabolic dysfunction-associated disease. Chronic fat accumulation results in a spectrum of disease with varying manifestation depending upon the organ loaded with fat. Chronic excess fat accumulation is termed as obesity, which has been in use for decades, and the organ dysfunction due to chronic excess fat accumulation is called AMAD. AMAD includes a spectrum of disease with varying manifestation depending upon the predominant organ system affected and share overlapping features because of other organ and system involvement. It's common to see more than one metabolic dysfunction associated disease in a single patient. The common pathophysiology and treatment approach helps to tackle all these abnormalities together rather than treating them as individual disease. This is the diagrammatic representation where you can see with chronic excessive fat accumulation, there is progressive increase in weight leading to development of AMAT and development of obesity and subsequently dysfunction of adipose tissue, that is adiposopathy, leading to development of AMAT. And so in the initial stage, the excess body weight or excess fat accumulation or obesity act as a risk factor, but it progresses into a disease stage called AMAT, which has got two stages, preclinical and clinical stage. So the advantages of using this new terminology, AMAT. The term obesity gives an impression that it's only a disease of excess body fat weight or excess fat accumulation, but in fact it is not. It can affect all the organ system in the body, leading to various disease process. Obesity is associated with common lifestyle disease like type 2 diabetes, hypertension, dyslipidemia, etc. The individual disease approach is replaced by overall risk reduction and organ protective approach and early metabolic care that indicate our knowledge about the pathophysiology of the illness. Multi-directional interaction between excess weight gain, metabolic disease such as type 2 diabetes, cardiovascular disease, and chronic kidney disease is well established. Cardiovascular and renal complications are integral part of the metabolic dysfunction and type 2 diabetes. And long-term remission of obesity associated condition is achievable with weight reduction. Weight reduction is associated with improvement or remission of type 2 diabetes, hypertension, dyslipidemia, metabolic dysfunction associated fatty liver disease, and other obesity associated conditions. Twin cycle hypothesis, that is chronic excess fat accumulation, leads to hepatic and pancreatic dysfunction, leading to development of type 2 diabetes mellitus, establish the link between obesity and type 2 diabetes. The strong pathophysiological link between diabetes and obesity is well described by the term diabesity. Type 2 diabetes in people with normal body weight and even in lean individuals develops when the personal fat threshold is crossed. Thin fat obesity indicates that even in people with normal body mass index can have increased fat deposition in the visceral organs. The term for non-alcoholic fatty liver disease has been updated to metabolic dysfunction associated fatty liver disease or metabolic dysfunction associated steatotic liver disease, and our new terminology that it is adiposity induced metabolic dysfunction associated disease echoes with the same pattern. The new terminology reflects the pathophysiological basis of obesity associated disease. Coming to personal fat threshold. Personal fat threshold is defined as the level at which a person can no longer store fat in the subcutaneous adipose tissue, or it is the amount of fat a person can store safely before it starts to spill over into organs like liver and pancreas. In other words, it shows the individual's variability in adipose tissue function and fat storage capacity. At this stage, it gets deposited in the visceral organs, leading to various organ dysfunction, including type 2 diabetes. So personal fat threshold is different for different individuals. This is the diagrammatic representation of the same, where you can see the chronic calorie excess lead to chronic excess fat accumulation, and it's deposited in the subcutaneous adipose tissue first, and when it crosses the personal fat threshold, it spills over into other visceral organs and leading to fat deposition in the abdomen and visceral organs. And initially, it will be asymptomatic. When the fat deposition crosses personal organ-specific fat threshold, symptoms start develop. So this early stage is called preclinical stage. And when it crosses the personal organ-specific fat threshold, it's called clinical disease, where it becomes symptomatic. So personal organ-specific fat threshold. There are different thresholds for different organs to manifest the problem of fat accumulation, and that is called personal organ-specific fat threshold. Personal organ-specific fat threshold is defined as the level at which a person can no longer store fat in a particular organ without affecting its function. Personal organ-specific fat threshold varies from individual to individual, and hence it is called personal. It further varies from organ to organ in the same individual, and hence it is called organ-specific. Each individual has a threshold for ectopic fat accumulation in various organs, beyond which organ dysfunction emerges. And this is the personal organ-specific fat threshold. This concept builds on the personal fat threshold hypothesis by adding organ-level specificity. Variable distribution of fat in different organs and different personal organ-specific fat threshold leads to various phenotypical manifestations of AMAD. The concept of thin fat obesity clearly indicates that even in people with normal body mass index can have increased fat deposition in the visceral organs, and when it exceeds the personal organ-specific fat threshold, they develop organ dysfunction, including diabetes, depending upon the organ fat accumulation status. Thin fat phenotypes and normal weight or lean type 2 diabetes clearly demonstrate that intra-organ fat accumulation, irrespective of total body weight, is the driving force for various organ dysfunction, including diabetes. So the fat accumulation in various parts of the body is not uniform. It varies from person to person, depending upon the predominant organ where excess fat accumulates, the personal organ-specific fat threshold of the individual, the disease manifestation varies. Hence, people with chronic excess fat accumulation develop different disease according to the distribution of the fat, independent of total body weight or body fat percentage. In addition to that, systemic effects of adiposity, like chronic inflammation and hormonal changes, affect remote areas also, away from the organ overloaded with fat. The pathophysiology of adiposity-induced disease spectrum involve one or more of the underlying mechanisms of fat accumulation, like ectopic fat deposition, insulin resistance, hyperinsulinemia, low-grade inflammation, mitochondrial damage, dysregulation of adipokines, and endothelial dysfunction. The threshold for fat deposition and fat distribution is influenced by various factors like age, sex, genetics, hormonal status, etc. Depending upon the stage of the organ dysfunction, it can be the preclinical or clinical stage of the disease, as we have already seen in the previous diagram. The clinical stage can be uncomplicated, complicated, or sequelae of the underlying dysfunction. Remission of organ dysfunction is clearly demonstrable in the early stage of the disease, when the patient achieves significant weight loss. Control of organ dysfunction, improvement in the quality of life, and arrest of progression of organ dysfunction is possible at all the stages of the disease, indicating the importance of achieving weight reduction at all the stages of the illness. So this is the diagrammatic representation. Again, a normal individual with chronic excess fat accumulation develops adiposity without any disease, and once the adipocyte dysfunction occurs, that is adiposopathy develops, they develop AMAD, that is adiposity-induced metabolic dysfunction-associated disease. And AMAD consists of various manifestations of excess fat accumulation in different organ systems in the body. So this is the classification of AMAD, organ system based classification. So it can affect the endocrine system, so it's called metabolic dysfunction associated endocrine disease. If it affects the cardiovascular, it is called metabolic dysfunction associated cardiovascular disease, gastrointestinal disease, hepatobiliary disease, neurological disease, genitourinary disease, circulatory disease, respiratory disease, musculoskeletal disease, etc., depending upon the organ system involvement. And under these, the various categories comes. Here you can see the metabolic dysfunction associated endocrine disease. There are various endocrine abnormalities associated with AMAD. Type 2 diabetes is one among that, but based upon these concepts, it's better to rename type 2 diabetes as metabolic dysfunction associated hyperglycemic disease. Similarly, metabolic dysfunction associated hepatobiliary disease, one major disease entity is metabolic dysfunction associated fatty liver disease or metabolic dysfunction associated steatotic liver disease, which was previously called as non-alcoholic fatty liver disease. So our terminology echoes with the new terminology for non-alcoholic fatty liver disease, that is metabolic dysfunction associated fatty liver disease. So it indicates the pathophysiological process also, and it also indicates that the disease stage is reversible with significant weight loss. So metabolic dysfunction associated hyperglycemic disease is the new terminology for type 2 diabetes mellitus. Advantage of the new terminology of metabolic dysfunction associated hyperglycemic disease, the new terminology reflects the pathophysiological basis. The new terminology echoes with the existing terminology with similar pathophysiological mechanisms like metabolic dysfunction associated fatty liver disease. It helps in early diagnosis of other component of AMADs because patients with type 2 diabetes will be having fatty liver or other dyslipidemia, hypertension, cardiovascular illness. So it helps in the early diagnosis of other components of AMAD because it groups all the currently considered different diseases with the same pathophysiology into an umbrella of a single disease, that is AMAD. And it helps in multidisciplinary collaboration and holistic care. So it reflects the interconnection between various metabolic disease, CKD, cerebrovascular disease, necessitating early screening for associated problems. It also helps to differentiate other types of diabetes mellitus with a different pathophysiological mechanism into different categories from those associated with metabolic dysfunction, that is type 2 diabetes mellitus. So implementation of the terminology change occurs through various stages like educational phase, where we have got educational activities for healthcare professionals and patients and for the public. Use of dual terminology, use AMAD, formerly known as obesity, or MAHD, formerly known as type 2 diabetes, then fully replace the terminology like type 2 diabetes with MAHD or obesity with AMAD, and integrate the terminology shift with allied areas and stakeholders engagement for guideline and endorsement. So to conclude, obesity is the mother of all adiposity-induced disease. Adiposity-induced metabolic dysfunction-associated disease is a disease due to excess adiposity. AMAD groups all the currently considered different disease with the same pathophysiological mechanisms into an umbrella of a single disease. This helps to evaluate and manage all these diseases as various manifestations of the single disease called AMAD. And we published all these in the World Journal of Diabetes in this article, Type 2 Diabetes Mellitus, isn't it the time to update the terminology? And the article is freely accessible online. Thank you for the patient listening.
Thank you, Dr. Ravindran, for that beautiful lecture. As you rightly stated in the conclusion slide, that adiposity is the mother of all metabolic diseases. And your paper on this is really wonderful. So I would like to ask you one question, sir. Considering obesity, like if you want to change the terminology, from type 2 diabetes. Am I audible, sir?
Yes, sir.
Yeah, so I was saying, like, if you're considering changing the name from type 2 diabetes, you metabolic um, associated hyperglycemia. So how does it make a difference to the treatment? Because once we consider a name change, does it make a difference to the treatment?
It will make a change in the treatment also, because now what we are doing is type 2 diabetes is treated by either diabetologist or endocrinologist. Fatty liver is treated by a gastroenterologist.
Gastro.
And all the individual diseases are compartmentalized into different specialty, and patients are not getting a holistic care. So once we classify all the disease due to adiposity into a part of a single entity, instead of compartmental care, we can give a holistic care, like a metabolic approach to manage all these diseases, rather than managing single disease as a single entity. Like previously, diabetes mellitus treatment was glucose-centric approach, which was changed to metabolic care in the recent years, and we are aiming to correct the metabolic abnormalities, not only to bring down the blood sugar value to normal level.
That we have seen in our practice since the advent of GLP-1 easily available to our patients also. We have seen that patients are getting in remission and their drugs are reduced to half, or somebody is off insulin, those who are unable to control their sugars. You're absolutely right, sir. I have one question do we have Dr. Dharmendra still online?
Dharmendra Bhai was here just a minute ago.
And what about Miss Khushbu? Is she still here or she's also offline?
Khushbu is also, Khushbu is here.
Yeah, good.
Yes, I am here. Yes.
Yeah. Just have one more question for you. So, how do you see diabetes technology evolving over the next 5 years to bridge the gap between advanced innovation and real world affordability and accessibility in countries like India? Since you're working in Denmark, everything is way above beautiful and easily available. So, in our country, how could you implement this technology driven diabetes care?
Yes, thank you so much for that question, Dr. Hitesh. I think it's a very important question. And one of the points that you mentioned is the key for technology to succeed in diabetes management or diabesity management, affordability. How do we make technology affordable? Today, we are having so many AI assisted solutions, but unfortunately, AI is still expensive. So with time, I think we what we need to do is to have scalability in these AI solutions at a level where AI can be useful for both doctors and clinicians. And then besides AI, make the digital data fundament, which is available for everyone, general availability of that. So that is why, for example, when we design platforms like this, digital platforms, what we do is we always take care of this fundamental value proposition is really good towards the doctors and patients, and it is not it is not unaffordable to any segment, so that we can also reach the last mile using technology, and that is what we aspire for. So yes, it is the key to succeed in diabetes management.
Thank you, Doc. Thank you, Mr. Yu. You're absolutely right. We have a lot of data, and that data need to be somehow synthesized and coming with the phenotypic and genotypic whatsoever person-based treatment. Great. Dr. Dhruvi, do we have Dr. So, but still, it's going to be a challenge in India to do that, because once you're coming from a government setup, then you realize what it means to do practice there. In private setup, it's still easy to implement all this AI-driven things, but in a government setup, it will take, I think, a decade more, it seems.
And there I can tell you that yes, we are also involved in some government hospitals. So there I must tell you that the hospitals are not that behind. They are catching up, and the adoption, fortunately, in our country is so fast. Yeah. So the adoption is also quite fast in even in rural and remote areas, Dr. Hitesh. So it's going forward, actually, at least.
Yeah, with you carrying the ship, everything will be fine.
Thank you. Thank you so
Dhruvi,
much.
Dr. Dhruvi, do we have Jyoti, sir?
No, Jyoti sir is still gonna take a little while, and that is why I'm going to request Dr. Rikin to introduce Dr. Viral sir. I understand he was in the next session, but let's keep Jyoti sir in his place and he in Jyoti sir's place, and let's take it up because Viral sir is here live with us all the way from US. So
Yeah.
if again you guys are the chairs.
Yes,
Yeah,
very
sure.
good
We can.
afternoon, everyone. Thank you, Dhruvi. I hope everyone had tea. So this obesity symposium is going to continue with our international speakers. But now we are shifting from type 2 to type 1 diabetes, as Dr. Viralsa is highly interested in this subject. It is honor to invite Dr. Viralsa. Sir is a professor of medicine in division of, can we have intro slide? In division of endocrinology and metabolism, and director of diabetes clinical research in Indiana Center of University. He is internationally recognized researcher focused on improving glycemic control and reducing complications, particularly in type 1 diabetes. Sir currently serves as the chair of Diabetes Technology Interest Group and a member of 83rd and 84th Scientific Sessions Planning Committee at ADA. Sir is recipient of multiple awards, including as Rising Star of Endocrinology Award, ADA Diabetes Technology Interest Group Award, Diabetes Technology Society Leadership Award, JDRF Mary Taylor, and MD Excellence Clinical Research Award. Sir is editor-in-chief of many journals, including Clinical Diabetology, Endocrine Connections, and board member of Diabetes Care and Journal of Diabetes Science and Technology. Dr. Viral Sai is highly recognized academic author with over 170 clinical research papers with insighted reviews, editorials, and book chapters. So it is honor to invite Dr. Viral Sai. Sir, please proceed ahead. Sir is taking use of GLP plus GIP in type 1 diabetes.
All right. Thank you so much. Thanks, Dhruvi, for the invitation. Appreciate changing the schedule because I have to leave for a next meeting in about 30 minutes. So give me 1 second while I share my screen.
Yes, sir.
Okay. All right. Great. Thanks. Yeah, my request to the chair and all of other faculties, stop saying sir, it's too British. I think we gotta change that. We are all colleagues. We all learn from each other. So I'm assigned a talk to speak on the GLP in type 1 diabetes, and you will be wondering why GLP in type 1 diabetes, because type 1 diabetes is traditionally managed through insulin since 1921. There is nothing else versus in type 2 diabetes, you have a new drug every couple of years, right? So I will try to convince a little bit. Here are my disclosures, and the marked in red are relevant to this presentation because the trials that I'm going to speak is some of them are actually funded by Breakthrough T1D, which is formerly JDRF, Novo, and Lilly. So the contents of my presentation today is focused on the three brief points. The first part that I will talk about why I'm talking about GLP in type 1. Why do we need that? The second part would be more of a what are the options we have besides insulin? And do we have any evidence to use GLP in type 1 diabetes? And then we'll touch on a practical aspect of using GLP in type 1 if you would like to use in your clinical practice. So let's jump to the first part. Why do we need adjunctive therapies in type 1? And I'm being very careful here that I'm using this word adjunctive because insulin still remains the treatment modality, the first line of treatment in type 1 diabetes. So anything that you use in type 1 diabetes is not going to replace insulin. It's going to supplement insulin. That's why I call it an adjunctive therapies. And that's what the ADA suggests, right? So ADA standard of care says that the insulin is the mainstay of treatment in type 1, and the best way to give insulin is actually automated insulin delivery system. So in India, you have a Medtronic 780G. US has 5 options at this moment, and Europe has actually even more options. But any form of an AID is going to be the standard of care in managing type 1 diabetes. But the problem is that even though if you use the AID in people with type 1 diabetes, not that everyone is going to achieve the best outcome. So this is a study that we published a couple of years back. We looked into about 3,000 individuals with type 1 diabetes in a single center. And what we looked at that how many people are achieving an A1C of less than 7%, which is considered as a recommended goal, when they use let's say, for example, CGM, which is in a kind of an orange bar, compared to those who are not using CGM, which is a green bar. So think about 2021. Now, again, this is a 5-year-old, so I'm sure this study is, if you do it now, it will be much better. But people who are doing an SMBG, meaning by that finger stick glucose to manage type 1 diabetes with insulin, about 15% will have an A1C of less than 7%. And if they start using CGM, that percentage will go up to 44%. So definitely CGM makes a big, big difference. And you do have a Abbott Freestyle Libre, I think version 2 available in India, and I would highly encourage to use CGM as much as possible. And then if you add automated insulin delivery system on top of that CGM, then that improvement goes up to the 51%, right? So of course, automation helps, but the automation does not help everybody with type 1 diabetes, right? I would wish that everyone with type 1 have an A1C of less than 7%, but that's not the case. And the reason behind that are many, but one of them is that the AID does really good job when you don't eat, when you are sleeping. It's not that great still during the day-to-day life when people are active, when they are exercising, when they are eating. Because there are a lot of challenging factors that makes the AID system challenging to work during those circumstances. This is probably more pertinent to the developing world, more so in the US, but I think I can see that every time I fly to India, I do see that this problem is coming as well there, that overweight and obesity is increasing in general population, and type 1 diabetes is not an exception. In the past, we used to say that, hey, lean and thin type 1, the big obese type 2, not anymore. We see people with type 1 diabetes with a BMI of 40 and 50 here all the time. So it's not something unusual for us to see that. So this is an US national database. And if you look at that, the prevalence of overweight and obesity in type 1 diabetes is equivalent to that of a general population. Okay. Type 2 diabetes is still a little bit higher than type 1 diabetes for sure, but type 1 is equivalent in, in terms of the general population. The other factor is that if you do insulin and if you try to achieve everybody with type 1 diabetes an A1C of less than 7%, that's good. It's going to reduce the microvascular complication, but it's unlikely to reduce the macrovascular complications. So this is 2 studies. I'm going to skip that part. Published in New England Journal of Medicine a few years back from a Sweden registry. And what you're seeing here is that the people who have an A1C of less than or equal to 6.9%, which is less than 7%, they still are dying from any cause about 2 times higher than the general population of people who do not have diabetes. And most of those deaths are attributed to the cardiovascular death, which is about 3-fold higher than general population, right? So that's a pretty high. And think about that. These are people with an A1C of less than 7%. That's what the recommended goal is. And if that's the case, that means that despite you try your best with the AID or other form of management, It's going to be great in reducing microvascular risk, improving the longevity, but I think you're going to see a lot of cardiovascular mortality in people with type 1 diabetes. So definitely we need something beyond insulin in type 1 diabetes. So what do we have if you think about other than insulin? And I think we wrote this review article. If you would like, you can read that part, which summarizes all these different therapies that have been tried in type 1 diabetes. And we focused on those type 2 related therapies that have been tried in type 1, not something that like a stem cell transplant or cellular therapy or gene therapies. But if you think broadly that the metformin is the most commonly studied or most studied drug in type 1 diabetes. The literature has been very neutral. And so in my personal opinion, I'm not a big fan of metformin, neither in type 1 nor in type 2 diabetes. DPPs are neutral as well, not studied very well in type 1 diabetes, but the earlier study did not show much improvement. And so that's why there was no enthusiasm to study DPP-4 in type 1 diabetes. SGLT2 is a great drug for people with the heart failure, CKD in type 1 diabetes. We use that off-label all the time. The problem is that it increases the risk of euglycemic decay. So you have to be aware, you have to educate your patients about that part. But I would highly recommend that if someone does have heart failure or CKD, once they have an EGFR of less than 60, microalbuminuria persistent after AC or ARB in type 1 diabetes, we prescribe SGLT2 inhibitor, and we generally do in a low dose because the evidence suggests that the low dose is generally okay in type 1. We don't have a lot of evidence, but I think whatever we have, I think sounds like a promising. So that leaves us with the GLP. And I think if you think about the GLP, liraglutide was tried first in type 1 diabetes. These are called adjunct 1 and adjunct 2 studies. I'm sure you guys are aware about that part. That study failed to show a statistically significant difference or in A1C by more than 0.4 that is required by the regulatory agencies for efficacy criteria. And so there were multiple problems with this study. I try to highlight them in red, but with the respect of time, I will skip them here. But I think I call this as a learning. There is no failure in a science. We learn, and I think what we learned is that we made some mistake that we should learn from when we conduct future clinical trial. So a few things we learned from an adjunct 1 and 2 were that the CGM is essential in type 1 diabetes when you want to consider GLP. If you consider GLP without CGM or AID, people are going to have a lot of hypoglycemia. Insulin dose titration is essential. I would say it's a must. So you have to see patients more frequently in your clinic when you start them on a GLP-1 analogs. People with the lower BMI don't tolerate GLP-1 very well. So in type 1 diabetes, the dose should be much lower than the dose that we use in type 2 diabetes and obesity. I don't understand that fully why, but I think, and also to me, I think I'm not sure whether it's a physiological reasons or it's the patient's perception of tolerating the drug because they would like to lose the weight compared to that motivation is going to be less in people who have normal body weight. But again, those could be multiple factors. So we learned a lot from liraglutide trials. We implemented our learning into a newer trial. And so this is the first double-blind randomized controlled trial of semaglutide in people with type 1, was published in New England Journal in Evidence. What we did is that we look at the people with type 1 who had a BMI of more than or equal to 30. So everybody had an obesity, had an A1C between 7 to 10. They were randomized to receive an semaglutide versus placebo. Now, this was double-blind randomized controlled trial. So patient didn't know, physicians didn't know, and they received that drug for 6 months. The primary outcome of this study was very unique, and to my knowledge, no one had similar type of a primary outcome. So we designed this study with the primary outcome as that composite outcome of achieving all 3 endpoints. So I'm going to say all 3, not just the one of 3. And that criteria is if you have a time in range more than 70% without time below range of more than 4%. So think about that part. We wanted to have a holistic primary endpoint. If you have a great improvement in time in range, but you have a lot of hypoglycemia, that's not good, right? So that's why we had this mandatory condition that the people has to achieve more than 70% without increasing time below range and weight reduction of at least the 5% compared to their baseline weight. So if someone is 100 kilogram, they must have at least 5 kilogram weight loss by the end of the trial, along with that improvement in time in range and without time below range. So 36% of people in semaglutide arm achieved the primary endpoint and 0% in a placebo group. This was the powerful because if you look at that number needed to treat, meaning by that how many people if you give a semaglutide would benefit is 3. So number needed to 3 is 3. So if you have in your practice, if you give a semaglutide to 3 people with type 1 diabetes, 1 person is going to achieve similar outcome. Significant reduction in the A1C. A1C was reduced by 0.8%. Now remember that these people had a good A1C to begin with, so it's not like a terrible control. So it's pretty marked reduction in the A1C and similar improvement in time in range, time above range, reduction in the time, time in range, time in tight range, and then reduction in the time above range. So it's all in line of what we see in terms of the A1C reduction. The weight was down by almost 9% from their baseline weight, which is a very similar if you compare that with the type 2 diabetes or obesity trial. Now, again, these are not head-to-head comparisons, but it's kind of a, and kind of an estimated comparisons. And it sounds like this drug works very similar in people with type 1, type 2, and the obesity space in terms of the weight reduction. The other thing I want to make you notice that the A1C reduction is a drastic within the first 8 weeks, meaning by that it's about 2 months. And after that, the further reduction is not seen much. So, and after about 3 months, you see that there is no change in the A1C. Okay. Versus in a weight, there is no plateau effect, meaning by that the weight loss persists for a longer period of time than the plateau achieved in a glycemia. So the glycemic effect of GLP-1 analog is different than the weight loss effect of GLP-1 analog. Number of adverse events, we didn't see any signal of increasing risk of severe hypoglycemia or DKA. Of course, the GI events were higher, which is expected in GLP-1 in any trial. The insulin requirement was reduced by 30%. So let's say if someone used the 50 units per day, they're going to have a 15 units per day reduction in their insulin requirement. And the insulin requirement reduction was independent of weight loss. And you observe that with the first dose of semaglutide, that's a 0.25 milligram, where you don't have a weight loss. So that's an interesting. So when you start GLP-1 in any people with type 1 diabetes, make sure that you reduce their insulin by about 20 to 30%. Otherwise, they're going to have a lot of hypoglycemia. Similar data has been published in tirzepatide, which is a dual GLP-GIP analog. Very similar, I would say. Of course, I would expect more weight loss with the tirzepatide than semaglutide. That's known. That's no surprise. But the glycemic effect would be very similar between two drugs. So this is from Australian group. They are still doing this as an extension of the TERTILE trial, and there are a few more real-world studies published both with the semaglutide and tirzepatide with pretty similar findings. So I think we have a confidence on the evidence of GLP in a type 1 diabetes. So from an Indian context, my 2 slides of a practical consideration in case if you are interested in using this molecule, who is the ideal candidate? Now, I would be cautious in using in everyone with type 1 diabetes because this is something that could be risky, may not be for everyone, but at least the people who are already on a CGM, they are struggling to achieve their A1C, have a BMI of more than 23, or already have a CVD. I think I would consider GLP. Which GLP to consider? I think I would consider semaglutide if you think about the cardiovascular or glycemic effect. But if you think about the weight loss, if you have someone with a BMI of 35 or 40, you know the primary desirable goal of weight loss, then I would use the tirzepatide over semaglutide because you have a great weight loss data with the tirzepatide. How to start? I would say that start with the lowest possible dose, and I will talk about that nowadays in US we call it a microdosing. What microdosing means that you use the dose that is not approved by the US FDA. And again, I will talk about that in a second. Make sure you reduced your dose by about 20 to 30% in terms of the insulin, whether it's a pump, whether it's a multiple daily injection. Make sure that they are on a CGM because the titration of insulin by looking at the CGM data would be more clinically meaningful and efficient. Make sure you educate them about the risk for severe hypoglycemia, ketosis. Now, ketosis is not exactly DKA, but these people are going to have some kind of a GI effect. So they're going to have a nausea, sometimes vomiting. So they're going to develop a starvation ketosis, right? So that ketosis, don't confuse that with DKA, but the ketosis going to happen. So you have to educate these people about checking their ketones, drinking a lot of fluid, make sure that you give them a Zofran in case if they have a lot of nausea. Educate them about not eating an oily food while they are taking a GLP-1 analogs because then they're going to make them more nauseous and may not be the best. So these are some of practical considerations. So this is a one thing that, it's published in Diabetes Care. The reference is in front of you. This is what we do in the US in most people with type 1 diabetes nowadays is that we do microdosing of this drug. So now this is different probably in India. I'm not aware about that part. You have to figure this out, your own schedule of dosing. But in US, you have a 0.5 milligram pen, you have got a 1 milligram pen and 2 milligram pen. And this is just the one example of a 0.5 milligram pen. So in a 0.5 milligram pen, you have a total of 72 clicks to achieve that 0.5 milligram of the dose. So you can now make up your own judgment that if you do 36 click, it's going to be 0.25. And if you do 18 clicks, that's going to be 0.135 roughly, or 12.5, right? So it's going to be 13. And then if you do 9 clicks, then that's going to be 0.06 milligram. Often I do start now. Most of the time when I start in people who already have an overweight and obesity. Then I would start with the 0.25 milligram directly. But if you are starting someone with a normal weight because of the cardiovascular risk, renal risk, or some other factors, then I would start with about 9 or 18 clicks, depending on what BMI they are at, how sensitive they are. Now, remember that we do not have any evidence that this kind of a microdosing is going to be effective in terms of the glycemia or cardiovascular risk reduction. But the idea here is that the start slow so that the people can tolerate this drug. They don't have a lot of weight loss. And then you up titrate slowly and gradually to a dose that has been shown effective for both glycemia as well as the cardiovascular risk. So that I think I will end my presentation and summarize that I think GLP has a promising mechanisms and effectiveness in type 1 diabetes. A lot needs to be learned, and I think there are a lot of studies going on right now, including the FDA approval trials with the tirzepatide in type 1. So I will not be surprised that by 2027 that we will have GLP approved for type 1 diabetes in the United States, but that's my prediction. We'll see. Thank you so much. Happy to take a few questions if you have. And again, thanks for being flexible with me.
Thank you. Thank you so much, Viral sir. It was indeed amazing presentation, and we always learn something new from you. And I would like to tell all the faculty that Dr. Viral sir is example of one of the finest human being on the earth. He is highest at the level of knowledge and still so grounded that you feel so much loved whenever you are around him. Thank you so much, sir, for accepting invitation, being present despite of different time zone, live on the session. And I would like to ask single question that when we are getting GLP effective in obese or double diabetes in type 1, how would be that a combination of GLP and basal insulin for type 1?
So if I understand your question, Vipul, is that so when you start the GLP in people with type 1, I would assume that all people with type 1 do receive both basal and bolus insulin because the basal
Yes,
alone is
basal
not going to be
and
sufficient. So
exactly.
when you want to reduce their insulin dose, you want to reduce both the basal and the bolus. Now, the effect of the GLP in the bolus reduction is going to be more prominent than the basal reduction. So, because of various effects, right? Because it has a good postprandial effect, delay in a gastric emptying. Food is not going to be digested, so you're going to see that curve, shifted more towards the right side. What I would do that, let's say if you are reducing the insulin by approximately 10 to 15 units or so, I'm going to probably reduce about 8 to 9 units on the bolus side and the remaining on the basal side. The caveat here is that if you have someone with an A1C of 8.5, in that individual, I don't want to reduce any insulin because you want to achieve the A1C drop. And so by reducing insulin, you're going to counter the effect of the GLP in reducing A1C. So those individuals, you don't need to reduce the dose. But otherwise, someone with an A1C less than 7.5, then we do about 20% less than 7, then it's about 30%.
Yes, and I'm asking about Iglar, Lixi, or Icodec with same combination used for type 1 diabetic
That
formulation.
is a different question. And so I would say that because you guys know that there are no combinations available in the US, right? So it's hard for us. I don't have any practical experience. I would be a little bit biased in saying that those combinations, and particularly because it's a fixed ratio combination, um, not great to be used in type 1 diabetes because the insulin requirement and needs are so variable that the fixed ratios don't work very well. Would be reasonably well in type 2 diabetes, but not in type 1. I would probably use it separately. Yeah.
Okay, so thank you.
One question and one comment from my side, Dr. Virasa. I think type 1 diabetes is the population who is going to be most beneficial in near 2 to 5 years, as once a week insulin is coming for type 2, probably more going to be approved in future for type 1 also. Inhaled insulin now it is available in India, and even once a week semi is for there. So type 1 diabetes patients might be go needle free. They just might have to take 1 or 2 needle in a week, in a future or near future, when these molecules are going to approve in type 1 diabetes. My question to Dr. Virasa is that, okay, Wegovy is approved in 12 to 18 years age, already US FDA approved, and just recently DGCI approved in India also. So would you recommend use of semaglutide in type 1 diabetes patients less than 18 years of age with obesity?
So we do have, okay, so let me give you answer to your second first and then comment about your first. So we do have a data about GLP in a youth. When I say youth, it's mostly reflective of between 12 to 18 years of age. And we do use that in a limited circumstances. Now remember, I'm an adult and I'm not a pediatrician, so I don't see those people with less than 18 years of age, but my pediatric colleagues would be reasonably comfortable if someone has an BMI of 30 or above in using GLP in that population. There are few concerns. Now, these concerns does not necessarily mean that it's bad. It's just that we don't know right now is that it's a growing age. And nutrition is necessary for growth, puberty. And so you don't want somebody to have such a significant weight loss that there will be delay in a puberty. Or remember that the menstrual period is highly related to the fat mass, right? So uh, there are some concerns regards to that. So we don't have the data, and so that's why it's considered as more of a like just the practical use and more of a clinical circumstances and consideration. To your point about the weekly insulin, I understand enthusiasm around that part, but I don't know that it's the right for type 1 diabetes patients. Why FDA didn't approve it for type 1 diabetes? There are reasons for that, right? In one word trial, there was a significant increase in hypoglycemia in people with type 1 diabetes with the Novo's weekly. I don't know. I think type 1 diabetes needs are very unique, day-to-day need, and think about yourself that let's say if they now go to the hospital for some reason, what you're going to do about their insulin? It's a weekly insulin, right? Or now they decide to go on a pump tomorrow. What you're going to do about that? Or if they are on a pump and they're taking a break and you want to give them a weekly insulin, what you're going to do about that part? There are multiple situations that has not been studied very well. I'm not saying that it will not be used. Of course, we're going to use that as well in type 1 diabetes. A lot of people would benefit from that part, but I don't think that it will be for masses in type 1 diabetes at present. Things will change for sure.
Yes, let's take one last question from Dr. Hitesh. And
I've just a comment to make. Like in DTechCon, we had this Melissa. She's a type 1 from UK, and she was using off-label Monjaro on her. She was actually being double diabetes. And what she showed, like, she has lost 15 kgs of weight, and her insulin requirement has gone way beyond, way down. And she can eat, and she don't have to go for those total daily carb counting and stuff. And she was like, she's more independent now. She just need to be doing her boluses. Otherwise, she used to be frequently thinking about the boluses, and she used to have a lot of hypos and that hunger pangs during this treatment. So it was an experience which she shared with me. Obviously, she used it as off-label. She was getting it through different ways. So exactly in the future is going to help in the double diabetes, no doubt.
Yeah, sure. It's an interesting part to me when people say double diabetes. It's of course it's being recognized as well as an entity by the American Diabetes Association. I would like to ask a question to all of you. What's the definition of type 2 diabetes?
I think insulin resistance, having a...
Do you measure insulin resistance in every single patient in your clinic? But you put the diagnosis of type 2, right?
These patients have acanthosis. I have a few patients of type 1 who is obese and they have developed acanthosis.
Yeah, so again, what I'm saying is that there is not a single diagnostic criteria for type 2 diabetes. Type 2 diabetes diagnosis is a clinician's judgment, and it's a phenotypical diagnosis. Like in a type 1, you have islet autoantibodies that makes your diagnosis of type 1. In a monogenic, you have a genetic testing. In a secondary diabetes, you have a pancreatitis, evidence of secondary things. Type 2 is a diagnosis of exclusion. And it's not there is not a single diagnostic criteria. Insulin resistance is, everybody is familiar with insulin resistance, but nobody knows how to quantify it. And so I feel like that type 2 is not a real diagnosis, and it has various phenotypes within that type 2 diabetes, and it's often being misdiagnosed. And so it's quite possible that all these different types of diabetes spectrum exist in a one patient. And that's what you call double diabetes, or you want to call it other, whatever term, but yeah. But that's my philosophy. All right. Any other questions?
No, it was a beautiful lecture, sir. It was always a pleasure to listen to you and your thoughts.
Yeah, sure. I missed the DTechCon, but probably next year. All right, Dhruvi and Vipul, thanks for the invitation.
Thank you so much. And Dr. Viral, like you see that everybody is really interested into discussing, use of GLP-1s and type 1 diabetes, obese type 1 diabetic. And yes, if you permit us, we could have another session where we just discuss, where we just talk, and where we are able to ask you questions, like this. At your permission, at your convenience, all of us are very, very, very interested into asking you a lot more questions.
Sure. Next time when I'll be in India, we'll meet in person. Okay. All right.
Absolutely.
Take care.
We would. Thank you so much. But thank you for saying a yes to this session, and heartfelt gratitude for you for doing this at a very awkward time. Thank you so much.
No, of course. And I wish you all good success for this conference. Okay. All right, guys.
Thank you. Thank you so
Enjoy.
much.
Bye.
Thank you. Bye-bye.
Yes, thank you, Dr. Viral sir. For our next session, we are going to invite Dr. Katrina Limbert. She is from Portugal. So we are going now. Yes.
Jyoti sir.
Okay. So now next session we are going to invite Dr. Jyoti sir to discuss on this.
And we have Jyoti sir's introduction slide. Yeah. It gives me a great pleasure to introduce the technology man in diabetes. He's been using technology since decades. And the examples which he shares with all of us during his conference is amazing. Sir is the chairman at Jyoti Diabetes Research Center, Kerala. He's editor-in-chief, International Journal of Diabetes and Technology. He is national president, DTech. He's also Central Executive Committee member of RSSGI. He's organizing chairperson of JPEF annual convention for last 14 years. He's managing trustee for P. Kesadev Trust, engaged in charity and literacy activities. He conducts monthly diabetes education via YouTube channels. He has published monthly internet-based free diabetes newsletter for past 16 years. He has more than 300 publications in index scientific journal and chapters in textbook. He is pioneering in cost-effective treatment of diabetes with the use of technology. JDC is an IDF recognized Center for Excellence in Diabetes Care and Center for Education. And JDC is also accredited for the RSSJ certified course in diabetology for doctors. So over to you, sir.
RX events, we have Jyoti sir's recorded lecture, and sir will be with us in the coming 10 minutes. RX.
To Dr. Dhruvi, Dr. Vipul, and the entire team, Practical Diabesity. Of course, we need events like this because there are major existing gaps in the treatment of diabetes and obesity. And the programs similar to this, focusing on the science, delivering the best which is required for the doctors is absolutely essential. So let me start sharing the slides, and this is the topic which is suggested by Dhruvi, and I'll be lecturing on beyond the currently available automated insulin delivery devices. And this is me, and I don't have anything to disclose pertaining to this lecture. No industry support is there, and hence I am independent in my lecture. This is a recent Facebook post. I posted this early this month, in the month of May. And in this post, I have discussed in detail the history of type 1 diabetes in Kerala and how our Keshav Trust has been supporting the children, and how we have formed an organization for the parents and how it has transformed, and how we were regularly educating the people across the state of Kerala on the management of type 1 diabetes. But if you look at the more than 200 or 300 comments, there is something in common. People are now demanding not analog insulin. People are now demanding not just glucose meters and strips. They are demanding as a basic necessity continuous glucose monitoring devices, and for a near normal life for people with type 1 diabetes, they are demanding automated insulin delivery devices. So this is the power of knowledge, but unfortunately we cannot provide because of the high cost involved and the amount of education, the magnitude of training to be given to those who are to be put on these devices. So let me share with you some of the upcoming devices, and this is good news for our country. So if you have been listening to my lectures during the past 2 years, I used to make a promise. And that promise is soon in India, there will be more than half a dozen cheaper but relatively reliable, affordable continuous monitoring devices. And that has become a reality now. So we have more than half a dozen continuous glucose monitoring devices now in the country. And there is a scope for competition as well when the price will come down. And the same I am promising, the same is going to happen with automated insulin delivery devices as well. And this is how you define an AID, where you have an insulin pump, you have a control algorithm, which is actually described as the brain of an AID, and then you have an analog insulin, and then you have a highly reliable continuous glucose monitoring device, and these are the integrated continuous glucose monitoring devices, and they need to be accurate and reliable to be attached to an automated delivery device space. It's very important. What are the recommendations? The recommendations from RSSDA, the recommendations from the Global American Diabetes Association, you have evidence for AIDs to be used in type 1 diabetes, and that is level A evidence. You have level B for type 2. Remember, almost 20% of those with type 2 diabetes also will require automated insulin delivery devices. And that is why I said in the beginning, there are major gaps still in the management of diabetes. We are not able to reach the targets of therapy despite the availability of gliflozins, gliptins, and recently all those mono and dual agonists. And when you are selecting the people, be cautious. When you are able to select a device, go by the individual circumstances, preferences, and needs. You have to consider the duration of diabetes, the type of diabetes, the knowledge status, the health literacy, the digital literacy, as well as the availability of a caregiver at home. So moving on to the evolution in India. And that has been a story lasting for more than 20 years. Whenever I discuss this slide, I always used to express gratitude to Medtronic. Medtronic is probably the only device manufacturer consistently present in India for more than 22 years. And I was so lucky to be part of all these launches from the 2004 onwards. And we started with the refurbishable pumps in India. And in 2006, the first sensor augmented pump. If you closely look at the picture, all these are pictures from our clinics. If you closely look at the picture, you can see the glucose data on the pump screen. And that used to be the continuous glucose monitor in 2006, real-time continuous glucose monitoring. But it was not a completely closed-loop system. We used to call it partly closed-loop. But the 2022 launch of Minimed 780G, it was a game changer. And that is the advanced hybrid closed-loop system. And for us, when we publish this data with more than 80% time in range, it was incredible data of our first 25 patients. And it is definitely a dream come true for people and for doctors, because before 780G, it was never possible. With continuous glucose monitoring, with standalone insulin pumps, with insulin pumps and CGM, reaching a target of more than 70% is not possible in people with long-standing type 2 diabetes, with uncontrolled diabetes despite the currently available therapies, and in type 1 diabetes. If you are to reach your optimal targets, simultaneously avoiding the high risk of hypoglycemia, you require advanced gadgets such as automated insulin delivery devices. If you ask a person who is suffering from type 1 diabetes, they are not concerned about A1C or TR or time below range. Their concern is sleep. And that is a metric for them. Their quality of life depends on uninterrupted sleep at night, which has again become a reality with 780G. And this is that commercially available devices, the landscape of all those devices available globally, of which 780G is the only one currently available in India. And globally, it can get attached to multiple sensors. In India, it is only the Guardian 3 and 4. But you have Simplera from Minimed, You have instinct from the Abbott family lasting for 15 days. And this is the good news. From Asia, soon we will have a patch pump in India. And this is going to be the first ever patch pump to be launched in the country. And this is a picture from our own hospital. And this is how the innovations have been progressing from the first gen to the second gen and gradually to the third gen. And we are currently at fourth stage of second gen innovation in AID. And the fifth generation, that is, the fifth stage of automation, you are supposed to have fully automated closed loop systems only with insulin. And this is the reason why we need to move ahead of HCL. The huge cognitive load upon the patients, they have to be very good in mathematics, assessing the carb content before every meal and then deciding on the dose of insulin, that inequality in the access of these devices, adherence balance, adolescents, elderly, cognitively impaired people. So currently we have multiple challenges using HCL. And many a time, people are actually not reaching a TR more than 70% of multiple reasons. And this is ADF 2025. Last year when we visited, multiple newer devices. And this is a tiny device from the Tandem family, and they call it Tandem Mobi. And this can be operated from the mobile phone. And this is Damiano and me, the creator of iLet. And they are now in the commercial space after many, many years of waiting. The insulin pump is now available commercially, not in India. And they have the real world evidence as well. You can see the difference between the basal A1C and hemoglobin A1C after 2 years. Phenomenal. From 8.9% to 7.3%, improving the quality of life. And this data, even if the hemoglobin A1C is 7.3, it needs to be considered as a robust evidence in type 1 diabetes. A pump which requires only the age and the weight of the person to be entered, and then it is fully automated. Of course, manual bolusing and the meal announcements are there for the currently available model. But I need to discuss on the challenges of the current devices. There is still a delay, and this is a lag time, the sensor measuring the interstitial glucose with approximately 10 minutes delay. And multiple regulatory blocks are there. FCL removes a human safety check of meal bolusing. The regulators are looking for data on hypoglycemia because the regulators are bothered with hypoglycemia because the sensor has to be very accurate. Otherwise, it can false bolus. So there are challenges to the path for a fully closed loop system. And liquid glucagon preparations are not stable in a bihormonal preparation. And desiglucagon, the trials have shown to be better, but not much difference between the insulin-only system versus the dual hormone systems. Reliability of the sensor still remains a challenge. That I also agree. Even the best sensors are failing in between. There are sensor dropouts, the warm-up inaccuracies carry higher risk, and then algorithm personalization in the different ethnicities across the world. Let me move on to something which is evolving out of artificial intelligence. The AI-powered closed-loop algorithms, many are under the trials, and this is the digital twin model. In AID, the digital twin will support the doctors, the researchers, and the systems to train and practice. And this is meant for keeping glucose in range, like rehearsing the treatment plan without inducing any risk to the patient. And this is ABC study, adaptive behavioral component. And here you have the tandem D-slim pump, the control algorithm, the tandem control IQ, comparing standard closed-loop control with an adaptive behavioral component, that is ABC and behavioral adaptation molecule. So in short, you are in a car and it is a self-driving automobile. You are trusting the car and you sit and relax, and the car learns the road. And next step of BAM, it is ABC. So the ABC will upgrade the car's brain, and now it is automatically detecting the route, the favorite route, the traffic, and so on. So look at the results of this clinical trial. Of course, these are all with digital twins with control IQ algorithm. The TAR 73 to 77, the time in titer range, the new metric which is rapidly evolving between 70 and 140 milligrams from 48 to 52%. So it is improving, it is evolving. And almost all the current clinical trials are with fully closed loop systems. Since we are done with the HCl, what about the current analog insulin? Even the ultra rapid acting analog insulins are too slow compared to how rapidly the glucose is rising after a meal. And because of the mismatch of the pharmacokinetics, the AID systems are struggling to deliver insulin fairly quickly. And these are some of the studies. We have the two university algorithms, the Virginia and from the Pennsylvania. So this is with unannounced meals and this is predictive meal anticipation. So even with unannounced meals, when compared to an HCl system, it is 77% time in range. So it is good. And the time below range is remaining the same. So the system, in the absence of meal announcements, are also able to reach a target of more than 70%. And this is another one, an automated priming bolus. That is a bolus priming strategy, that is BPS versus no bolus priming strategy. So in simple terms here, the moment the system is recognizing that the person is ingesting a meal, it will certainly deliver a bolus, and that is the priming of a bolus. So when you are comparing BPS with no BPS, there is a significant improvement in the insulin which is delivered, resulting in a rapid control of glucose, and the glucose is remaining under control for a longer period of time, and the postprandial spike is also lower. So this is FCL home, the iodine and fully closed loop system, where all these factors are being taken care of. It is a fully closed loop system. The BPS strategy is there. The temporary control rate, the TCR addressing the stress, the sleep pattern, artificial neural networks, and the cloud-based monitoring, and then adaptable aggressiveness based on multiple other factors. So these are all upcoming factors. And let me tell you, some of these not commercially available is all there in the DIY users. That is do-it-yourself artificial pancreas users, including in India. Some of these components are already existing. So this is a 14-day home control period on usual care. And then there is a 5-day in-hotel supervised fully closed loop, 7-day at-home remotely controlled FCL, and there is a crossover arm control before or after FCL. So if you look at the results, this is a fully closed loop and difference, and you look at the time and range, overall daytime and overnight, very encouraging results. Very encouraging results. Overall, it is 57.9 versus 63.6. So overnight, even the time in titer range appears to be more than 50%. So 53.8%. So the results and limitations are discussed here. The study duration was only for 12 days. Longer clinical trials are required, but the available data is very, very encouraging for the developers. And this is iPancreas, another one using Dexcom G6, predicting the carbohydrate amount. So here in the iPancreas, we look at the results. There is reduced user-initiated bonuses by 38%. The TR iPancreas was non-inferior. It could detect the meals 26 minutes on average, with 83.3% sensitivity in identifying, recognizing the meal. So meal recognition is a challenge, and the systems are improving with significant improvements in the postprandial hyperglycemia. This is CAM-APS Liberty, the world's first commercially available fully closed loop system, and this is available with the Dana insulin pump, CAM-APS, and also with some other pumps such as Increda. And this is what it does. It is improved in the month of January 2026. Fully automates the delivery of insulin, no carb counting, no pre-meal bolusing. It is integrated as a Liberty mode within the existing CAM-APS FX app. And this is Vivera algorithm. We are looking forward to the launch of Minimed in India, 3rd gen fully closed loop algorithm. and you have minimum flux replacing the 780G. And this is, as you can see, it is a very small pump and all the controls are within your mobile phone. And Minimum is also planning for the first ever patch pump, and that is going to be minimum fit. And this comes with the Vivera algorithm, 73.8% time in range in the ongoing clinical trials. Very quick start, bypasses the 48-hour warm-up period. So currently, it will be in the manual mode of the first 2 days. And that is not required in the new Vivera algorithm and the new devices. New glucose target, there is, in addition, there is 90, 100, 110, 120, 130, and 140. So the thresholds are going to be different in the new device, and no need of AIT. So active insulin time need not be programmed. Adaptive AD and with seamless transition. And of course, we have AI-enabled dual hormone systems being developed, and these are the different strategies for the delivery of primary diet. So if you look at the insulin-only strategy with the model predictive control against the dual hormone MBC, and dual hormone independent, it's more than 80 to 90% time in range. So with all these systems, AI-enabled dual hormone MBC algorithm, again, you have encouraging results, but with limitations. So most of these are in silico studies. These are the 2026 competitions going on. You have the FCL being developed by multiple device manufacturers from CAMP-APS, Insulet Evolve, Idynet I have discussed, Inrida, Diabloop, and Minimeda also is currently developing the fully closed loop. Remember, these devices can be used along with type 1 diabetes, can also be treated. In many countries, it is approved for the use along with the GLP or with the dual agonist. There, the settings of these AID and the pumps are listed here. You have to make some subtle changes. And the same is also true when you are using dapagliflozin or empagliflozin. You can reduce the total daily dose of insulin by 25% or 30%, or in some cases even by 70%. So the future will be dual ketone and glucose monitoring systems, and this is already there in the space from Abbott in some countries, and we are looking towards the future.
Type 1 diabetes, whether it can contribute to the incidence of type 1 diabetes, what is the impact on type 1 diabetes management, how can we treat obesity in type 1, and of course, my last key messages. So let's have a look on the World Obesity Atlas. As you can see, there is no doubt that there is an increase in overweight and obesity worldwide. Even in India, the rates are going up, and probably as a rising economic power, India will also see these high rates of overweight and obesity in some years or decades. But for the moment, we consider obesity an epidemic, and it is defined as a global public health issue of our time. So for you to have an idea, the global prevalence of obesity has nearly tripled since 1975 in adults and in children. And according to the World Obesity Federation, looking forward, we can see, or they are previewing, that by 2035, more than 1 in 2 adults will be living with overweight or obesity. And the proportion of children and adolescents between 5 and 19 years of age with obesity or overweight will be almost 40%. So this changing landscape of type 1 diabetes is not new. And the first ones who were just having a look at the numbers were the United States of America. And they were seeing that since the 1980s, so 40 years ago, there was a rise in the proportion of overweight and obesity among adults with type 1 diabetes. And these rates were going higher and higher, and they could also see that this was not only a problem of older people, this was also a problem of younger age groups, like between 18, 25 and 26 and 49 years of age. And nowadays, there is no doubt that the numbers of obesity and overweight people with type 1 diabetes are more or less the same as in people without diabetes. And this phenomena and this changing was also seen in Europe a little bit later, in the late 90s. And we can see on your left side, the Swedish National Diabetes Registry. So the high rates of obesity were starting more or less 98, and they went up until now with an overweight rate of 33% and obesity 8%. So a little bit lower than the United States, but still very high. On the other side, you can see the German registry, where also the conclusion is that the rate of type 1 diabetes is more or less the same as the increasing rate in people without diabetes, about 1.2 kilograms per square meter. But so if it is the same rate in people without diabetes and people with type 1 diabetes, what is the concern about it? What is the problem? Well, the problem came out some years ago, in 2019, with the work of Rashvani, who was looking into the type 1 diabetes Swedish registry, one of the biggest register in type 1 in the world, and one country that is known for the very, very good metabolic control of type 1 diabetes population. And what he could see was that the rates or the cardiovascular that say that obesity and type 1 diabetes do not go well together. And what about overweight and obesity in children with type 1 diabetes? What do you know about this? Well, there are not so many studies, but this one that I'm bringing you is a very important one. It was looking into the three of the major registries in type 1 diabetes in the world. So the one from the USA, Type 1D Exchange, one from Germany, the DPV, and the one from Australasia. And they were comparing the data of these three registers between 2018 and 2021. What we can see is that in all registries, almost 50% of people were overweight or obese. On the other side, the proportion of obesity is increasing, particularly in young children, in all three registries, as you can see here on your left side, in children between 5 and 10 years of age. And which are the reasons for overweight and obesity in type 1 diabetes? Is there a particular reason for this? Well, we can say that there are many contributors to overweight and obesity in type 1 diabetes. And the major one, the significant reason, is, of course, the global overweight and obesity epidemic that you are seeing all over the world. But on the other side, there are factors related to the disease itself and to the management of type 1 diabetes that can contribute to increasing weight in this population. You have the psychological burden, like burnout and depression, related to the eating behavior disorder that we see very often in this population. You have the physiological alterations like hormonal disturbances in insulin, glucagon, and amylin. Of course, it is a disease related to behavioral disturbances as well, due to the hypoglycemia avoidance behavior, due to very reduced physical activity because they are afraid of hypoglycemia, so sedentary life, and then the vicious cycle of weight gain and escalating insulin doses. And also, of course, the social economic factor is also contributing to overweight and obesity in this population. Factors like the low income and low education, the healthcare access, gender disparities, all these are factors that contribute to the weight problem in this population. For many, many years, the treatment related like intensive insulin therapy was considered a major factor for gaining weight in type 1 diabetes. And I would like just to show you that was really a problem, because during many years, many centers didn't want to start intensive insulin therapy because of weight gain, one side, and hypoglycemia, severe hypoglycemia rates that were associated with intensive insulin therapy. And indeed, this was coming from the DCCT study in 1993, where the weight gain in type 1 diabetes was really happening in those in the group of intensive insulin therapy, already starting in the first months of treatment, of intense treatment. And this observation was also related to the lowering of the HbA1c, which was again related to the higher rate of severe hypoglycemia. But what I want to say is that we have to put all this information and results in context. And the cause for the weight gain at that time in the 90s during the DCCT was that we were using more insulin, so multiple daily insulin doses per day, together with the more or less same carbohydrate intake. And this was bringing, of course, much better control with lower HbA1c, less glycosuria, and increased weight gain due simply to the fact that they were eating the same and giving more insulin. And the severe hypoglycemia rates that were going higher is, in my opinion, no more a problem, because we have nowadays a significant improvement of kinds of insulins, and the diabetes technology that is affordable for at least part of the world. This is a study that I wanted to show about the impact of intensive insulin therapy on BMI. So this is a modern study that was done in an Australian large pediatric diabetes center, and they wanted to compare the glycemic control and BMI STS before and after the implementation of intensive insulin therapy, which could be MDI or pumps in type 1 diabetes adolescents. And what they could see between 2004, 2010, and 2016 was that the BMI STS did not rise with increased target glycemia. So to have a better target glycemia didn't mean to have a higher BMI STS, which is quite reassuring. And if you look into the more recent publications, looking into the effect of automated insulin delivery in the BMI, this suggests that BMI does not increase despite improved glycemia. So the other next question that I would like to discuss with you is, can obesity or can overweight and weight gain contribute to the incidence of type 1 diabetes? I would like to share this to see your reactions live, but let's have a look on the slides that I brought you. So the potential links between obesity and type 1D pathogenesis exist since a long time. 15 years ago, there was the accelerator hypothesis that was defending that obesity-induced insulin resistance was responsible for the increased burden on islets in those genetically at risk. And this would lead to an increased insulin demand from these cells and would induce autoimmune destruction and accelerate all the course. Well, this is partly true, but it's not the only truth. We know that obesity, nowadays we know that obesity is a state of chronic systemic inflammation. And this systemic inflammation may, as an inflammation state, induce the inflammation of the beta cells and contribute to the development of type 1 diabetes. On the other side, obese people have a high fat and simple carbohydrates diet normally, which increase oxidative stress in the body, leading to dysbiosis and contributing to beta cell fragility, and of course, later on to the development of type 1 diabetes. So there may be many factors that are related to obesity that can contribute to the autoimmune disease, which is the definition of type 1 diabetes can contribute to the trigger, as a trigger for the autoimmunity in susceptible people. And I would like to show you two studies, very interesting. This one is coming from Israel, showing that overweight and obesity may be a risk factor to type 1 diabetes. And what they did was they were looking into the 1.4 million adolescents were evaluated before mandatory military service. They looked into the oxology and somatometric data from these million people, and then they went to the Israel National Diabetes Registry for type 1 diabetes and tried to look into associations between BMI and in healthy people and the risk for type 1 diabetes. And this is the result. So we can see that the higher BMI in healthy adolescents is associated with increased risk for type 1 diabetes in early adulthood. Other studies, this one's prospective cohort studies from the group of the TEDdy study, I think you all know the TEDdy study, they were looking into distinct growth phases in early life that could be associated with the risk of type 1 diabetes. And indeed, they could see that a higher rate of early weight gain and a higher BMI Z-score are predictors for the development of islet autoimmunity. Here down in the table, you can see the higher gestational age adjusted for birth weight is related to the onset of antibodies for type 1 diabetes. And now another important point is the impact of obesity in type 1 diabetes management. Well, I think this is a really concern for those who have experience with type 1 diabetes and with children that are both. So they have, we can say they have a double diabetes. It is a type 1 diabetes with features of type 2. I think we can say that. We can also say that they have increased cardiovascular risk, so increased heart disease risk, cardiovascular complications, macrovascular complications. They are leading with the typical insulin resistance. That means they need higher doses of insulin, also because of type 1 and insulin resistance. And they are typically harder to maintain stable because of the glucose variability. We never know how high is the insulin resistance and how is the weight oscillating during their lifestyles and during their life phases. So there is a high impact of obesity in the management of type 1 diabetes, and the clinicians are really struggling with this kind of diabetes. What is the world doing to treat obesity in type 1 diabetes? So I brought here the American Diabetes Association and the standards of medical care concerning obesity and weight management for the prevention and treatment of diabetes. And what this group is recommending is that we apply the same obesity management strategy used in the general population, including GLP-1 receptor agonists and even metabolic surgery, to those adults with type 1 diabetes who have an obesity rate of over 30 BMI or over 27.5 kilograms per square meter if they are Asian Americans. So there should be no difference in treating obesity in people with diabetes, with type 1 diabetes and without type 1 diabetes, so no diabetes. But the point is, or the problem is, that we still have only the lifestyle interventions as first line to treat obesity in type 1 diabetes. So the recommendations are, of course, everything we know, so healthy eating patterns, to have physical activity at least 1 hour per day, trying to counsel the family-based behavioral And then, of course, we have more challenges in the population with type 1 diabetes because they have a higher hypoglycemia risk during exercise and fasting, and they have to take carbohydrates many times or more times to prevent the lows. So this is something that is, again, impact on the management of obesity in type 1. Looking in the pharmacological adjuncts therapy to insulin. Well, there is only one FDA-approved drug, which is pramlintide. Pramlintide is like amylin hormone, and pramlintide has, and after so many years, not such good results as we thought it would have. So it has a modest influence lowering HbA1c and weight reduction. And the big limitation is that we have to have frequent dosing for this drug, which is not at all practical for patients already doing insulin every day, many times a day. GLP-1 receptor agonists are still off-label for type 1, even if they show a significant weight of loss. The same for the dual gastrointestinal peptide together with GLP-1s. They are off-label, and metformin has modest short-term weight and insulin dose reduction and doesn't influence HbA1c in type 1 diabetes. And the SGLT2 inhibitors, they have a weight loss benefit, but also at the same time, they have a significant DKA risk in type 1 diabetes patients. So we have to be cautious, especially in pediatric population. The ADA is also recommending metabolic surgery, but just in severe cases for type 1 diabetes, so a little bit higher BMI than in the population without diabetes. So BMI over 35 with comorbidities or BMI over 40 should be go to metabolic surgery, and there is practical no data for the pediatric population on metabolic surgery. I will now focus a little bit on GLP-1 receptor agonists, as they are being very popular, at least in the Western side of the world. And what do we have? What is the evidence that we have? Well, we just have, most of the evidence comes from the adult studies. But the first thing I have to say, again, GLP-1 receptor agonists are still not FDA approved for type 1, but the off-label prescription is without doubt increasing in most of the countries. So in 2023, almost 7% of the population with type 1 diabetes was getting these prescriptions. Looking into the studies with GLP-1 receptor agonists and in the type 1D population, there are not so many studies. We have the big adjunct 1 study and with two trials using liraglutide 1.8 milligrams. We have also a meta-analysis on 24 random controlled trials using liraglutide or exenatide. And then we have the real-world data, also with liraglutide mostly. And they were showing, all of them, a significant decrease in HbA1c, about 0.4%, a decrease in total daily insulin dosage for these patients, and weight reduction as well, about 5 kilograms. Looking particularly in the semaglutide pilot study, this one, in my opinion, was the best result. They showed an improved BMI, a really significant improvement of BMI, about 7% of the weight reduction, and an improvement in time in range and in glycemic variability. But all these studies were showing increased reports of symptomatic hypoglycemia and hyperglycemia with ketosis. So we have to be aware when we think we can use GLP-1 receptor agonists in type 1 diabetes, like in the population without diabetes. And particularly if the patient is using an automated insulin delivery system and is using GLP-1 receptor or the dual therapy, there must be a periodic assessment of the AID settings to reduce the risk of hypoglycemia, and we have to try to avoid prolonged insulin delivery suspensions that may predispose to ketosis. So saying this, I go back to the standards of care, and according to the ADA standards of care, we have to be aware that are indications and contraindications for the use of GLP-1 receptor agonists and dual therapy in type 1 diabetes with obesity. So this is a table showing these several indications, so who may benefit and who shouldn't go for the therapy. And for the several indications, I would highlight, for instance, some comorbidities like the obstructive sleep apnea, the metabolic steatohepatitis, or important coronary artery disease. But those comorbidities should be happening in patients with an intact hypoglycemia awareness and no recent DKA or aglycemic ketoacidosis, so stable glycemic control, which is, of course, not easy. And the patient factors, these patients should be willing to monitor ketones. They have to monitor ketones, but because they will happen if they are doing these drugs, and they should be able to adjust insulin doses themselves. And about completely contraindications, so we should dissuade the initiation of these drugs, is related to the gastrointestinal motility, so patients with gastroparesis or delays in gastric emptying, because the drug will even worsen this gastric emptying and will mismatch with the insulin timing, or patients with hypoglycemia unawareness, or those that cannot detect lows. They will be at risk or more risk if they are on GLP-1 receptor agonists. And of course, patients with a ketoacidosis history are also contraindicated to use these kinds of drugs. What do we know about treatment of obesity in the pediatric type 1 diabetes population? So there is very, very few data. I took here the ESPAT guidelines, which are again defending that the first line of intervention is lifestyle intervention. With an energetic recommendation based on an ideal body weight to prevent overweight, and of course more than or at least 1 hour, 60 minutes a day of exercise, physical activity, and the exercise should be always discussed at the diabetes visit. At least I am doing this. This is my first question, or the second question: what kind of sports are you doing? How long are you doing? How many times a week? And I'm also motivating children to do sports, even the parents are a little bit afraid. What about adjunct pharmacotherapy to insulin? Well, unfortunately, as usual, there are no pediatric type 1D approvals for none of these drugs that we know. So not pramlintide, not metformin, not GLP-1 receptors or SGLT2 inhibitors. The studies that we have in pediatrics and type 1 diabetes, obesity are also very few. The only one I think is very interesting is this one recently published from GARC, from Satish. It is a pilot study where he could show semaglutide is effective and safe, lowering BMI after 1 year in type 1D children, improving at the same time HbA1c, time in range, and glycemic variability. So I think I come now to the conclusions. And as conclusions, I would say, first of all, that 1 out of 4 people with type 1 diabetes is overweight or obese. in the world, which does not differ significantly from the non-type 1 population, at least in high-income countries. The most recent data demonstrated double burden in adults and also children with type 1 diabetes, and the combination of both diseases and disorders can lead to worse cardiovascular outcomes, much more than one condition alone. The prevalence of obesity and overweight in type 1 is a consequence of the obesity epidemic worldwide. There is no doubt about that. However, specific variables related to type 1 disease are strong contributors to the increase of BMI. That is also sure. We can think and we can hypothesize that overweight might be a risk for the incidence of type 1 diabetes, and there is for sure a very urgent need for pediatric studies, randomized or from real-world data on GLP-1 receptor agonists in the type 1D population, at least to inform evidence-based guidelines. Well, now I would like to thank you for your attention. This is my group of work, my city, Lisbon, and my last slide is to invite you to come to the ISPAT meeting in Rio de Janeiro in the next November from 4 to 7. We'll talk about the journey to the new world of pediatric diabetes. So thank you very much for your attention, and I hope I can get some questions from you.
Thank you, Dr. Katrina. She has a wonderful talk. The excellent discussion of obesity and type 1 diabetes. I would like to invite Dr. Smruti to introduce our next speaker.
Sure. Can we have
You are muted, Smruti.
Sorry, can we have the slide for Dr. Michaelovich, please? The introductory slide. Okay, it is my privilege to introduce Dr. Michael Witch. He's an endocrinologist and diabetologist at Center Hospital in Luxembourg. Dr. Witch is internationally recognized for his expertise in pediatric diabetes care, digital health systems, clinical data management, and quality improvement initiatives. He serves as a digital health officer for the medical department and has played a major role in advancing international benchmarking and collaborative learning in pediatric diabetology through the SWEET initiative. He has been a member of SWEET Steering Committee since 2015 and its executive board since 2018, contributing significantly to global efforts in improving pediatric diabetes outcomes. His work in diabetes technology, registry-based research, and quality improvement has earned him the prestigious ISPAD Innovation Prize. We are honored to have him with us. Please join us in welcoming Dr. Michael Witch. Can we have his lecture, please? Our RX team, can we have Dr. Michael's lecture, please?
Kishore bhai.
Welcome and good morning, everybody. It's a privilege to be here at Practical Diabesity 2026. My name is Michael Witch. I'm a pediatric diabetologist at the Center Hospitalier de Luxembourg. And since 2010, I've been working with the SWEET registry. Since 2011, my role within SWEET has
recording stopped.
Recording in progress. want to share with you what 15 years of international benchmarking in pediatric diabetes have taught us, and importantly, why the lessons from SWEET are particularly useful for a country as large and diverse as India. I have some disclosures. I receive a honorarium from SWEET for the benchmarking report since 2020. For the 10 years before that, I worked for SWEET without any honorarium. No further declaration. Why do we benchmark in the first place? The honest answer is because comparing yourself to others is the fastest way to find out what you don't yet know about your own practice. The Videre study group showed almost 20 years ago that even when you compare pediatric diabetes centers in highly developed European countries with similar resources, you find big differences in HbA1c. And perhaps more strikingly, the rank order of these centers barely changed over more than a decade. The centers at the top stayed at the top, the centers at the bottom stayed at the bottom. Some exceptions. Yet the whole group's HbA1c improved over time. That tells us two things. First, there is something real structural about how each team works that drives outcomes. Second, when groups of centers talk to each other and benchmarking openly, everybody can get better. The Swedish National Pediatric Registry, SweetDiabKids, is a textbook example. Open public benchmarking combined with deliberately low HbA1c target applied across all centers lowered the group HbA1c after years. So benchmarking is a mirror, not a ranking exercise. The question is never, are we better or worse? The question is, what could we learn? SWEET stands for Better Control in Pediatric Adolescent Diabetes, working to create centers of reference. It was started in 2008 as a 3-year EU-funded public health project, and after the EU founding ran out, the group did not dissolve. Instead, in 2011, it became a registered non-profit legal entity in Hanover, Germany, in close partnership with ISPAD. And in 2014, it becomes even international worldwide. SWEET has 4 pillars: data management and benchmarking is the engine. Every 6 months, centers transfer a defined set of clinical parameters and receive a benchmarking report back. Research uses the joint database to answer questions no single center could answer alone. Peer review is a structured, clinically led visit program for centers of reference. And underpinning all of this is the education, both for clinical teams and for data managers. Today, SWEET has over 120 active centers in 5 continents with around or more than 100,000 children with type 1 diabetes captured. This includes India centers, which I'll come back to. A benchmarking report sitting on a hard drive does nothing. The transformation only happens when a team sits down together and looks at it. Twice a year, SWEET centers receive an update on the SWEET Cloud, an application usable on PC, tablet, and even the telephone, which displays interactively all data. The report is focused on whole group report and individual center, but also we have 7 regional reports, including one for India. The report is sent both as a PDF. No, this is an old. No, I want to tell you that it's PDF. No, it was a PDF. Sorry. And now we have the SWEET Cloud, which is really amazingly usable. Because you can filter, you can set your own settings, and you can download all charts and tables in it. So it's extremely useful. In our center Luxembourg, we have 10 minutes every week in our staff meeting on data quality, and twice a year a 1-hour strategic session where the report is shown to the whole team and even to parents and patients. That is what data-driven actually means. On the top of the report, SWEET runs a peer review program, clinically led, developmental, not inspectoral. The point is to help centers improve, not to grade them. Benjamin Franklin captured it well. Tell me and I forget. Teach me and I remember. And involve me and I learn. Let me show what we mean by international variation. The figure is adapted from Syed and colleagues, 2021 Sweet paper, which compared 5 regions across roughly 49,000 children. The adjusted mean HbA1c in Europe was 7.8, in Australia and New Zealand 8, in North America 8.4, in South America 8.7, and the Asia, Middle East, Africa region 9.4. The mean daily insulins variate from 0.8 to about 1 unit per kilo. The pump uses, you can imagine, dramatically variate between North America, for instance, with 80% and up to 4% in South America. But here's a key point I want to take from the slide. These are regional averages. Within each region, between center variation is even larger, and that is where the learning happens. And even you see the outcome ranges between regions who have highly access to technology and a low access to technology varied not so much. So that's why I think a regional average does tell a center in Bengaluru or Kolkata what to do. A comparison with peer centers facing similar changes does. Of course, we all talk about technology. Yes, technology matters. Let me give you 4 data points so you can see where the conviction comes from. First, our own 10-year Sweet benchmarking paper, Charlton and colleagues, 2021. We compared 2 time windows, 2008 to 2010 versus 2016 to 2018 in 19 countries. HbA1c improved significantly across all age groups with no overlap of the 95 confidence interval. In parallel, CGM use and pump users rose. Second, the recent Lancet paper from Zimmerman and colleagues, 2025, a longitudinal analysis of more than 100,000 children in 9 pediatric diabetes registries, including Sweet, between 2013 and 2022. Group HbA1c keeps falling, and the recent acceleration tracks AD uptake. Third, iterative meta-analysis of automated insulin delivery from 2023 to 2025 consistently show 8 to 20 time and range gains over multiple daily injections, center-mounted pumps, and pump-only therapy without increases in hypoglycemia. So what you see here, of course, it matters. But even if you have a very good access to these technologies, the variations are still high between centers. And I think this is what we should focus on. Because we do not pretend that technology is equally available. Sweet pump use ranges, like I told you. So even within a single country, in a high-income country, CGM and pump uptake differ across socioeconomic status. And we see this, for instance, for the US or for the German DPV cohorts. Also, reimbursement varies between neighboring European countries. So that's why the ISPA 2022 guidelines on management and limited resource settings explicitly describe a stepwise progression of access. Reliable insulin and SBMG, a trained team and structured education. This is extremely important. You know, the base is that we have insulin and we can measure blood sugar, and we have teams who can educate our patients. Routine HbA1c monitoring, and then comes intermittent CGM, routine CGM with pump and AAD. This is the right framing for benchmarking. Don't compare center to center with full reimbursement and ask why your CGM uptake is lower. Compare a center to peer centers at the same step on the ladder and ask, where is the next achievable step for us? One of the most striking pieces of feedback we got from Sweet centers was this, and I quote, seeing the difference in HbA1c at your center compared across the network has revealed that centers with lower technology uptake can achieve better glycemic outcomes than centers with higher technology uptake. This is so important. Do not believe that only the access to technology is important. This is not a comfortable sentence for something else, but it's true. Diabetes care is a system. Technology is one component. The other components are at least as important. Structured education for child, family, and schools or other caregivers, a multidisciplinary team that is actually staffed, follow-up frequent enough that the team is reachable between visits, a clear vision of the team, psychosocial support for depression, disorder eating, stigma, etc., written, individualized, time-bound targets the family understands, and reliable data capture for every visit, every patient. A center that gets 6 right with MDA and SMG can outperform a center that has CGM and pumps but doesn't. This is also where benchmarking earns its keys. It lets you see the comparison in real numbers. Here, let it make me the concrete with 3 centers from the suite network, all of them in low middle income settings, all of them participating in benchmarking, all of them documented in Packard's 2016 suite supplement paper on developing country contribution. And you see it here. We have good examples from Belgaum in Karnataka, where we have a takeaway that means free insulin program, family education, and peer connection was their important point. From Ahmedabad and Gujarat, the takeaway was the group education, school awareness, mother and peer programs. And from Mali, we learned that before suite partnerships, life expectancy after type 1 diagnosis was only 1 year. And that's, I think, so important that we learn what is the best in your individual center, in your region, what can help the most for your patient. And of course, I cannot answer this to you, what is really the best and I would not say in India, because India is so huge and diverse. I think that is also important to say what is in your center. And I really want to motivate you to have a look on this. I think what I've seen is that the smartphone as a bridge is clear. Connection to patients is not anymore the problem. You have so many good programmers in India. I think it would be very easy to have little apps or even WhatsApp-based follow-up for diabetes, which can help to have close contact and to overcome sometimes the barrier that patients can come to face-to-face visit on a regular basis. We've seen even, during COVID, where no physical contact was possible, many centers achieved that the results were as good as they were before or afterwards. So that means technology in communication can help us tremendously to keep or even to develop a good metabolic control. So now let's come back to India. You have, please correct me if maybe some numbers are not right here or outdated, but there is a huge diversity, about prevalence and also what is possible on access to insulin, to modern technology, and what we've seen here, it's so interesting, and for me, it's really fascinating that so many Indian centers are participating in the suite group. That you even in suite you're able to compare yourself, and I come back to this now. So let's have a look on the suite cloud. These is just we published the last data just 2 weeks ago. This is here the picture of the whole platform of the almost 200 centers in total, but active centers really sending data on a regular basis to 126, and the 194 are also those included who are in the pipeline, because now many centers sent their applications to suite. And look at this orange diagram. There you see what is on the left side, the countries with more than one participating centers, and who is the most? Your country. That's so amazing that India is so well represented in the suite group. So congratulations to you for this. Now let's have a look on your individual Indian report. There you see, okay, there's 7,200 patients here in all together, and in 2025, 1,700 patients are in the database. You're using often the DPV software, which is a specialized software which we give for free when you're in Suite. So if anybody else here is interested to participate in Suite, please feel free to participate and share your data. Now we come back to the whole group. You see here we have now 45,000 patients in 2025 here in the group, the HbA1c. That's the median of the patient's median, which is 7.3. And the use of sensors is 78, and the use of pumps is 58%. What's also interesting, you know, what happens with type 1, type 2, and the other types, you know, that's on the right side, the lower graph, the orange bar is the type 1 diabetes. So in pediatric age group, still type 2, we're not overwhelmed with patients, because we thought maybe when the obesity rises that we have more and more, but this is not the case when we look at the whole group. And we are more active in detecting the other types of diabetes, genetic forms, that's the blue, the light blue bar. And this is interesting that I think we detect more and more, and we report also more. The complete list is quite high. That's the graph on the lower left side. And that, have a look on your data, what you can do on this perspective. So now let's have a look on the Indian report. There we see, okay, there is a little bit to do on the completeness of monitoring. I think it's normally that you have also less other types of diabetes, because you have maybe less resources to detect them, to do genetic analysis. The HbA1c is about 9% in average. The use of sensors, and that's quite high, actually better than I expected. It's 50%. The pump use is very low, with here reported 2%. It maybe also varies from center to center in your country. So, and now let's have a look on the Indian report. And there you see, and I think this is the most interesting, there's a huge variety on the HbA1c, you know, from even below 8 to a very high percentage on the right side. This maybe has to, I have to have a look on the center. Is there maybe something also with the data submission, or, you know, maybe technical errors that, because it's extremely high with over 12. But you see, even when you look at the other centers, there is a huge variation. That means there is room for improvement on many perspectives. So this is not your data, but this is, we had did it in Suite. And here we've seen, even in centers with same insulin access, that was at the time here where we have only blood sugar measurements and no technology access, same team size, and also same center size, and we see huge differences between centers. That's always what I'm looking at, is we should learn, you know, the one with the red ones here should really learn from the green ones what you differently, and are your approaches transferable to our situation, which is not always be the case, but sometimes we have to think out of the box, what is transferable to our centers. So then please don't compare only with the global average. Global average is super, it's easy to compute. It's, I would say, fair to no one. And it mixes, of course, pediatric centers with a high technology coverage and centers, you know, with low. And it's not the question where we are below average. It might be demoralizing, or we are above average and we are complacent. The question is what you can learn from it. So therefore, it's Also, the peer group comparison, as I already told you, is so important. Look at centers with similar resources, and you can even look at suite, to other countries and see, wow, what I can learn from other centers in other countries, like a peer when they have similar resources, even maybe from the patient perspective, similar backgrounds that we can learn what really helps them to make everything better. Know a lot about your population. I'm extremely in favor of that you know what is your population. That means how many patients do you have? How are they structured? What is the family situation? Look at these, also what happens directly after onset. I think it's extremely important. Do you cover a very good HbA1c in the first year, or are they even start quite high and then never get better? Because this is so important. It's like the beginning of a story. When the story starts well, we have a high chance that it stays well. When we have, after a couple of months, already HbA1c of 10 and never become better, then we really have to focus in what can we do for these patients at onset, that they start on a good track and not already very high. And that's not about technology. That's about training, formation, about the capacity, of course, of families, about their health beliefs. So there are many, many things, and you even know it much better what is important for your families. But also try to have a clear mindset. What is my setting? I really want to emphasize a lot that it's so important what we as professionals believe is possible for our families. We have a huge discussion, for instance, is the HbA1c of 6.5 not too strict, or is it possible? And then we've seen in other countries around us, yes, it is possible. And you can tell, of course, do it now even higher, say, okay, 7.5 is possible in our country, let's go for it, and we are capable to transmit this information to the whole team. Convince everybody that this really is widely accepted, and transmitted also to your patients. So when we look at these average HbA1c, when you look at the central level, it's extremely important because you can do leaderships, you can do founding, you can do audits, you can do comparison. But when you look more in detail on your individual data here, then look at the subgroups, because maybe you have to focus on the adolescents with a high HbA1c. I'll give you an example. I have a club over 10. What does it mean? When a patient has an HbA1c over 10, it means he loves me so much. He wants to see me every week. And I do it so long till the moment they really hate my face. They do not want to see anymore this Dr. Rich. They want to get out of this club. And of course, they only can get out of the club if the HbA1c is below 10. So they have to do something. They have to move forward towards a better metabolic control. And I think, that's just one example. But look at this, on your group where you really should focus on where is the most important. And also, even if it's cruel to decide, okay, what are my resources? And with these resources, on which group should I focus? With a very high HbA1c or a little less, but maybe I reach more patients with my resources. I think that's extremely important to target your resources reasonable. Of course, on the patient level, it's clear there the story begins because when we look at the individual patient level, we have to find what is the individual solution for a patient. So set realistic goals. When you look at benchmarking now, let's have a look. What is possible in the next months? When you look at your sample, let's have a look. Okay, maybe we really should work on data completeness. That we add, the minute extra to enter some basic values. Be clear in your center what is important for you. When you say, okay, HbA1c, BMI, blood pressure for every visit, and a little comment on every patient. What is the goal for this patient, and try to define these goals and stick to it, that you enter it every time, that you have a follow-up from one visit to another. And of course, with the data, when you send them to suite, or if maybe you have even benchmarking initiatives in your country or your region, then stick to it. Then identify the high-risk tails, like I told you. Then define, okay, what can we do for this? What could be the targeted education for that tail? Group sessions, school visits, having maybe training in the sport groups, etc. Or maybe you have to train the fathers and the mothers both, or who is also sometimes has a negative impact on the metabolic control, where a health believes, where you really should target on. And then said to us, okay, what can we do for you? Have some centers who have so many patients, more than 1,000 patients. There you can say even, okay, we track it monthly. What is our average HbA1c? And have a look, what can we do to become lower? Then, of course, the technology question, that's, I think, there the influence is maybe very limited, because that depends on your healthcare system. But then when you have a clear targeting, then after 1-2 years, be realistic how you can adapt these targets. Not too, for HbA1c, not too low, because it should be manageable, but also not too high, that is a challenge for you, that you say, hey, why we are not becoming lower, what we can do now. So when I look, at suite in general, and this is not, this is maybe scientifically has to be proven, but this is what my impression is here. Clearly is all the very good centers in suite have lower written targets. They have a target in the target setting is quite low. It's 6.5 rather than 7.5, and they work with it. They have often more contacts per year, more follow-up visits to have, to stick in country. We've seen also now that this rule becomes, with digital guidance of the patients, even more like a triage system. You say this patient group is so well, I only see them once a year because it works perfectly. Why should I see them? Therefore, I have more capacities to focus on those patients who need much urgently direct contact. A structured education at every age step seems to be extremely important. To really not only do an initial training and then nothing else anymore. No, it's an ongoing process to see what have the patient and the family captured, what have they learned, where are their gaps, and what can we do for them to keep a high diabetes education. The active monitoring work on the high HbA1c tail is extremely important to see which patient groups need as much our support. The team meetings on outliers, that's what I also told you. Look at your data and work, even on a weekly base. Okay, which patients are we have? For instance, in our center, we had for a certain time when we had even an HbA1c above 9, over around 15 to 20%. We have a list, concrete names, what are the names of these patients who have such HbA1c, high HbA1c, and what we are doing for them to get lower, and of course what they can do. So a systematic CGM download review or SMBG download review is important to see, to recognize patterns with your patients, and to compare it also to the values in the last visit. This is extremely that is important. The family and school and peer engagement is often can help a lot. That depends on your region and your health beliefs. As family, we see, unfortunately, that group trainings in our centers, the patients are less interested. We had groups a couple of years ago where 60 people comes and we have 400 patients, so quite good. And now even maybe not 10 comes anymore to group training. Maybe life becomes so difficult and fast, and there's no more time for this type of engagement. So that you have to see what works in your center. And this open data culture, I could not emphasize this more. It's so important that you say, okay, I compare openly with my peers. I show my data. I show my strengths, I show my weaknesses. And maybe there's at the beginning only weaknesses, and you say, oh no, I don't want to show that because I feel, awkward and maybe ashamed even. But this is, go through. Because when you tell everybody, okay, this is my, and ask for help, for better understanding, and then you maybe identify centers in your region who are quite good, and then say, hey, what helped in your centers? And get this in touch. And I think a congress like this can also help you finding the next achievable step for every child with diabetes. So thank you very much for your attention. It was a pleasure to see you, and I hope that there will some questions and comments. Bye-bye.
Yes, thank you, Dr. Michael, for so much wonderful, insightful discussion on sweet registry, how this works, how this collects data, and how this data is utilized for a better patient outcome. Because of the limitation of time, we are going over to our next speaker, and that is Dr. Karin de Beaufort. She is from Luxembourg. Can we have intro slide? She is completed her MD and PhD, and she is a pediatric diabetologist and endocrinologist, working for children and adolescents with chronic diseases. Her early research on diabetes technology in pediatric populations has laid the foundation for our enduring focus on this clinical practice. She is based on Luxembourg, has established leads multidisciplinary DCCP team, and recognized as a sweet center for reference in ERN Endo. She serves as a medical coordinator and has a research in different diabetes and technology, disease pathogenesis, and childhood non-communicable diseases. Currently, she is a part of the Lancet Commission on Type 1 Diabetes with a focus on education and expansion of registries. So for more discussion on Type 1 registry and how they are utilized for clinical practice, I am honored to invite Dr. Karin de Beaufort. Can we have start the session, RX events?
Dear colleagues and friends, I'm Karin de Beaufort. I am currently in Luxembourg and regret not to be with you, but will try to share my presentation as good as possible through this video. My topic this time is building better outcomes and what the role of T1D registries would be in modern diabetes care. Now, before moving on to this topic, I think it's very important to realize what are our outcomes. Do we talk about better or do we talk about best outcomes? What are the treatment modalities currently available? And where is the place in this all in a registry? And then some summary comments. So I think very important to consider that our outcomes in diabetes care, and pediatric diabetes care as much as in adult diabetes care, is that good metabolic control. Ideally below 6.5. I think we're already pretty happy when we've got a below 7. And we target as well when we're able to use continuous glucose monitoring to have values more than 70 or 80% below 180 milligrams. We want a normal physical, psychosocial development and good quality of life. And of course, all within the long-term purpose to prevent chronic complications, but just as much not at the price of acute complications. There are other outcomes in diabetes care currently described and targeted in 2030. But you have to carefully mention and document it. Because then you know what you're comparing and what you're comparing with. So then we've got different indicators, and I'm only mentioning two here with respect to the registry, or a relevant registry in diabetes. That would be then, for example, a process indicator, which is just listing, has there been a certain blood measurement, or has there been a blood pressure measurement? Because I can say, if I've measured one HbA1c in 500 patients and that one's brilliant, I could say, oh wow, outcome indicators are brilliant. But I should, of course, mention as well that I only measured it in that one patient who had that perfect control. So outcome indicators, process indicators, you have to carefully, for both of them, define the variable and the source. Then a very, very old example of a form of a registry was documentation of a Dr. Pirard, a Belgian guy who, after the Second World War, with insulin available, already started documenting in a registry, paper-based, because, come on, in the 40s and the 50s, what did you have? And no sensors, no HbA1c, you're in control, and glucose control. And he documented with these very basic indicators in his patient population in Belgium, Brussels, what he considered good, fair, and poor control. And then he linked that to the prevalence of complications. And what I think, even if afterwards everybody knows about DCCT, this guy published it already in 1977 and 1978, showing how good documentation, a registry, even if it's one center documenting it, can help you in telling you what makes a difference if you look at diabetes care. Then now going back to a very important point, it is the role of T1D registries. And after the very old one, which delivered a lot of important information, I would like to discuss shortly a very advanced global registry, which did not start as a global registry and which did not start as good and as professional as it's run today. Initially, it was just a program, European project with Thomas Danner in the lead, looking at cross-border harmonization of diabetes care, the SWEET project. After the completion of the project, it was turned into a registry and first limited to Europe. But already there, we started to collect relevant information, again, with careful definition of the indicators, variable, and the source. Not all indicators were available in all units from scratch onwards, so some would start with a limited number and progressively increase the number of data which could be shared, because it was not available. But currently, I think it's very clear, and I know that there are different centers as well in India. The purpose is this global longitudinal data collection to compare outcome. And I think that's where the key question of my presentation is answered. What we want is to compare outcome through benchmarking, not to judge each other, but to learn from each other. And we've had brilliant results in countries where there was 10 times nothing compared to less good or equal results in countries where people have access to everything, which means that you have to question what really makes the difference. And every time and again, after these benchmarking efforts, it's important to evaluate, see where you are, change if need be, and then again, re-evaluate the outcomes. The eternal plan, do, check, act, and so on and so forth, in order to really get the best possible care and know what's happening. I mean, if you would have this kind of process at a global level, it would probably become easier to see whether all people have access to insulin who are living in a certain geographical region and how they're able to get an acceptable metabolic control. So plan, do, check, and act. Now, quick, and I hope that you will get some more access to and insights in this sweet cloud data, the dashboard, which is, I think, which is done by the brain and heart and competence of Michael Witsch, one of my colleagues. But this is what you get. And whether you're based in South America, in Africa, sub-Saharan Africa, and India, in the Middle East, in Europe, wherever on the globe, it will allow you to have a look how your data, how you're doing. And for us in Luxembourg, huge country, you know, somewhere in Europe, I don't know how many times we would fit in one state in India, but still, for us it's very important to compare and to have access to what's happening in different countries in order to be exposed to different developments, see where we're doing well and where we're not doing well. Now here you've got all the, say, the very global picture when you're looking at the dashboard, and it's incredible. I can access it anytime, day and night, when I want, and I can check how we are doing with the data entered into the system, because you need data entry and you need to define your indicators. But then the number of visits way now approaching 2 million, the number of patients approaching 150,000, and mean HbA1c, which is documented. So really relevant information. But of course, you want to know as well what's happening with your own center, as I mentioned. Now let me position this one at a different place again. And here you see what's happening in Luxembourg over time, to 10. It finished with the project, to 11. We started with the registry, and here you see number of patients with a pump, still limited. It was mainly those very young age, the MDI with definitely more than 3 injections per day. And here it was less than 2, but that's quite surprising because after the Videre data, we very quickly went up with the number of injections. But again, I can think that we did a different job, but this is what the data show. And here from 2013 onwards, you really see that there is a change with no one left behind in getting multi-injection treatment, and as well more people involved in the diabetes care. Because starting in Luxembourg, even without a nurse educator, we now can't almost not imagine it anymore. Anyway, mean age, I get it directly, number of patients, the HbA1c, use of sensors, use of pumps, number of people, percentage with type 1 diabetes, and nowadays important as well, of course, understanding how type 2 diabetes, certainly in Europe, is evolving. So this is information I get. If I see that there is, for example, a change in outcome, be it hypoglycemia rate over time, DKA, very interesting. Have a look at 2022. I think everybody can imagine why we did see an increase in DKA at that period of time. But the evolution of this is so very important. I apologize for pushing too quick on the button, and I still have no time anymore. So this is, I think, very important. And here, the global view, if you see treatment approach, if you see the sensor use, it is highly important information because you can change things, you understand things, you can discuss things for the team, hospital administration, governments, but most important for people with diabetes. Thank you so much for your attention, and sorry for being 1 minute long.
Yes, thank you so much. It was a wonderful, insightful session on type 1D registries. So last two sessions, we have understood so much about the suite registry, type 1 registry, how they work, how they get this data, and how they are meaningful for our all over the world and Indian patients for particular type 1 diabetes. So we are now concluding this our type 1 symposium. It has been wonderful with 4 international speakers, and I think all the delegates must have got some good knowledge. So we are handing over this session now to Sachi. She can carry forward.
Thank you, sir. So yes, wonderful session. Now moving ahead to our debate session, the Dhanvantri dilemmas, the tradition, technology, or both. And to chair this session, I would like to invite the tech forward practitioner, our very own Dr. Rutul Goklani, sir, from the city of Ahmedabad. Dr. Rutul, sir.
Yeah, thank you.
Thank you, sir.
Do we have Dr.
And
Hasmukh here?
yes, and we have our dynamic, our strategic architect, our passionate Dr. Hasmukh Shah, sir, from the city of Ahmedabad. Welcome to the show, sir, and over to you for this debate session.
So, Rutul sir, before you start, I think Dr. Shambhu is requested for a couple of minutes. So, if we can utilize this time for a couple of question and answers, we are all people who we can discuss either precision medicine, use of GLPs, use of registries or pediatric diabetes or obesity. So maybe we take the next 2 to 3 minutes to discuss that, please.
Yeah, so it's a really pleasure to have to be here, and actually I was there whole day and could listen to a few of the lectures, and congratulations and kudos to you guys. And I want to say something that it's really difficult to be practical, but it's really easy to listen to all practical diabesity lectures, because it was really practical lectures, and we can implement this in our clinical practice. Another thing that I don't want to discuss anything related to obesity, as we have many lectures and we are going to discuss in all the discussions tomorrow and the day after tomorrow about obesity and so many things related to technology. But I would say that the most important thing that Dr. Karen Buford discussed, and it is about registries, especially registries related to type 1 diabetes, are very much relevant in India, because what we are seeing that still our patient living with type 1 diabetes, their longevity, their life is very short. I would say not average could be around 30 years. And this is quite shocking. And then I was the day before yesterday, I was going through one of the paper, and it is not published yet, but it was also saying the similar kind of thing, that many people are living with complications related to type 1 diabetes, and their life is very short. So if we do not have data, and we do not chase those data, do not follow those data, and we do not work upon those data, then we can't improve the things. So the things which are being followed and being observed keenly, those only can be improved. Otherwise, we can't improve them. And this is why our own registries are very important. Definitely, we all are part of suite registries. But what I have observed, that we don't get the chance to be part of it regularly, and as it is mainly a European societies mostly taking part, and it's we can't be involved in the way we want to be involved. So type 1 diabetes registries are very much important. Definitely obesity and type 1, or obesity in children registries should be separate, or they could be included in pediatric registries. So with this, anything my co-chair, Dr. Hasmukh Shah, wants to add? Sir, please go ahead.
So actually, I congratulate Dr. Dhruvi, Dr. Vipul. Really, it is nice initiative. And today, really, after post lunch, we are engaged, and it is really going very smooth. Otherwise, it is very difficult to organize live conference. In most of the online conference, we have recorded session, but we are going actually live. So I congratulate whole team, Nimmi, Dr. Rikin, and all of us. Okay, thank you. And I totally agree with the Rutul sir. So we need our power registry, and yeah, look, there are so many things are there, but it is not properly implemented. As we know, in India, we are full of so many laws and everything, but they are not implemented. So it's time to implement the things, and we do the awareness campaign. And at the pregnancy level, look, right now, as we come to know that the disease, we initially suddenly we come to know type of people are born with the type 1 child. Okay, so we know we should uh, make the awareness session for the pregnant woman as well as for the adolescent girl, and how to prevent type 1. So there is need to do, I think, these things also over and about the registry, and prevention is much more needed. And Dr. Rutul sir is also doing work on pregnancy and diabetes, hyperglycemia. So here there is time to work on these things, prevention measure in pregnant women.
Thank you. Thank you so much, Asmuk Bhai. Thank you so much, Rutul Bhai, for your words of appreciation. It's a team effort, and we all have worked hard for making this thing come to the reality. In last 1.5 months, we have worked hard. I also congratulate Dr. Sambhu for the win in West Bengal, and I would like to understand in a one sentence that what is about East Bengal.
What is about East Bengal?
Yeah.
East Bengal is one of the
Facebook.
that is a, we can say, landmark club in India. That is a very prolific, we can say, football club.
Okay.
East Bengal and Mohun Bagan. These two clubs are famous in India. So, and if you say there is a relationship with diabetes and East Bengal club, because we are actually promoting football in women, girls. So we want our future mothers to be healthy, so that we could fight in a greater way against the metabolic disease spectrum. And I also get influence from Ahmedabad, because you have Dr. Rutul there. He is training his daughter football, So that is really, football is something, and we are working hard now. Football is one of our key focus.
Son is also in football, and
oh, that's great. That's great.
He's going to Europe somewhere for training.
Yeah, thank you, Dr. Rutul. So again, technology is very important for executing what data or registry level work is missing in India. Because right now, when we are saying we are very diverse population, we have very poor connectivity between the cities, we have different level in education among even healthcare professionals. So if we can connect with the use of technology, it can be very easy to come at same level and to have proper registry, proper data, proper analysis, and from that analysis we can plan a new policy that can be India specific. So with that, let's start the debate. I would again give it over to chairpersons for introduction of our first speaker.
You're muted, Dr. Rutul. Yeah. So for this debate of Dhanvantri dilemma, tradition, technology, or both, our first speaker is from Kolkata, the most dynamic, Dr. Shambhu Samajdar. He's the closest friend all of us. And can we have the CV for him? And he will be talking on position, tradition, and root cause of healing, the forgotten foundation. So he is DM clinical pharmacology, gold medal, and PG diploma in endocrinology and diabetes from RCP UK. He's a fellow in respiratory and critical care, and diploma in allergy, asthma, and immunology. So many domains he has achieved gold medals. And he is consultant physician, diabetes and allergy, asthma therapeutic specialty clinic at Kolkata. He is faculty for JMN Medical College and Hospital, Nadia.
As a good friend of you, can I take the liberty to request you to start today's deliberation?
Yes, please go ahead, Dr. Sharma.
Thank you. So at the onset, I want to thank Dr. Vipul Chawda and also Dr. Dhruvi Hasnani for organizing this wonderful event. And this topic is really interesting and also helped me to relearn many things that I am going to share with you all. So let's start. So today I shall talk about something that when you talk about tradition and root cause healing in the background of technology, that is something the forgotten foundation. As the title of today's topic is the Dhanvantari dilemma, I want to start with one article that had been prepared by us. So yes, Dr. Hers will tell about technology, and I am not against technology, but I want to think beyond technology. So I want to start with this article that we had published with the help of Dr. Shashank Joshi, Dr. N.K. Singh, and our Honorable Minister, Dr. Jitendra Singh, in the CME India, where we try to focus few important aspects from Ayurveda, our ancient wisdom, and I just want to highlight few of those points to start with, like ajirno bhojanam bisham. So if previously taken food is not digested, taking more food is akin to consuming poison. Very importantly, very practical for all our doctor friends that had been late, even in the articles prepared by Dhanvantari, that na vaidya prahurayusha. That means no doctor can give longevity. And if you talk about stress, they had clearly mentioned how chinta vyadhi prakashaya. So in that way, we try to focus the time-tested principles of Ayurveda, which could offer a complementary approach to modern medicine. Now, another article we had published in Times of India, especially in the speaking tree section, with Dr. Shashank Joshi sir, that how Dhanvantari to internal medicine we can relate, especially if you talk about Dhanvantari's pot of nectar, the Amrit Kalas is not only a symbol of that immortality, it is reminder that the highest goal of medicine is not parameter correction alone. I am not targeting some HbA1c, fasting PP, but restoration of the whole person. Here, when we talk about whole person, that means body, mind, behavior, environment, and spirit. So, are we treating disease or only managing numbers? So, if you talk about modern medicine, it has transformed care. There is no doubt in that. In terms of diagnostic, imaging, intensive care, new drugs, interventional medicine, digital health, AI, and precision therapeutics. But still, we are facing a paradox. Despite we have such an unprecedented scientific progress, we are seeing increased prevalence of diabetes, obesity, hypertension, MSLD, anxiety, insomnia, burnout. We need to tackle polypharmacy, multimorbidity, starting from younger ages. We are seeing patients suffering from acute coronary syndrome, in the background of type 2 diabetes, in the background of COPD, in the age of 40 or 45. So from 45 years of age, he or she is consuming more than 7 or 8 drugs and sometimes 10 drugs. So we need to understand the deeper question. Are we only correcting such numbers like HbA1c, BP, etc., inflammatory markers or risk scores? Or are we also asking ourselves, our patients, such questions so that we can understand the answer of these questions, like why did the disease begin? Why is it progressing? Why is the patient relapsing? Why are medicines increasing but health not returning? So if you talk about today precision medicine, it can tell us the molecular signature of disease, but it often fails to ask why the soil become fertile for disease in the first place. So we need to understand the answer why the soil become fertile for disease. So the challenge before us is not whether we need technology. Of course, we need to use that. But the real challenge is whether our technology is helping us heal the patient as a whole or merely helping us managing certain numbers more efficiently. So what do we mean by tradition here? Traditional medicine. First of all, need to acknowledge tradition is not blind belief. Tradition is accumulated clinical wisdom. So by tradition, we are not going to establish that we can reject evidence, we can replace insulin with certain herbs, we can ignore myocardial infarction, sepsis, cancer, stroke, or renal failure, just romanticizing with past, promoting certain untested claims, and putting certain specific ideology above patient safety. But what we try to understand, try to mean that tradition is something larger healing framework. That framework, which remembers the patient, is not only a biochemical report, but a living person shaped by certain dietary discipline, physical activity, sleep rhythm, respiratory regulation, mind regulation, seasonal or daily routine, certain support from the family and community, ethical living, spiritual resilience. So patient-centered counseling, how we can respect for nature and environment. And of course, what is missing very much today, the trust between physician and patient. So why it matters? Why we are talking about tradition? Because when we talk about different chronic disease, do not arise from one abnormal number alone. They emerge from disturbed ecosystem consisting food, movement, sleep, stress, our environment, behavior, even the relationship, our meaning to life, and what are the other medications we are using. So tradition is not the opposite of science. Yes, tradition becomes dangerous only when it refuses testing. When we talk about science, that becomes incomplete when it refuses our wisdom. So if you talk about root cause, it's not one cause, it is the network behind disease that we all know. Yes, when we use technology, and especially technology first approach that may focus on these parameters we can see here, starting from HbA1c to digital twins to certain risk calculators. But when we try to focus on root cause approach, I think these are the important questions for which we need to search answers. Why insulin resistance in my patient? Why visceral adiposity is there? Why the patient is taking late dinner? Why sleep deprivation, etc., etc. Why patient is consuming ultra-processed food or tobacco? Why there is loneliness? So the take-home message should be, yes, we need to acknowledge that therapeutics can lower glucose. When we talk about root cause medicine, it asks why glucose dysregulation happened, why it persists, and why relapse occur after treatment withdrawal. So the forgotten foundation of healing, if we talk about, these are the 7 foundations before prescription escalation. Ahar, when we talk about ahar, it is not only the quantity of food, but also the quality, timing, cultural suitability. When we talk about vihar, that is the movement, daily routine, occupational habits, nidra, that means sleep duration, timing, sleep hygiene, manas, our stress, anxiety, emotional regulation, vyavahara, that means the relationship, behavior, social support. When we talk about parishar, that means our environment. We talk about endocrine disruptors, the pollution that matters, other toxins. And when we talk about finally the 7th part, that is the aushadha, and that should be used rationally, safely, and compassionately. So when we talk about medicine, should not begin with prescription and end with escalation. Medicine should begin with understanding and end with restoration. So, technology is powerful, obviously, but it is incomplete. Yes, technology can improve diagnosis, it personalizes therapy, it detects the risk early, it also helps monitoring patients remotely. Also, we are having now different technologies which can guide insulin titration. There are AI model now which can tell us, yes, this is NSTEMI, arrhythmia detection, retinal screening, genomics, drug discovery, etc. But technology cannot replace these all. Clinical wisdom, empathy, lifestyle transformation, spiritual resilience, trust, adherence to therapy, family participation, ethical judgment. So the physician's ability to sit, listen, and understand suffering, technology cannot replace that. So an AI can detect diabetic retinopathy, but it cannot yet sit with a frightened patient and transform the fear into disciplined hope. So if we talk about technology-only medicine, there are dangers. If we talk about precision, and sometimes precision becomes reductionism, patient becomes certain dashboard, disease becomes a biomarker, consultation becomes certain transaction, though debatable word, but I'm sorry to say that sometimes it happens also. The prescription become a substitute for behavior change. The healthcare system becomes reactive, expensive, and when we talk about polypharmacy, it increases without addressing the drivers of disease. We are adding one tablet, another, and that sometimes be a part of prescribing cascade. So human suffering is medicalized but not healed. So when we talk about precision without perspective can make us very accurate about fragments, but still blind to the whole person. We know the description of several blind person of one elephant, that story we all know. And that is why I think our root need to be understood. And for that, we have our Vedas. If you talk about Vedas, the Atharva Veda and Upanishad, especially from Atharva Veda, we got Ayurveda, and Upanishad actually is the starting point of yogic philosophy. And they had given enough description how we should behave, how we should treat the physical, mental, social, and spiritual health. And if you talk about the Atharva Veda, what is there in Atharva Veda? If you talk about Atharva Vedic lens, starts with protection, balance, resilience, harmony, disciplined living, ethical conduct, collective welfare. Everything is documented in there, in that Atharva Veda. And if you just have a classification of different chapters, there are chapters by which they guide us regarding the ethical governance and public welfare, how the leadership, how justice, equity, how sanitation, how access to healthcare, sustainable food systems, environmental protection, protection of vulnerable population, peace, cohesion, everything was important. So governance as a social determinant of health, that had been mentioned in Atharva Veda. If you talk about our environmental harmony, earth, water, air, plant, everything, how the infection risk can be minimized, food insecurity can be dealt, mental health burden, how that is linked with environment, everything was there. Very importantly, they had emphasized on mind-body regulation and the community health, along with stress on the woman health, health of the mothers, family health in a comprehensive manner. So that was there in Atharva Veda. And if we talk about, as we were mentioning, how Upanishad was linking with yoga, and when we talk about yoga, it is not just some movements of our body, it is about yoking first the mind. The idea of yoga here is control of our lower mind, much as in Yoga Sutras, and awakening of our higher intelligence. So, yes, we need to acknowledge tradition, whatever we were talking, that also must be accountable. So, if you talk about root cause healing, that must be evidence informed, because we cannot have an excuse for untested claims. So traditional practices must be studied with modern methods. Unsafe combinations with modern drugs must be avoided. There could be drug-herb interactions. So herbal products need also pharmacovigilance, quality control, and interaction monitoring. And if we talk about lifestyle intervention, mind-body intervention, that also should be protocolized. And there we need to give emphasis on clinical outcomes. What are the effect of these interventions on HbA1c, BP, weight, sleep, quality of life, hospitalization, etc. Let's see, let's dissect certain published evidence with our ancient wisdom. Yes, there were a very good amount of studies now ongoing after we have a dedicated Ayush department. These are a few excerpts from their treatment we can see here, starting from Chyawanprash to Arjuna powder plus Arakka Vardhini Vati, that had been shown to having an ameliorating effect on cholesterol value, especially the LDL and TG, inflammatory markers like CRP, even the blood glucose value. And when we talk about classical Ayurvedic treatment in rheumatoid arthritis, there was a randomized controlled trial where that classical Ayurvedic therapy, which was mentioned in Ayurveda, that had shown benefit when that had been combined with methotrexate. These are few excerpts of different herbs, different Ayurvedic products, starting from ginger to garlic to curcumin, and their effects on different parameters, and they had shown their benefit. So it is important to believe our ancient wisdom. And of course, we need to generate data like the researchers had done. And these all are very well-designed meta-analysis of or systematic review we can see here. And if you talk about yoga, and we know the pathophysiology in type 2 diabetes, how the metabolic inflammation and insulin resistance are contributing that cascade of disruption, metabolic disruption. But if we have yoga, the mechanistically it can have an effect on inflammatory system, insulin sensitivity, along with they decrease the cortisol value and catecholamines. So overall, the inflammation will be reduced and we will have a balanced metabolic health. This is one review which had shown the mechanistic benefit of different asanas, starting from Surya Namaskar to different other asanas, how they are helping in tackling the insulin resistance and inflammatory markers like interleukin-6, TNF-alpha, how their effect become decreased. And this is again another review where we understand the mechanism of yoga practice and how it could be helpful in prevention.
Dr. Shambhu, sorry to interrupt, but we are running short of time and it's a debate. So Harsh is also getting late.
So I will finish. So there are evidences already. Just I want to show those evidences, because when we talk about tradition, that must offer wisdom. But when we talk about science, that must offer verification. And our patient deserve both. And we had shown certain effects already. We show some evidence-based literature. So I think I can finish here with this Dhanvantari version 2, tradition guided, technology enabled healing. So it starts with technology for diagnosis, but tradition for discipline, pharmacology for rational treatment, lifestyle medicine for reversal or remission, AI for prediction, physician for interpretation, and there are the very important parts like clinical judgment to empathy to our wisdom, human wisdom, family for adherence, spirituality for resilience, and finally public health for prevention. So with that, I think we can say like that when we talk about healing tradition, technology or both. Technology is the new instrument, but tradition is the old compass. And when we talk about a compass without instrument, that is slow. But instrument without a compass, that is dangerous. So that is why when we talk about Dhanvantari, did not represent treatment alone. He represented restoration. The future of medicine must not merely be more precise. It must be more human, more preventive, more rational, rooted, and more whole. So thank you very much. I think I am very sorry for exceeding sometimes.
It was really an eye-opening lecture or for debate, because what usually we listen in our conferences is never related to that deep cultural thoughts which are embedded with our this modern medicine. So thank you very much, Dr. Shambhu, and I would request my co-chair to introduce our next speaker.
Now I invite Dr. Harsh Hirani. I request RS Event to upload the introduction slide. So Dr. Harsh Hirani is from Hyderabad, and he's clinical and research year fellow in diabetology under the Padma Shri Professor V. Mohan at Chennai. He's holding PG Diploma, Medical Law, Policy and Ethics from the NLU Gandhinagar as well as from USA. He is the winner of Torrent Young Scholar Award, Masterclass of Training 2021 in Diabetes and Therapeutics Technology from Johns Diabetes Center, USA. Gold level trainer in certification from the Time in Range Academy, USA. Associated as Global Trainer Faculty Certified International IDF, and as well as sub-editor, International Journal of Diabetes in Developed Country. Founder, Director, Dokyantra Private Limited, a state-of-the-art AI in healthcare solutions, which is incubated by the NASCOM. Author in chapter and peer review papers for diabetes complication, healthcare technology in leading textbook and journals such as ADA, IDTD, Diabetes Technology and Therapeutics. Now I welcome Dr. Harsh Hirani. Initially, I thought he's from Ahmedabad, but when I just now saw he's from Hyderabad. I welcome you.
Thank you. Thank you so much, Hasmukh sir. At the outset, I want to thank Dr. Vipul Chavda, Dr. Dhruvi, Dr. Rutul, and Dr. Rikin, an entire team here who has joined us and created this wonderful initiative. And firstly, I want to thank my partner, Dr. Shampu, to create such a wonderful session, such a wonderful perspective he has added. And as we all know, debate is all about looking at the hourglass from different perspectives. So I'm going to take you through a quick 10 to 12 minutes of perspective where the technology is slightly different, and there are a lot of roots of technology. Fortunately, it was such an exciting activity for me to build this session, because as Dr. Shambhu took us through the history, I also could go through some history of our tradition, and you'll be very happy and surprised to know that technology actually has been a forefront even in those times of origin of our healthcare sutras and everything. So I want to start my session by paying my humble regards and respects to Lord Dhanvantri, because this is the title, Dhanvantri Dilemma. As you can see on the right side, this is the Lord we have been worshipping for the health and well-being of all our patients. So there are no financial interest or any conflict of interest for this. Again, there is a use of AI in this presentation for research evidence synthesis. This is not a general AI, but these are all certified evidence grade AI tools which have been used to build this presentation. So let me start with the core aspect, diabetes itself. Let's understand what we cannot see. We undertreat. We don't fully treat. And we all are aware how the microvascular injuries trigger with uncontrolled diabetes over time. So I completely agree with Dr. Shambhu, where tradition shapes values, trust, and adherence. But then let's understand, precision is there to shape diagnosis, dosing, and prevention. Right. And India's diabetes burden, I just want to highlight two facts. So why precision is not optional, but a mandate right now in the current care of diabetes, because we are world's largest absolute burden as per the IDF at list of 2025. And the projection of diabetes rise is close to 75% rise over the past 25 years, which is what we're going to see till 2050 if we don't intervene. And all my slides, you must be able to see the references down below for your deeper reads of the concepts, what we're discussing. So because it's important to understand, only 36.3% patients globally achieve HbA1c target of less than 7. And if we look at the combined ABC control, which is something very much taught to us by a lot of our senior mentors, at A1C, blood pressure, and cholesterol control, collectively, if we see less than 7% of patients actually end up achieving this in India. I think there's a beautiful paper written by one of my mentors, Dr. Ranjit Unikrishnan, published in 2016, which clearly translates this. And there's a median delay of therapy intensification, which often exceeds by 1 year even after above target HbA1c. So 64% of treated patients with diabetes remain above the A1c target range. This precision gap is clinical crisis precision, and technology is designated to close this. So if you can see on the left side, that is Shushrut Samhita 600 BC ka actual physical, the scripts which used to be there. And actually, if you see, Shushrut Samhita has a section called Shushruta's Yantra. Yantra is a tool. It's an engineering for clinical precision. So if you look at Shushruta Samhita's Yantra concept, and it also talks very deeply on the pathology aspect of how a physician should instrumentalize approach when handling a disease, with 3 very important pillars in it. First is called Shalya, which is any pathological force causing the physiological suffering. Yantra is a precision instrument to isolate, control, and eradicate this Shalya. And Hasta is declared as Pradhanatama yantra, which is supreme embodying yukti, which is clinical intelligence. So clinical intelligence and yantra, the tool or technology or precision, actually goes hand in hand. And there are 101 plus yantras and 20 shastras which have actually cataloged. So let's understand. Shushruta Samhita talks about technology, but in its own way of tools and yantra, which are obviously now enhanced and modified in the way we see it. But it's just not a mere philosophy, but it's an ancient health engineering context, right? And this was beautifully, represented in G.D. Sengel's, approach of Shushruta's concept of yantra. Wonderful, script to read up. So let's look at unbroken yantra lineage of last 2,000 years, 3,000 years, from 6,000 BC to 2026 C, which is where we are right now. Now, every component, if you notice from a philosophical perspective, historic perspective, as well as mythological perspective, let's say a Nadi Vaidya, if you look at that whole science, I think Dr. Shambhu had beautifully shown was one chart. If you look at it from the interventional perspective, let's say it's a hollow tube for deep drug delivery. We have subcutaneous insulin cannula doing the same in an AID pump. So micro doses, insulin into subcutaneous cannula every 5 minutes. This is the reality where we are in. So precision is actually taking the lineage and legacy forward. So if you look at Hasta Pradhanatma Yantra, which is embodying Yukti, simple thing, model predictive control of algorithm. The artificial intelligence algorithms are just thinking like how Nadi science used to think, right? So it's creating its own algorithm. It externalizes clinical intelligence, making a tireless error-free outcome, right? Because numbers, we may goof up as humans, but machines don't. And if you look at Nadi Pariksha, radial waveform, so which is a more ancient form of radial waveform diagnosis, the CGM waveform and AI pattern recognition actually do this in front of our eyes. So we actually now have visual perception of these technology, taking forward the legacy of our traditional concepts forward and actually enhancing the care. And this is precision medicine. This is precision care, what we are able to do now with the advent of technology. So technology, precision, it's the same. The river is the same. The instrument has become just more precise, more reliable, more relevant. And most importantly, if you look at the choosing of closed loop in 2026, it actually is a absolute fulfillment of all the 4 pillars of Shushruta's mandate of a yantra or a technology or a tool, which is a precision tool. So the same instinct that built Shushruta's yantra concept now builds a closed loop algorithm, if you see. So Shalya, if you look at it as diabetes, microscopic complications, or pathological force, yantra, the instrument which is helping address this, and the thesis, which is the collective amalgamation of the CGM, AID, digital therapeutics integrated as a singular precision technology powered system. So let's look at CGM. I think I won't cover this more in detail because many of these CGM sessions have already covered or they will be covering these pointers, but I'll just highlight 1 or 2 important points here. The time in range gain of 3.6 extra hours per day. Imagine, friends, giving 3 to 4 hours of 24 hours of extra hypoglycemia-free, hyperglycemia-free control in the right time in range actually has so much of benefits, right? 10% of 24 hours is what? 2.4 hours, right? Imagine, we have got papers which show that 10% improvement in time in range can prevent so many complications of diabetes, nephropathy, diabetes, retinopathy, microvascular complications. But imagine, friends, here we are talking beyond 10% of 24 hours, 3.6 hours. You can actually imagine the kind of benefits tech is bringing in the overall outcome and the care. So if you look at certain other aspects also, we've got data from type 1 diabetes meta-analysis, right? Clearly, it has shown a better HbA1c improvement, time in range significantly improving with technology and precision medicine incorporation. If you even look at type 2 diabetes evidence, it's not far. It's actually significantly superior reductions in HbA1c we have been seeing. And even if you look at Indian real world data, there was a wonderful study from Fitterfly Diabetes CGM Digital Therapeutics Program, which was published quite recently, just 3 years back. Again, an interesting article to read. It was published in JMI Diabetes. Time in range is improved. There's a good weight loss, and there's the best part is there is scalability in tier 2, tier 3 cities. Apart from HbA1c, overall care has enhanced completely. So if you look at HbA1c versus time in range, there's no comparison here, but I'm just putting a perspective. CGM is a diagnostic mirror for a disease that hides between the appointments. I'll repeat this again. CGM is a diagnostic mirror. This technology, this precision therapeutics, where CGM data backs our decision making, our clinical thinking, is a diagnostic mirror for the disease which hides between appointment of January and appointment of April. That's the power of tech, friends. And CGM sensor filament is just like a Shalaka Yantra reborn, signaling the Shalaya, which is the disease glycemic variability, before the physician's hasta could even feel it. And before physician's clinical thinking steps into the picture, it's giving data to enhance that clinical thinking process. So it's so data is no longer just an non-emotional, non-human touch aspect, but it's actually enhancing the human touch in the collective care. And let's look at the AID perspective. It's no different. Like ADA 2026, if you see the standards, actually remove prior treatment prerequisites for eligible adults on. And so AID has now moved from specialist niche to a broader standard of care consideration, which itself is the beginning of a broader acceptance of this. And if you look at NAGM 2022 publication of islet bionic pancreas, which is like one of the first attempts for an artificial pancreas, the improvements and the results are mind-blowing. If you look at AI adapt or CAM APS FX study, again in type 1 diabetes in pregnancy, not a regular type 1 case, which is one of the highest risk RCT, significant time in range gain has been observed by this integration of technology. So I think these are all pointers to further amplify the fact that we are headed into a beautiful future, and technology in precision undoubtedly remains the first point of transformative approach in the collective care of diabetes. And if you look at the HbA1c change, the TIR outcomes, security 2D, which was done on Omnipod 5 with type 2 diabetes individuals. So insulin pump in type 1, we always know, but in type 2, this has been done. Absolute amazing improvement in time in range. And you imagine there's a 29% reduction in requirement of insulin, which is again very surprising and interesting at the same time, because a better, more precise control, lesser over basalization is possible, right? With the right tech integration. Now, again, here control IQ with tandem, if you see this particular pump study, again, insulin requirements are reduced. There's a better time in range even with reduced insulin requirement. Interesting, right? Again, in AI adapt study, I'll not repeat it, but this is the maternal and fetal benefit which could be translated across type 1 diabetes in pregnancy population. And if you look at real world AID performance across every demographic, just leave, you may be biased to say that this was covered just on, type 1 diabetes or type 2 diabetes, or just type 1 diabetes in pregnancy. So let's look at adult, pediatric, geriatric, all the populations where AID is used. And when auto mode is used, there is significant improvement in the outcomes. I think there's a voice coming over.
That's nice.
I think there's a voice over. Yeah, perfect. All right, thank you. So that's how impact the technology is able to make. So I think AID is the perfect yantra, something which in fact Shushruta or even Lord Dhanvantri would appreciate, because it's a complete fulfillment of what an ideal yantra should be. Like precision, we have micro interventions for day foresight, because algorithms forecast 30 minutes ahead now, right, of any glycemic excursion. And Yukti, which is the component of clinical judgment, which is externalized into a continuously automated learning system. So you're not just treating, you're enhancing the care multifold. Now comes a very important leg of precision therapeutics, right? Because precision technology, we covered 2 or 3 different perspectives, but now let me guide you through the phenotypic approach of therapy framework, which is one of the very important component of precision care, right? And let's look at type 2 CKD scenario. We have put data of SGLT2 inhibitors, with a mechanism of net reverses and tubuloglomerular feedback, and clearly we have seen prevention of so many bad outcomes, right? eGFR decline is prevented, ESKD is prevented, heart failure hospitalization is prevented. Same way we have GLP, we have got GLP with GIP combinations. Each of them have shown very unique, very precise benefits in precise clinical scenarios, right? So, a weight loss, a glycemic benefit, CV mortality, we are all aware about this. Let me tell you, friends, this is part of phenotypic guided precision therapy, and flow trial doesn't stay behind, where clearly in NEGM we have seen GLP-1 receptors in type 2 DM and CKD, 24% of relative risk reduction in preventing dialysis and CV death in CKD cases, which is very, very significant. So this is the last section of my talk, which is of AI and telemedicine perspective. Again, the fourth pillar of the whole precision technology aspect. It's beyond the clinic. Now, we are very much aware about the retinopathy and the nephropathy and cardiology benefits of integration of AI and the risk prediction, or not just risk prediction, but even identifying of patterns of retinopathy and guiding on the forward preventive care. But then similarly, we have seen machine learning models where CKD progression have been projected as early as 3 or 4 years before the actual pathological changes begin. And even wearable ECG with AI integration has prevented so many silent cardiac autonomic neuropathy worsening, and non-invasively they have been starting to get detected. These are very important papers what I've quoted here. All of them cover on these 3 pillars, and some very important aspects have been addressed on the precision technology addressal, especially in the complications prevention space. So let's answer the traditionalist claims, right? Like credibility is built by conceding honesty and pivoting sharply. So tradition is fulfilled, absolutely not opposed with the precision and technology preference, over just the mere traditional outdated approach. Ancients used the probe to find what sight could not. Today, our probe is the CGM in diabetes. Because this is a diabetes conference, I'm staying restricted to diabetes, reading hidden physiology between the visits. Tradition gave us the language of healing instruments. Technology gave us better instruments. Ethics demand that we use them optimally and efficiently. So the claim that lifestyle and traditional wisdom are enough are actually not enough. Let's understand evidence-based responses. A lifestyle is definitely foundational. Traditional wisdom guides on discipline and self-management. Let's face it, friends, realistically, the diabetes injury is hidden and episodic, and CGM improves self-management accuracy when combined with structured education. And it actually, not just CGM, but even the AID or AI integration and everything we see, it's actually more justifiable to see whether the interventions are actually working or not. Right? The algorithms depersonalize the medicine, and actually precision medicine uses more individual data, phenotyping, risk, comorbidities, not less. The contrast is not human versus algorithm, but it's going hand in hand and together. It's a protocol versus individualized but evidence-based approach. Technology is elitist, impractical outside tertiary centers where not really. The costs are coming down, and there are strategy approaches. The technology access mandate, government is very strongly adopting now as we speak. Building of Indian data sets, subsidizing Indian devices, Indian manufactured initiatives of a lot of technology is upcoming. Yes, it is slow, it is going to time, but we are not far where we will have a lot of things more accessible, more approachable in the near future. Coaching in Indian language is already happening. There are tools which are educating doctors in multiple languages, in the multiple ways. The knowledge transmission is happening in a way which was not done in last 75, 80 or probably 200 years, right? And this is how the Amrit Kalash fulfills the civilizational promise of a care which is just beyond technology, precision, or traditional mindset. Precision is the clinical standard now. Under treatment, targeted tools and hidden injury all get addressed. Visibility, absolutely, with more data, protection with prevention of hypoglycemia, prevention of nocturnal changes, phenotype-based approach, so that you're treating the right problem with the right intervention, and the scalability with the advent of AI. All these factors are pointing towards an optimum, brighter future. So I'll just add one last slide, just to rather compile both of our talks in a different way. So if you look at traditional principle, let's say yoga and pranayama, CGM biofeedback can actually help us understand whether patient is actually benefiting how well with the pranayama in real time. Right? Fenugreek, or the so-called herbal supplements which exist in traditional care, can actually be verified by phytotherapy response outcomes. Right? Machine learning waveform analysis can actually translate to Nadi Pariksha outcomes in specific, if anything exists, because Prakriti gets decoded, and ancient diagnostic precision actually meets machine learning. And this kind of clubbing would be very interesting to explore how it goes. And Ahara Niyama, which is again the lifestyle adherence, can again CGM and AI-backed nutrition coaching can actually transform truly individualized food guidance for based on Indian diets. So let me end this again by paying my humble regards to Lord Dhanvantri. Tradition shapes trust, meaning, and adherence, honored and clinically valued. But let's understand, friends, technology shapes what is measured, dosed, and prevented, which is directed by nothing but data, by RCTs and consensus guidelines. And tradition, technology, or both is not the right question. The answer is both, with evidence as the guiding hierarchy. So with this, I'll leave this room with a line to remember. A healer who refuses precision and technology is not being traditional, he's just being late. And we should not be late in the quality of care delivery to our patients. So compassionate precision, a brief summary: visible glucose, automated protection, phenotype matched treatment, expert care that travels, Precision is the new healing. Technology and therapeutics are the best yantra of our age, modern age of 2026. And again, tradition shapes values, evidence must guide the treatment, and precision must deliver both. Hence the motion supported. Thank you so much for your patient listening. And I again thank the organizers for giving me this opportunity to project a different perspective on this debate. Thank you so much. Signing off.
Thank you, Dr. Harsh Hirani, for giving just such insightful information on tradition and technology. And you have included so many things. As a diabetologist, as a physiologist also. So many things, components are covered regarding the biofeedback, Nadi Shodhana, CGM. So we are thankful to you. Now over to the organizer.
Thank you so much, Harsh. So much, Dr. Sambhu, for wonderful. It was not a debate, I guess. It was a complementary thing that we are not competing with each other, but we are complementing each other. So let's go ahead with a patient-centric precision and powerfully backed by technology-led medicine for all our patients. Thank you so much, both of you. Thank you so much, Hasmukh Bhai, for being there throughout the session. Thank you so much, Dr. Rutul. Dr. Rikin is there. He's from since 2 o'clock. He's there in front of camera. Thank you so much, Dr. Rikin. And over to Dr. Rikin and Dr. Dhruvi for vote of thanks to end the day. Thank you.
Yes, thank you, Bulbhai. Thank you all the faculties and thank you all the delegates for this today's presence. Today, all the sessions has been wonderful. All the national, international speakers, all the topics were so much insightful that I think from all over the India, delegates who are not able to attend physically even, they can learn, they can educate, and they can transform these practices, transform this knowledge into their clinical practice throughout the India and also from delegates out of the India. Thanks again, all the delegates, faculties, and Vipul Bhai and Dhruvi, who are the main persons for behind this whole scientific academia. And I will hand over to Dr. Dhruvi for further comments.
Dr. Nimmi is also there throughout the session. Thank you, Dr. Nimmi.
So, thank you is a very small word for all our friends, faculties, delegates, our team members, the organizing committee. Very overwhelmed to see such a fabulous response. This was a wonderful session. Thank you, Dr. Shambhu. Thank you, Dr. Hirani. It was amazingly put, and that was the idea when Dr. Hirani had told me that this will be kind of complementary thing and less of a debate. So I was like, that's what we want to emphasize on, the technology and tradition go hand in hand, and maybe our tradition was more technologically advanced than what we are currently. So I just want to say a very heartfelt, deep gratitude to everyone for supporting us on a very first day of Practical Diabesity 2026. I look forward to meeting you all in person tomorrow morning, 10 a.m. For all of you who have been a part of our sessions from outside of Ahmedabad, from outside of Gujarat, and from outside of India, I am literally very touched by the passion that you have shown to be a part of our program. It is all of ours together. It is not mine, it is not yours, it's of all of ours together, and that's how we stand united. Together, let's do good work and good practice, good medicine for good outcomes. Thank you so much, everybody. With that, I think I'll request the RX team to stop the recording for today, and I'll see you all tomorrow morning. See you all tomorrow morning, 10 a.m. Yes, we start at 10 a.m. So let's meet at 9:30. Yes. Let's have tea together. Sure, Long Island Ice Cream. It's still recording.
So I think welcome all the delegates and faculties. Please come tomorrow. Please join us from 10 a.m. tomorrow. All the sessions are going to be superb. All the speakers, they are thoroughly prepared for all the national and international speakers. So if you want to gain knowledge and if immediately you want to apply in practice, all the delegates, please join us for the 2 complete days. Saturday and Sunday. Saturday start from the 10 a.m. and Sunday start from the 9 a.m. Pause your OPDs for one day and get this knowledge and apply in OPD. You can postpone your patients to the next week, but this knowledge you cannot postpone.
Thank you so much.
So true. We have excellent panel discussions planned. We have excellent debates planned, and we look forward to seeing all of you tomorrow.
Thank you. So RX team, can I request you, Jignesh Bhai, to please stop the recording, please?